Hello, everyone, and good morning for those of you in the United States and in the Americas. Good afternoon for those of you who are in Europe, and good evening for those of you who are in Asia. I'm Dr. William Zoghbi. I'm the Chief of Cardiology here at Houston Methodist, and it's a pleasure to welcome you to our 11th annual Multimodality Cardiovascular Imaging for the Clinician Conference. It is amazing that it has been already 11 years that we've put this conference. And for those of you who are obviously interested and in the field of imaging, this field has evolved so much. So this conference is most importantly to get an update of where we are in this field, all the advances that we have come through, not only from a technology point of view, but also from an implication to patient management. We have an amazing array of topics and experts in the field. So we want to welcome you to this. Yes, it's virtual this year. Hopefully next year will be a combination, a hybrid, since we've done that hybrid for many, many years actually before. But there's an advantage also to a virtual conference, is to be able to reach so many of you throughout the world, as you will see how many people have really joined from different parts of the world. First, I want to acknowledge certainly our co-directors that you know most of them, Dr. Al-Mallah, Dr. Little, Dr. Mamarian, Quinones, and Dr. Shah. I think you will meet them in addition to many other experts in the field of imaging. And hopefully we want this to be an interactive conference. As you will see, there are ways for you to interact with us. Send your questions to Paul Ev or texting, and you'll get all these messages as we go along. We have 8 sessions, and I will go through these sessions for you. Remember, this is Central Time here, so you can adjust in the United States. We have more than 400 learners that will be logging in and have registered for this conference. I want to also emphasize to you that this material will be available to you for the following 2 months. So please register for you to be able to see that. We have more than 26 faculty also involved. And this is an amazing interaction with the world, really, for sharing knowledge in cardiovascular imaging in 40 countries, more than 400 people. And I want to highlight the first one here on this, which is Antarctica. I can't believe that somebody in Antarctica will be watching, and I think this is amazing. Probably using ultrasound, I don't know, advanced imaging, but I think welcome to this person from Antarctica. You can follow us on social media. Many of you do. We have more than 67,000 subscribers to our YouTube channel. And you can see the Twitter handles for DeBakey CV Education, as well as my Twitter handle, if you want to interact down the line regarding really any topic that you would like. So this is multimodality imaging, and we want to talk about the state of the art of the images. And as you will see from the first session, it will be mostly about the advances in technology. Imaging has been really now crucial in cardiovascular imaging, health, and delivery. I feel that it is a core laboratory for any clinician who wants to tackle cardiovascular disease. It is complex, and I think that's part of the reason for us to do this, is to where do we use appropriately the various imaging modalities that we have. It is no longer certainly echo and nuclear from the old days, and I think it's important to navigate this field from a technical point of view and from an imaging point of view and implications for patients. Also, we have to be mindful on cost effectiveness and the use of such modalities, because it is important. We are stewards of the healthcare system, and we want to make sure that we use these appropriately and don't layer many imaging on top of each other. Well, if you were here physically, this is the Texas Medical Center. I think Houston Methodist is in the middle there, but the Texas Medical Center is among the largest actually in the world, of conglomerate of institutions. And we would love to welcome you at some point in time when the pandemic hopefully gradually dies down. This is our Houston Methodist and Walter Tower. Actually, I'm broadcasting from here, from the middle of this picture. And we'd love to host you and show you around and interact with you as much as possible. Also, again, if we come back to be live, you will be in the MITE, which is the Houston Methodist Institute for Technology and Innovation Education, an amazing facility for learning. more than 40,000 square feet just dedicated for learning. And we could use also, hearts to correlate imaging with the anatomy of the heart. We have a 70 Tesla MRI scanner for advanced imaging, and certainly digital Siemens digital PT scan. This is our group, and I think you will meet many of them. I want to highlight Janet Champagne, who is the director of our imaging laboratories, which houses all the imaging laboratories, and you know many of the people in the picture. Let's talk a bit about our program. This is day one today, Saturday. We will start with a session on advances in technologies and what should we know, what should we incorporate in practice. A session 2 on ischemic heart disease. Then we have lunch, and a lunch break would be actually an open forum. And I would like to invite you to participate in this. Any question really goes. So we'll have fellows, and we'll have senior and junior attendings to relate with you and answer any questions that you may have. In the afternoon, role of imaging in heart failure. And then last but not least, very important, Dr. Tajik and myself will go through and moderate case studies in various diseases. Tomorrow, Sunday, we'll start at 8 o'clock Central. 2 sessions on valvular heart disease and structural heart disease that you really don't want to miss. And in the afternoon, a shortened period till 3 o'clock in the afternoon, read with the experts. And it will be very interactive, sequential, echo, CT, MRI, as well as nuclear. And on Monday, half a day in the morning about congenital heart disease, diseases of the aorta, peripheral disease, and a surgical perspective to that. And I think we would love for you to come and join us. These educational sessions really would not be possible without support from our collaborators and granting agencies and industry, Abbott, Boston Scientific, Edwards, Gubert, Lantheus, Medtronic, and Siemens. Thank you for your grant support, and for exhibitors, Siemens, Bracco, Jubilant, Lantheus, GE, and HeartFlow. Thank you very much for your contributions. And last but not least, certainly our collaborating and cooperating professional societies, ASNEC, ASE, the ACC, as well as Society for Cardiovascular and Magnetic Resonance. Thank you again for collaborating for these educational activities. And with that, I think I would like to welcome our first co-moderator. I will co-moderate the first session with Dr. Lang, who really does not need an introduction. Roberto, good morning to you.
Good morning. Very happy to be here.
It's great to be with you, and I think you are part of our yearly annual conference on multimodality imaging. Dr. Lang is, as you know, professor of medicine and cardiology at the University of Chicago, truly a leader in echocardiography and 3D echocardiography, particularly past president of the American Society of Echocardiography, and it's a pleasure to co-moderate this with you, Roberto. And we will talk about technology in this first session, you and I think we have an amazing cadre of speakers, and I think talking about the amazing cadres, you're the first one, Roberto. And we'll talk about 3D echocardiography, the latest advances and applications.
Well, good morning, everybody. It's a pleasure, like every year, to share with you a little bit about the latest advances in application of 3D echocardiography. We have truly advanced and continue to advance in the acquisition of three-dimensional echocardiography. And that is the reason why we are now using 3D echo in almost every procedure that is done in the interventional lab. And I would even say that there are certain of these interventions that cannot be performed without the use of three-dimensional echocardiography. We have seen more and more the use of fusion imaging, also called fluoroscopic anatomy, a situation in which we use 3D echo fused with fluoroscopy. And if you look at the image on the top left, you can see a patient with a perivalvular leak, and you can see exactly on the fluoroscopic space where this leak occurs. And we can then use a catheter or guide the positioning of a catheter. You can see how well these images are fused because the catheter is completely overimposed with the image of this catheter. This is, of course, some work in which we have expanded on the use of fusion imaging, in which you perform fusion of three-dimensional echo, in which we have painted on the surface in a parametric display the three-dimensional strain and overimposed it with the anatomy of obtained from CT of the different coronaries. Every year we are outstanded by the amount of changes that occur with analysis of three-dimensional echocardiography. And we have seen more and more the use of automated intelligence, and in which, computers are trained to try and identify the surfaces by training a computer to obtain, a model of three-dimensional echo. And this has occurred and now provides you with automated information dynamically of the cardiac cycle of the left ventricle and the left atrium. And you can see very nicely the curves of left ventricular and left atrial function. And you can see that this is now already almost prepared to work in all the chambers. Because the pyramid of data is not enough to occupy all of the cavities, there is now a separate program that does the analysis automatically of the three-dimensional volumes. And this will soon also perform an analysis of the right atrium at the same time. This, of course, is with minimal interaction. We have seen also through the American Society of Echo, the WASE study, which is the World Alliances of Societies of Echocardiography, in which we have now performed multiple studies trying to obtain in a large group of patients from around the world the normal values for three-dimensional cavities. And there are now studies that describe the left atrium, the right atrium, the left ventricle, and so on, and they will all be eventually compiled in a document. And I think for the first time, we have now really reliable, well-acquired values of 3D echo. And this is just a figure of a left atrial volume. And you can see how nicely when you average 200 or 300 patients in each age group, how you can see that the contribution of atrial contraction towards LV filling increases with age, in keeping with a reduction of the compliance of the left ventricle. Another area where 3D echo is advancing is in the shape analysis of the left ventricle. These are three images obtained 1 year apart of a patient with mitral regurgitation, and then after this patient underwent surgery. And you can see how the shape of the ventricle changes from a football or a soccer ball to an American football over time. So I think the development of all these types of new shape indices that are based on LV contour are very important. And you can see these are some that we have developed that looked at the conicity and sphericity. But more important is the fact that when you have a 3D echo, you have this dynamic wireframe from which it is possible to calculate the regional curvature. And from these regional curvatures, curvature, of course, is the amount by which a geometric object deviates from being flat. And you can see that when you do that, you can sort of put the shape analysis. This is event patient that underwent a myocardial infarction. You can see that, and you can see that as the ventricle dilates, you can see that the curvature of the apex and of the base of the heart changes. This is an article that was published in the Journal of the American College of Cardiology, in which we show for the first time that shape analysis is as significant as many of these typical parameters to look at what happens with mortality. And you can see that essentially the apical, the septal, there are different walls in which changes in curvature as you remodel have a major impact. The same is now happening on the right ventricle, and you can see this is a patient with an LVAD in which we are looking at the changes in a ramp test of how the revolutions per minute and the impact that it has on the cavity size. You can see how as the ventricle unloads, it becomes a bullet shape, and all you can see the simultaneous changes on the right ventricle, hoping that these changes will help us understand what is the best speed of an LVAD. And you can see also as you look at the right ventricle in patients that have severe PH or patients that have severe pulmonary arterial hypertension, that the shape of these ventricles are very different. I'd like to spend now a couple of times to show you that there are unbelievable changes that are occurring now on transducer, on the transducer, and that has a major impact in the quality of a 3D study. Look at an old transducer and a new transducer. Look at the quality, how we can see the posterior wall. And if you look at the cavity at the endocardial border with an old transducer, these of course are images derived from this 3D echo, and compare them with a new transducer, you can see how nicely you can see, and in these transducers, the new 3D transducers, you can actually, even at the same frame rate, you can see the endocardial border much better. And look at what happens when you obtain with a new transducer a multi-slice. This is the same with an old and new transducer. Look at the endocardial border. This looks virtually like an MRI, and I think this will open the opportunity of using these transducers to do exercise testing or 3D echo testing. You can look at how much more clarity we can see a catheter within crossing the tricuspid valve. Now with the new rendering techniques of transillumination, you can see how nicely you can see different types of structures with these new transducers. These, of course, are images obtained transthoracically, are all different views of an aortic valve, then obtained from a transthoracic point of view. These are beautiful images of a non-coapting tricuspid valve, also obtained with a new transducer. And look at this, is a patient with mitral stenosis. These are transthoracic images. And you can see how nicely you can see the orifice, the fusion of both commissures. And again, let me remind you that these are all transthoracic transducers. And for the first time, a study that we are now preparing, we can obtain 3 transthoracic 3D images of the pulmonic valve, which I think make a huge difference. Look at this patient that has a prolapse. This, of course, is the TEE image of the flail. You can see this very nicely on the P2. And this is the transthoracic image. It's very similar to the TE. So there are huge advantages in the quality of 3D echo. And this leads us to the end of my talk, in which, for many, many years, we thought that maybe there will be a time in which the quality is good enough that we can, from a full volume 3D echo, slice it and obtain multiple 2D slices. And you can see this from the parasternal point of view, from the apical point of view. And now we are saying that from 3D full volumes, you can obtain 17 2D echoes or slices of a 2D echo. And this is exactly what we have done. These are all obtained from an RV-focused 3D data set. And we have actually compared from these images the quality compared to a regular 2D echo, and also the ability to obtain measurements compared to a 2D echo, and thinking that this could probably change the manner in which we are actually going to be doing a 2D echo study in the future. Because I'm saying that with 3 full volumes, you can obtain all the 2D echoes that could be separated by automated intelligence and measured completely then automatically. And these are just examples in which we compare images obtained from a 2D transducer and from the 3D transducer in situations in which images are about the same. And in 80 or something % of the images, when you look at this very carefully, the endocardial visualization is exactly the same. We have seen over the last 2 years a lot of changes in the manner in which we display 3D images. And I think one of the biggest advantages has been the incorporation of transillumination. You can see here in the same image with transillumination how more clearly we can see the rupture of both codes, and also lately also the addition of changing the quality of the transparency of the adjacent tissues. And the tissue itself remains transparent, and the image is now highlights the borders. And look at this atrial appendage, and this is now with transparency. Look how nicely we can see the borders, the pectinate muscles, and we can see also the circumflex. And this is just to show you in a patient that has undergone a clip, how much we have advanced. This is a regular 3D echo. This is now when we start putting transillumination, and when we start also changing the transparency of the adjacent tissues. You can see nicely the orifices here, how clearly these are visualized on both sides. And also we can start seeing the clip that we were not able to see before. With the added advantage, of course, that we can add color Doppler to it. And I think this becomes extremely useful. This you can see here that the color originates all throughout the line of closure of the valve. This is looking at the valve from the left ventricle looking up. So the addition of real good 3D color Doppler on these images provides you a lot of information regarding the location or the origin of these jets. That same patient underwent 2 clips, and you can see that at the end of this procedure, we still have a mild jet of mitral regurgitation, and we can see that from the left atrial approach, where it originates, and also where it originates if you're looking at from the left ventricular approach. And again, just to leave you with this left atrial appendage, just to show you the clarity of the pectinate muscles and also the circumflex coronary artery. So we are actually changing and moving, and we see with these new transducers that a lot of reproducibility is being improved. We have improved temporal and spatial resolution. We'll be able to do things automatically and hopefully at decreased costs. And we have seen major changes this year in the assessment of shape, image fusion, and transducer technology. And with this, I'm happy to answer any questions later, and I would like to thank you very much for your attention.
Thank you, Roberto, for really an amazing presentation. And actually, the slide before last is a great reflection of where we were and where we are now. It really is amazing, the technology that you could see nowadays with 3D. I just want to remind also our audience to go to Pollev, POLLEV.com, enter DeBakey, and this way you could send your questions. You can also text it if you want to. Text to DeBakey, DEBAKEY, to 37607, and also text your message so Dr. Lang and us can answer some of these questions in addition to our other speakers. All right, I think next, Roberto, I'm gonna go ahead and do the next presentation regarding contrast. You're on live, I can see you.
Yeah, absolutely. I mean, of course, you don't need any introduction, and who can be better than you to talk to us about this contrast echocardiography and tips and how can improve our use.
Hello, everyone, and thank you for joining us again today. And my topic will be contrast echocardiography, a powerful tool in diagnosis and management. I know most of us are very familiar with agitated saline to look at shunting, intracardiac shunting, or intrapulmonary shunting, if you will. And that's a great example here of a patent foramen ovale. However, as many of you hopefully also do, is use the other generation contrast echo that pass through the pulmonary circulation for better diagnosis of the left-sided structures, particularly ventricular function and exclusion of thrombi and other things in the left ventricle. So in the United States, Optison, Definity, and Lumason are approved for such use. And also from a quality point of view, I'm glad to report that the number of patients that are increasingly used contrast echo is increasing appropriately, which is very important to improve diagnosis, and that can guide therapy, as we will be talking about. So the power of contrast can be certainly illustrated here, and I do hope that you have also the experience with that, is in this non-diagnostic study, if you use contrast with either of these agents, you can convert a completely uninterpretable study into something that can be certainly interpreted. And if you guess that ventricular function was bad in this individual, certainly it is not. And at times you'll be very surprised as to what your guess would be after you use contrast and enlighten what you see. For your references, these are the guidelines, and I think the most updated one is first author Dr. Tom Porter, looking at the clinical application of ultrasonic enhancing agents or contrast. I think this is the new terminology, but they can be used really interchangeably for such. Now, the clinical applications of contrast echo, what is approved by the FDA is certainly improvement of regional and global function. But inherently also it delineates LV hypertrophy. Certainly you rescue uninterpretable studies, improve stress echocardiography, although it's not specifically released for that or approved for that indication. Doppler signals enhancement, particularly of aortic stenosis, if you will, because on the right side we could use still saline contrast for enhancement of these jets. And definition of structural abnormalities if there is a question of thrombus or pseudoaneurysm, and we'll show you some of these cases. Now, this is the appropriate use criteria. These have not changed. Routine use of contrast is not appropriate. Certainly, whenever you are not able to see the left ventricle and its segments, 2 or more segments, it is certainly appropriate, and that's the indication. Now, in intensive care unit patients, obviously the incidence of technically difficult studies increases. And you could see this is from our earlier experience and investigations. You use fundamental on top, then you use harmonic, you improve it a little bit, harmonic on contrast compared to transesophageal echocardiography. And these were the data by Dr. Yongki Young many years ago, showing that if you use contrast with harmonic imaging, your diagnostic capabilities of ventricular function to evaluate regional and global functions are almost similar to transesophageal echocardiography in the unit. The other study I want to share with you, time has flown by, it's almost 11, 12 years earlier, looking at the impact of the diagnosis and management of patients that are in the hospital or in the outpatient setting. A sizable number of individuals were were evaluated. By definition, they had a very difficult difficult transthoracic study to start with. So in red is the technically difficult study on the left. And on the right side, after contrast, the vast majority were much more adequate for evaluation of regional as well as global function. Still some in the surgical intensive care unit, almost 20% were still difficult to interpret, but the uninterpretable ones is almost non-existent. Now, what is the impact? The need for additional procedures in these patients. The impact is the vast majority is in intensive care units, be it surgical or medical, and no procedure change only in the minority actually, but in others, TE avoided, or nuclear imaging for assessment of ventricular function certainly was impacted in a positive way. The least impact is in the outpatient setting, where by definition, their quality of images would be much more appropriate than the hospitalized patients. Also, use of contrast will exclude and may uncover the presence of thrombi, and this is from that same series by Dr. Kurt and us. Suspected thrombus 35, and after contrast only 1. Definite thrombus only 3 at beginning, but certainly diagnosis of 8 afterwards in this cohort. So let's review some cases with together here, and you can make your assessment whether this is a thrombus or is this a reverberation artifact. If you can make that judgment for yourself, this is after use of contrast. Actually, there was no thrombi in this individual. A bit of a surprise, but this is real. How about this patient? Thrombus versus trabeculations. And this is what you see on the right side. Indeed, a thrombus, a layered thrombus in the apex, nicely delineated with contrast. How about this patient here? Thrombus or reverberation? Not well seen, actually. It's quite an impressive, actually, thrombus in the ventricle. So quite a few surprises, actually. And I think we have to take the guess out of this, particularly when you're not seeing very well. So the total effect on patient management, quite substantial, particularly, again, in the inpatient setting, surgical and medical intensive care units. These are the procedures that were avoided in red. Medication change, particularly inotropic agents or anticoagulants, and also importantly, there was appropriate saving per patient, about $120 in the United States. And also, we looked at whether the increasing the number of non-visualized segments had an impact on your overall management. And as you would expect, obviously, the higher the number of segments that you could not see before contrast and after use of contrast, your impact is certainly much more impressive. Take a look at this individual. You know ventricular function is down, although the images are not, the most pristine. But with the use of contrast, in addition to delineation of all the segments, you could see another surprise, an apical thrombus that is seen, which would change certainly the management in these patients. Another interesting individual here that I was involved in quite a few years ago. And at first glance, it looks like the ventricle is rather normal, but you use contrast in somebody who had a very abnormal electrocardiogram, and you could see this unusual location of the abnormality, and this turns out to be a true aneurysm as opposed to a pseudoaneurysm. A few other cases here for you, technically difficult, somebody coming in with chest pain, and then a very abnormal electrocardiogram. I guess the differential is an akinesis, and with ischemia versus a apical hypertrophic cardiomyopathy. And that's what you see, actually, a very nice ace of spade and an apical hypertrophic cardiomyopathy. How about this individual? Notice that the epicardium doesn't move as well in this patient, and you wonder what's going on in the apex per se. Again, akinesis versus maybe significant hypertrophy, and indeed a very impressive apical hypertrophy. And you could see the intramyocardial arterioles actually enhanced by contrast itself. So quite an impressive, actually, example. And this is the last example I have for you. A very large aneurysm, actually, in the apex, a nice function of the base itself. Use contrast, no thrombi there. And are you satisfied with this? Actually, you could be satisfied and say that's what it is. But interestingly enough, in this individual, if you go just for the contrast case, you will be missing the diagnosis, because early on in the contrast, once you start seeing contrast coming into the right ventricle, you see something crossing into the left ventricle nicely there with actually a ventricular septal defect that could have been missed if you just waited for contrast to be enhanced on the left side. So in conclusion, contrast or echo-enhancing agents improves endocardial border definition in suboptimal individuals, enhances the interpretation of regional and global ventricular function, rescues uninterpretable studies, and improves the quality, better diagnostic accuracy, enhanced management and avoidance of more costly or invasive procedures, certainly is cost effective and adds value in patients with suboptimal echo studies. And I do hope in your institution you're using it appropriately where it's needed to enhance your diagnostic capabilities and quality of overall studies and patient management. Thank you again for your attention.
All right, next I think we're going to go to address advanced imaging in CT, cardiac CT, and I think our next speaker does really not need any introduction, Dr. Jonathon Leipsic, really one of the world leaders in cardiac CT. Dr. Leipsic is the chair of radiology in Vancouver at the University of British Columbia, and he is also professor of radiology as well as cardiology and past president of the SCCT. Jonathon will be talking about cardiac CT angiography, the latest technological advances. I think with many of them have happened, and it's really amazing to see the major changes in CT, in resolution as well as radiation.
Jonathon Leipsic from Vancouver, charged with the task in 13 minutes or less to talk about the future of cardiac CT. I'm going to focus on coronary disease because obviously we could have a whole additional talk on advanced analytics of structural heart disease. But I'm really grateful for the opportunity to share some of my thoughts. I do have some disclosures. I have received grant support from GE Healthcare and provide advice to HeartFlow. Most of my other disclosures are not salient to this discussion. Now, I wanted to focus to start, when we talk about the future, I think the future of cardiac CT as it relates to coronary disease is really bright, and it starts with the updated ACC-AHA chest pain guidance, which gave a class 1 level of evidence A support for CT, both in the stable and the acute setting, because CT informs diagnosis, prognosis, and helps guide downstream decision-making. This really creates a meaningful opportunity, not only for all of the advanced analytics that I'll highlight in a moment, but just fundamentally for broader use for the patients across the United States and inevitably globally. The reason I think that they really leaned in with the CT for strategy is because they've highlighted that through CT, you have an actionable pathway that provides a diagnosis not only of coronary disease, the extent and severity of plaque, which we'll touch upon, but also anatomical disease, and then allows you with a single test to marry non-invasive physiology to inform the need for revascularization. On the other hand, if you start with a non-invasive stress test, whether you have a mild or moderately or severely abnormal stress test, it ends very much with guideline-directed medical therapy, importantly, without knowledge as to whether the patient has atherosclerosis or, for that matter, to the status of the left main. So I think the future of CT is bright because it has broad and strong guideline support. Importantly, I think image quality and diagnostic yield will also continue to improve. If you go back 15 years ago, you can see cardiac CT at 64 slice generation was really exciting for the field of clinical cardiology. We've had 4 centimeters of coverage, good spatial resolution, but we know the field has moved drastically and has progressed meaningfully in the last 16 years. First and foremost, the test has become safer and safer, as we saw from Protection 6, as 80% reduction in dose from cardiac CT as compared to a decade earlier. We've also seen recently, just at the RSNA, the introduction of the first photon counting scanners, creating a meaningful opportunity for true spectral imaging to move CT beyond where it's currently at and really create an opportunity for tissue characterization, plaque characterization, and further improvements in spatial resolution. These scanners are no longer just futuristic, but are now being used in clinical practice at a number of sites. And you can see the opportunities with regards to the improvements in spatial resolution that potentially will afford us the opportunity to image plaque with greater characterization, as well as evaluate for in-stent restenosis. The other part of the future that I wanted to talk about was really how CT is going to continue to advance our understanding of atherosclerosis and risk. We know that CT doesn't only provide us an anatomical measure of stenosis, but allows us to evaluate the presence or absence of atherosclerosis with reasonable, at least small data sets would suggest reasonable correlation with intravascular ultrasound. Of course, this is done non-invasively. We have the recent guidelines, actually the slide says in press in 2019, but was actually published in 2020, highlighting that even in clinical practice routinely across America and the globe, CT can be used to identify anatomical stenosis, the number of segments of plaque, the morphology of the plaque, and provide at least a crude measure of semi-quantitative evaluation of the total plaque burden. Why would we want to do this? Of course, we know that the risk to the patient comes not only with the stenosis, but also with the quantity of the plaque, as well as the morphology of the plaque. This is work over 12 years old from Jagat Narula and Sadako Motoyama, highlighting that positive remodeling in low-density plaque appears to connote risk beyond stenosis alone, identifiable uniquely, non-invasively by CT. Building on that, we participated in a registry called ICONIC. The ICONIC registry was nested within the actual CONFIRM registry. 240 patients with myocardial infarction matched to patients who did not experience myocardial infarction. But you'll note we matched them for sex, site, cardiovascular risk, and genotypicality, but also for quantitative core lab atherosclerotic burden on CT, which is highly important to reflect on. In doing that, what we identified was that the culprit lesions at baseline CT, which the CT was performed often years in advance of the infarction, the patients often didn't have high-grade lesions, and commonly the culprit was non-stenotic. Importantly, the culprits, again, often had a higher burden of non-calcified plaque, low-density plaque, and positive remodeling, identifying an opportunity to explore plaque morphology to better understand and refine our appreciation of risk to the patient. But I would pause here and highlight to you that all of this opportunity around plaque morphology is really in the context of normalization for overall plaque burden. As you could see, both in the ICONIC registry, we matched based on the CT extent of plaque, and more recently, a presentation given by Harmony Reynolds just at AHA, coming from the ischemia trial, highlights that the total plaque volume appears to be the strongest predictor of incident risk. So having a tool that allows us to non-invasively quantify plaque is going to be fundamental for us to understand not only treatment response, but patient-specific risk. Beyond that, I think CT is also teaching us a lot about the importance of plaque progression. That baseline plaque volume is important, plaque morphology is interesting, but it's patients that progress that are at risk of incident myocardial infarction. To explore that, what we've seen over the years is that there are many studies that have highlighted that on baseline imaging, the culprit lesions on subsequent infarction were non-stenotic. Of course, the story from these studies is not that non-stenotic lesions are more sinister than stenotic ones, but rather that non-obstructive lesions should not be ignored. That if left for plaque progression, there's a risk of incident myocardial infarction. And that is what we see from this elegant figure put together by Amir Mahdi, that at the time of the infarction, the culprits are severe and bulky and ugly and large. And so something is happening from baseline imaging to incident myocardial infarction. That something is plaque progression, as we saw from Sadako Motoyama in her 2015 JACC paper, that high-risk plaque features are important, but high-risk plaque features with plaque progression really denotes the patient at risk. Building on that, the paradigm data set, thousands of patients, about 1,400 patients that were followed, in fact, 1,760, that had CT and then had CT at least 2.5 years after, were evaluated using quantitative plaque measures to understand patient-specific risk and patterns of plaque progression. From these data sets, we learned that we can understand treatment response based on serial CT, at least in a core lab, understanding that statin-taking patients have less plaque progression and more progression of calcified plaque than non-calcified plaque. So I think the future of cardiac CT will really allow us to explore patient-specific risk, understand baseline coronary plaque burden, and then track treatment response. But for that to happen, I think these tools will have to be not just core lab required and manual, but rather AI and machine learning supplemented and really facilitated so that we can get reproducible and accurate and accessible measures of total plaque burden. Finally, I think the future will hold a routine planning of coronary intervention with CTA. And I say that because I would posit to you that you wouldn't do a TAVR at Methodist or anywhere without doing a non-invasive evaluation of the annulus. And yet far too often, patients go to the cath lab without any planning for coronary intervention. Why would we not plan a coronary intervention as we do a TAVR? Why would we send a patient based on clinical symptoms and non-invasive stress testing to the cath lab without evidence or without confirmation of the presence or even knowledge of the presence or absence of anatomical disease? I think those days are done, and I think the future will build a time when we don't go to the cath lab and only to find no coronary disease or sinister coronary disease, but actually go to the cath lab with a plan. Why do we need this? I think because far too many patients are going to the lab that don't need to, and far too many leave the lab incompletely revascularized. As we saw from Greg Stone at the ACC, 40 to 60% of patients in the ischemia trial were incompletely revascularized. And we know that incompletely revascularized patients have a hazard for incident myocardial infarction. So we need to do better. I think we can start by providing fluoroscopic angles in a fashion similar to what we do with TAVR. We can do the same for coronary CT, providing fluoroscopic angles to optimally visualize the left main bifurcation, and so on, routinely just from the resting coronary CT. We can help provide fluoroscopic angles that will prevent foreshortening of lesions, as in this case. An angle provided by CT highlights that this lesion is 1 centimeter longer than would have been predicted using a routine fluoroscopic working angle from the cath lab. I also think CT can help us avoid unnecessary surprises. Why would you not go to the cath lab with knowledge of left main stenosis rather than relying on a stress test only to find severe coronary left main disease at the time of the invasive angiogram? We also know that CT can help us with CTO planning, but beyond CTO planning, I think it can help us identify lesions where lesion preparation for lithotripsy or rotablation may be needed, and actually go to the cath lab aware that you're going to be encountering a heavily calcified lesion and have the tools ready to intervene as needed. Finally, I think understanding physiology before intervention will be fundamentally important. We know that CT is a good gatekeeper to the cath lab, but generally when you have complex disease, the non-invasive anatomical syntax exaggerates the disease burden compared to the invasive gold standard. But as we learned from Carlos Collette and Professor Soroy's, that when we integrate physiology and we provide a non-invasive functional syntax, the agreement with the invasive gold standard is actually very, very good, thereby providing an anatomical and physiological roadmap in advance of the procedure. To highlight the opportunities, here is a critical LAD lesion. This patient may not even need a physiology for the LAD, but had a moderate to severe right coronary lesion. Instead of telling the interventionalist, good luck, go figure it out, wire the right, you can actually go to the cath lab with a planned LAD intervention and deferral of the right coronary artery. And you can do that safely, planning that intervention in advance of the procedure. In addition, we can help understand the phenotypes of physiology, appreciating that certain phenotypes of physiology lend themselves to PCI and other phenotypes of physiology do not. Pressure loss with a diffuse pressure loss does not lend itself to PCI. A focal phenotype of physiology where there's severe translesional pressure loss actually lends itself very well to PCI to improve the symptoms, reduce the incident myocardial infarction rate. What if we could understand that in advance of the cath? And I think we can, using non-invasive physiology, helping map out not only the presence or absence of abnormal physiology in the LAD, but the phenotype of that physiology to help inform invasive angiography. And finally, I think in the future, we're going to start looking at additional measures, things like myocardium at risk. So to understand the amount of myocardium subtended by any individual stenosis, using advanced computational modeling to understand the likelihood and benefit of revascularization. In addition, I think that there are opportunities that have been explored recently in a trial called P3 to help us understand the feasibility of improving physiology with revascularization using a so-called interactive planner. This planner allows the proceduralist to idealize the lumen and essentially recalculate the computational fluid dynamics to understand whether the pressure recovery will be meaningful with PCI. To explore this again, the P3 trial was performed by Carlos Collet and the group from Aalst, Belgium, Neuron-Sonk, and their data is quite interesting and very provocative. What it shows us is that the agreement between the virtual post-PCI FFRCT, the virtual planned intervention, and the recalculation of the physiology agreed quite well with the measured post-PCI FFR, with a mean difference of 0.02 and a standard deviation of 0.07. So the future may allow us to not only identify abnormal physiology computationally in advance from CT, but then to virtually stent the lesion, recalculate the physiology, and predict the likelihood of pressure recovery and meaningful impact on physiology from PCI. As you can see here, severely abnormal physiology calculated and measured, and then significant improvement of physiology with PCI calculated and measured. An opportunity to go to the cath lab again, planning your intervention, not only identifying patients that need to go to the lab, informing decisions around PCI, but also informing the likelihood of significant physiology improvement with PCI as well. So I will close there. There's much more that we could talk about as it relates to shear stress, as it relates to additional plaque characterization, and then obviously the whole world of structural heart disease. But I'm honored to have shared my thoughts, particularly as it relates to the future of coronary CT in the coming years. Thank you again for your attention.
Thank you, Jonathon, for a great presentation.
Thank you. It is a great distinct pleasure to introduce Dr. Salerno, who is a professor of medicine and radiology at Stanford University, where he recently moved from the University of Virginia. Dr. Salerno, those who follow him, you know that he has had a major role in the development and evaluation of multiple novel MRI pulse sequences and techniques that have improved the clinical utility of cardiac MRI. Dr. Salerno?
Hi, thank you very much for giving me an opportunity to talk about basic concepts and new developments for CMR. Here are my disclosures. Most importantly, I'm going to discuss some works in progress which are not clinically available. So for this talk, I want you to understand some basic components of a CMR exam, to understand the limitations of some of the traditional techniques, and understand how new developments can improve the efficiency and diagnostic utility of CMR. So I'm going to go over the basic techniques here, including what we do for single shot scouting, myocardial function, tissue characterization, perfusion, and delayed enhancement. So here is a pretty typical protocol where we have scouts and anatomy imaging using single shot imaging that takes about 5 minutes. We then typically perform cine imaging of cardiac function. Then we perform T1 mapping, which typically we do in a base, mid, short axis, and a 4-chamber. If there's an acute process, we might do T2 mapping, resting perfusion, additional imaging during this washout delay. In some cases with a normal function on a 2 and 4-chamber, we'll actually do the function imaging after we give contrast. Late gadolinium enhancement imaging about 10 minutes after contrast. And finally, post-contrast T1 mapping. So I just want to talk about a couple of concepts. When we talk about single shot imaging, what that means is we collect all the lines of the data in each heartbeat. So in each heartbeat, we're getting a new image of the heart. And this is really used for our anatomic imaging, either bright blood imaging using a technique called steady state reprocession, or dark blood imaging using a technique called haste. When we perform our cine images, we use a technique called segmented imaging. And so when we use segmented imaging, one cine series is obtained typically over a, say, 6 to 15-second breath hold. It utilizes cardiac gating in order to synchronize the imaging across multiple heartbeats. And the limitations are that it's sensitive to inadequate breath holding and arrhythmias. So here's what happens if a person falls asleep during the cardiac MRI. We get a lot of motion-related artifacts and ghosting, which happens on late gadolinium enhancement imaging. So again, to kind of explain the idea between single-shot imaging, in a heartbeat, we acquire all the image data, and we're able to get an image. Advantages are that it's less sensitive to motion because it's all acquired in one heartbeat, and it has a relatively short acquisition for the data. The disadvantages are that it has lower spatial resolution and a larger temporal footprint, and typically lower signal-to-noise ratio. So the trick around this is called segmented imaging. So in segmented imaging, in the first heartbeat, we acquire some of the data. We acquire some of the data in another heartbeat until we've acquired all the lines of data that we need to make our image. And then that will give us a higher resolution image with a higher temporal resolution. Again, with the limitations that I mentioned, this is now acquired over a breath hold. It's sensitive to motion, and it needs EKG gated. So what about the segmented cine imaging that I was mentioning? The idea here is that we're taking segmented images at different phases of the cardiac cycle. And so each frame is essentially a separate segmented image. And over multiple heartbeats, we're able to make multiple different images at different phases of the cardiac cycle. Again, what are some of the disadvantages of this technique? If a patient breathes, we can have a lot of artifact. There are other techniques called real-time imaging. In this case, the patient had both difficulty holding their breath because these large bilateral pleural effusions, as well as some arrhythmia. So we're giving up temporal and spatial resolution to do this. What about tissue characterization? The three main concepts are T1 mapping, T2 mapping, and ECV mapping. The concept behind T1 mapping is that if we know the shape of the T1 recovery curves, here a scar post-contrast has a short T1, whereas the myocardium will have a longer T1 post-contrast. If we acquire images at multiple different points along this curve, and we know the shape of the curve, we can make a map where each pixel in the image corresponds to the exponential time constant of this longitudinal recovery, and that's T1 mapping. The technique that's typically used to do it is a technique called MALI, where we do an inversion pulse and then acquire a few single-shot images. We allow signal to recover, and then we do the same thing on a second acquisition. And then we fit the intensity at each different point to this model, and we're able to get the T1 value at each pixel location. And so on a T1 map, things that have a short T1 will be dark, and things that have a long T1 will be brighter. If we invert the T1 map, which is called an R1 map, we'll see this looks a lot like a late gadolinium enhancement image, where the shorter T1s are going to have bright signal, and the myocardium is going to have a lower signal. So what factors affect native T1? So if you have myocardial edema, if you have an infarction or other fibrosis or amyloid, those are going to increase T1. Things that decrease T1, lipids in Fabry's disease, hemochromatosis with iron overload, and when we intentionally give contrast. So the other concept is the extracellular volume fraction. And the idea here is that we want to know what's going on in each little pixel in the image. And so if we blow that up, we can see that there's both cells as well as extracellular space and the plasma space. And the gadolinium is an extracellular contrast agent, so it can only go in the plasma space in this interstitial space. So what we're looking at with an ECV is the ratio of the space in the extracellular space where gadolinium is able to go over the total space of that voxel. So it's expressed as a fraction of the voxel. So changes in any of these elements within each voxel can result in a change in the ECV. So how do we practically do ECV mapping? If we take our post-contrast and pre-contrast gadolinium maps, and we do 1 over the T1, which gives us an R1 map, and then we take the difference between those, that's a delta R1, which is basically the numerator of this equation. We then divide it by the delta R1 of the blood pool, which is the denominator of the equation, and we multiply by 1 minus the hematocrit to deal with the fact that the gadolinium is only in the plasma space and not in the red cell space. And that gives us an ECV map. What factors affect ECV? Fibrosis that's diffuse, fibrosis that's focal, myocarditis like edema, and infiltration. And then on the other side, if we have primarily cellular hypertrophy without much expansion of the extracellular space, such as in athlete's heart, you can actually have a decrease in ECV. And pointing out that in the cases where you have a high ECV and a high native T1, that's helpful for detecting amyloidosis. If you have a low native T1, that's useful for looking at Fabry's disease or iron overload. What about looking at edema? So in the normal myocardium, there's a ATP pump maintaining the sodium-potassium balance. When you have ischemia, you lose the ATPase, resulting in initially intracellular edema, and then later into extracellular edema. And this early intracellular edema, people argue that T2 mapping is a little bit more sensitive, whereas once you have spilled into the interstitial space, you'll pick this up with T1 as well as ECV mapping. How about the concept of T2 mapping? In T2 mapping, the idea is if we acquire images at different points along the T2 decay curve, and we know the exponential model, we can fit the T2 value, which is the exponential decay constant for these curves. So here we see blood has a long T2, whereas myocardium has a shorter T2. What technique is mostly used is called T2 prep SSFP T2 mapping. The idea here is first we do an image with no prep that gets us a point up here. Then we do a acquisition with a 30 millisecond prep that gets us a second point on these curves, and then finally do a 60 millisecond. And then we fit to this equation here, and we solve for the T2. So T2 mapping has been used to look at both acute MI as well as myocarditis. So I want to talk about two more topics here, the time course of gadolinium contrast. So when we inject a gadolinium contrast, the T1 weighted signal intensity goes up in the normal myocardium, and then it washes out. In an area of an infarct, it will have a slow wash in and then a slow wash out. And under adenosine stress, an area that's ischemic but viable will have a reduction in the slope of this upslope and a reduction of the peak amplitude, as shown here in a case of adenosine stress perfusion defect in the inferior wall. So how do we do this? We do a T1 preparation. So normal areas will be bright and hypoperfused areas will be dark. And in each heartbeat, we're acquiring single shot images at multiple different slice locations. And that's why the signal to noise and image quality for perfusion is challenging. So here's an example, stress images on the top, rest images on the bottom, showing a perfusion defect in the anterior wall. If we look to the later part of the time curve, we'll see that infarcted myocardium had a slower wash in, but it also has a slower wash out. Whereas areas that have normal myocardium are going to have a more quick washout of the contrast. Areas that have microvascular obstruction are going to have a really slow influx of contrast. And typically at around the time when we do delayed enhancement imaging, the areas of microvascular obstruction will appear black, scar will appear white, and normal myocardium will appear dark. So what's the mechanism for this? In normal myocardium, there's not much space for gadolinium to accumulate. In an acute infarct where there's cell rupture, there's a large space for the gadolinium, a large volume of distribution. And finally, in the setting of scar, there's a large area of extracellular space for the gadolinium. A couple of other points here. The technique that we use for late enhancement is called inversion recovery. And these images tend to be taken as a magnitude image, which means that following the inversion pulse, we can't tell the difference between a signal that's negative or a signal that's positive. So when we see the magnitude, these things here are going to appear is that they're going to be bright in the image. So as an example, if we go just past the null point of normal myocardium, we'll see that the myocardium is dark, scar is going to be bright, and the cavity is going to be bright. If we go to a point where we're just right a little bit shorter than the null part of the myocardium, you can see this sort of patchy kind of appearance, and you have to be careful not to mistake this for diffuse fibrosis. Just showing a couple of other points on the curve. If we intentionally chose to be where the blood pool is going through its null, you'll see that will be black. And if we went very early and went where the scar was going through its null, you'd see that that is going to be black. So in reality, we want to be just to the side of the signal being positive. The other concept is phase-sensitive delayed enhancement. And what that does is that instead of getting a magnitude image where something that is near -1 or +1 will both be bright, in phase-sensitive, it's set up so that the magnetization that's negative magnetization of the longest T1s will be dark and the shortest will be bright. So here's an example, again, where the box was chosen, the inversion time was chosen to null the blood pool. And by using phase-sensitive detection, we're able to restore the polarity of the image. So the last part of this talk, I want to quickly go through a couple of ideas of advanced techniques. These include rapid cine imaging, rapid LGE imaging, and advanced techniques for parametric mapping and perfusion. So here is an example of a standard breath hold data set taken over 8 heartbeats. We can do real-time imaging where we acquire the data over only 1 heartbeat, but that tends to have lower image quality. Newer techniques called compressed sensing cardiac cine allow us to get higher quality images acquired over a single heartbeat. Another technique is a deep learning cine, and in this technique, we can significantly reduce the time for the acquisition. A typical acquisition takes the time that it takes to get the whole heart, which is typically about 10 minutes. And here in about a 25-second breath hold, they can get high quality cine images across the whole heart using either an e-spirit technique or a deep learning technique, which has a very fast reconstruction. Another concept which is being applied more recently is where we acquire the images during free breathing. We measure the EKG, and what we do is we acquire real-time images, and then we bin the data and do registration so that we're able to get a higher quality image. In these particular cases, the imaging is typically acquired over 90 seconds to cover the whole heart. And here are examples here, real-time cine with motion correction. In about 90 seconds, we're able to get 14 slices. When you compare that to the product breath held sequence, it would take about 375 seconds. So a significant reduction in the amount of time to do this kind of imaging. Unfortunately, my movie's not playing here. Another approach is free breathing single shot late gadolinium enhancement imaging. In this case, there's a single heartbeat image, which has a lower image quality. If we do motion correction of these different heartbeats, we can do motion averaging, and then we're able to make a very high resolution image. And these are acquired during free breathing, again, over about a 3-minute acquisition. Another concept is to use deep learning for denoising. Here is an example of a single shot image. And this image looks noisy because we're acquiring the image in a single shot. If we use a deep learning approach, we can improve we can denoise this data and more nicely be able to see the infarct. In terms of parametric mapping, a direction that a lot of things are going right now is instead of just trying to acquire T1 maps, of trying to acquire T1 and T2 maps simultaneously. And these can be done typically in free breathing approaches as well. The last topic I want to hit is quantification of myocardial perfusion, which there's a growing interest in. And the concept here is that we acquire the perfusion images, And then we can perform quantification similar to what's done in PET. Here, very nicely seeing a perfusion defect in the lateral wall. And this has been well validated in a number of studies. So in summary, standard segmented cine images are being replaced by rapid single shot and free breathing approaches. Similarly for lake gadolinium enhancement. In the future, T1 and T2 mapping will be likely to be replaced by multi-parametric mapping, where we're able to get T1 and T2 simultaneously. And finally, quantitative perfusion will likely become clinically available in the near future. Thank you very much for your attention.
Thank you, Michael, for a great overview of the latest in cardiac MRI. Quite a few advances also in this technology. It really is amazing. Our next speaker is Dr. David Wolinsky. Dr. Wolinsky is the Director of Nuclear Imaging at Cleveland Clinic, Florida. He's past president of the American Society of Nuclear Cardiology. Really a pleasure to have him with us today and give us what is the latest in nuclear cardiology.
Good morning. I'm David Wolinsky from the Cleveland Clinic. I'm thrilled to be invited again by Dr. Zoghbi and Dr. Al-Mallah to participate in this program again this year. I'm sure all of you in attending will be getting a lot out of this meeting over the next 3 days. My topic is discussion of nuclear cardiology in 2022. These are my disclosures. This is the outline of what we're going to cover in the next 15 minutes. We're going to look at the redefining the role of non-invasive imaging through the viewpoint of myocardial perfusion imaging in nuclear cardiology. We're going to talk about the role of MPI after the ischemia trial. We're going to talk about the impact of AUC on myocardial perfusion imaging, and we're going to discuss a little bit about where myocardial perfusion imaging fits now that the chest pain guidelines have been published. So the concept of why test is relatively simple. We want to prevent sudden death. We want to prevent a heart attack. Unfortunately, it becomes a little bit more complicated because there is a difference between defining risk with a test and proving a test has value. This is me, and if all of you are golfers, you know this is the Swilcan Bridge on the 18th hole of St. Andrews. I don't need a test to determine whether it's safe to jump off that onto the 18th fairway. By the same token, if I'm going to jump off the Golden Gate Bridge, I don't need a test to help me define the risk. So to do tests for the sake of testing is often going to set us in the wrong direction. So American Society of Nuclear Cardiology has tried to reverse the imaging pendulum and try and create more value in whatever tests we do. We've defined an initiative called Patient First, in which we think about what information the patient needs, what tests we ought to do, and what tests should be done to most help the patient. And if it's not helpful to the patient, then it's not worth doing. And taking us out of these silos of, I'm just an echocardiographer, I just believe in CT. There's no one test that works well for everybody in every scenario. I think it's a difference between the science of nuclear cardiology and the science of cardiology, for which there is a vast body of information, and the art of nuclear cardiology, which helps us go back to decide really what's in the patient's best interest. The traditional perspective looked at demonstrating prognostic efficacy. If you could show that a test predicts risk, it's a valid test to do. And it has to be able to predict risk better than the information that you had prior to that. That is, the post-test probability is more well-defined than the pre-test probability. The current perspective is different. We need to define therapeutic efficacy. That is, do the treatments that we choose based on the results of testing lead to improved outcomes? And is it done in a cost-effective manner? And that means we have to really go back and understand what we're looking for and go back and understand how we use tests properly. So I'd like to review now some major observational studies in nuclear cardiology and compare those results to some of the randomized control study and see why the data is a little bit different in each set. So that's a very classic graph from Roy Akamovich when he was at Cedars-Sinai. It looked at the amount of ischemic myocardium and the risk based on the treatment that was shown. This slide looks at 5,300 patients. Similar slides exist for over 11,000 patients, but it defines the fact that once you hit 10% ischemic myocardium, 10% myocardium in jeopardy, the outcomes are better with revascularization than they are with medical therapy, whereas less than 10%, we don't see a benefit. The Courage paper was published in 2007, and I'm going to talk about the whole study a little bit later, but I want to talk about the portion of the study right now that looks at ischemic guided therapy. And the question we asked is, does reducing ischemia reduce risk? So this was a pre-specified sub-study, outcomes of 105 patients with moderate to severe baseline ischemia, and they returned for a second study. And you can look here at the reduction of ischemia. And in those patients who had greater than 5% reduction of ischemia from the first study to the second study, their outcome or their risk was the risk was 1/2 of those people who did not have ischemia reduced. So it really didn't matter how the ischemia was reduced. As long as you reduced the ischemia, the risk was reduced. In fact, PCI did reduce ischemic burden more than optimal medical therapy alone. Let's go back now and look at Akamovich's data and see whether any other observational data has shown similar results. And keep your eyes on the shape of these curves. This is a study from the J-axis study, which similarly looked at those that are high-risk scans versus low-risk scans. Here, patients with greater than 10% ischemic myocardium were followed up to about 6 or 7 years. And you can see the risk associated with lack of early revascularization versus early revascularization in patients who had significant amounts of ischemia. If you look not at ischemia, but hibernating or jeopardized myocardium, you can see a similar curve that at around 10%, hibernating myocardium, those people with more than 10% did better with early revascularization as opposed to those who underwent medical therapy. If we get a little more contemporary and we look at PET, we can see similar data. Here, seeing now that the cutoff is not 10%, but 5% and greater than 5% ischemia with early revascularization did better than those who did not receive early revascularization. 5% is now more sensitive than 10% because of the improved diagnostic accuracy of PET imaging. We can also not only look at perfusion, but we can look at global blood flow reserve. And this paper, again by Patel, looks at the cutoff that we normally use, around 1.8 or 1.9 for global myocardial flow reserve. Those patients who had flow reserve reduced less than 1.9, who underwent early revascularization, had half the risk of those people who did not undergo early revascularization, again suggesting that ischemic guideline therapy works. This is a more contemporary paper from Cedars-Sinai, and it looked at modern solid-state cameras with artificial intelligence. And if you can look at patients who had greater than 10% total ischemic perfusion defect, the risk associated with early revascularization was half of that associated with no early revascularization. So we have this large body of observational studies that consistently show the benefit of early revascularization in the setting of ischemic burden. I now want to look at the entire Courage study, which compared optimal medical therapy versus optimal medical therapy plus PCI. And you can see in this curve that they're identical. There was no overall benefit to adding coronary intervention to optimal medical therapy. And then the Courage study led to the development of the ischemia study, which Judy Hockman presented in 2019 at the American Heart Association. So the goal of the ischemia study was to evaluate routine invasive therapy, compare with optimal medical therapy among patients with stable ischemic heart disease and moderate to severe ischemia and non-invasive testing. It was not an ischemia imaging trial. Here you can look at the curves. Patients followed out for 5 years, and there was really no significant difference between the conservative arm and the invasive arm. It did not show that there was no role for stress testing. Many of the patients who many of the patients who were too sick or had too much ischemia and were not entered in this study and were simply went on to coronary revascularization. It did not show there's no role for risk stratification. This always needs to be done. But it did suggest that we need to understand more about the relationship between the beneficial effects of optimal medical therapy and the beneficial effects of revascularization. And I want to look a little bit more here at optimal medical therapy in these two studies, Courage and Berry 2D. Both of these studies looked at the number of risk factor and lifestyle modifications that were effectively controlled. Over on the left, you see from the Courage study, and you can see in patients who had 0, 3 of the traditional risk factors control, they did much worse than the patients who had 4 to 6 risk factors control. And this was independent of the nature of the treatment. In the Berry 2D, looking at a diabetic study, and you can see particularly on the right, the risk of death related to the number of risk factors at optimal levels. And you can see, again, the more risk factors that were controlled, the lower the risk. Let's take that information and look at what happened in ischemia. Ischemia is a study where patients undergo treatment with optimal medical therapy. Okay, you see a 50% increase in the use of high-intensity statins over the course of the treatment. You see almost a 100% increase in the number of patients who achieved LDL less than 70 in the study. And you consistently saw twice as many people have high levels of optimal medical therapy at the end of the study than at the beginning of the study. So what it seems to show is that optimal medical therapy is responsible for significant risk reduction. But the question is, how well can we achieve risk reduction in the real world? And maybe that explains the difference between the randomized control studies and the observational studies. So in the observational studies, it was more representative of the real world. They included more sick patients. Everybody was included. Randomized control studies had selected patient populations. People who enter studies tend to be referred if they were less sick. The most sick people tend not to be referred. Additionally, people who enter clinical research tend to be more motivated. The observational studies tended to be single modality, such as nuclear with an expert read. On the other hand, the randomized control study mixed up a variety of non-invasive imaging and non-imaging types of ischemia assessments. Compliance with optimal medical therapy certainly is better in a randomized control study. Placebo groups always do better than the outcomes that you normally see in the real world. They're meeting with the study coordinator on a regular basis. They're trying, when they're asked, did you do the right thing? They want to be able to tell the truth and say, yes, I'm being compliant. So risk factor modification is clearly more effective in these randomized control studies than in the real world. And you can make an argument that maybe these randomized control studies are a study of the value of optimal medical therapy when optimized compared to the real world accomplishments. Another way we can possibly improve the value of myocardial perfusion imaging is to reduce non-helpful testing. Now, we usually start with a pre-test probability assessment, and for many, many years, we've used the Diamond and Forrester criterion. This looks at 3 criterion: age, gender, and nature of symptoms, be it typical angina, atypical angina, or non-anginal chest pain. And based on that, patients can be classified from very low to intermediate to high. The question is this still an appropriate and real categorization of risk in 2021. Well, if you look here in this paper, the paper that Prem Soman published, the straight lines indicate the risk prediction in both men and women by pretest probability of the ACC and American Heart Association guidelines. The bars indicate the observed prevalence of abnormal myocardial perfusion scan. And you can see that there's a tremendously increased risk prediction than actual determination of ischemia in patients with typical angina and atypical angina. So many patients who were deemed high risk, in fact, did not have abnormal scans or manifest ischemia. European came up with recent data with a new set of pretest probability assessment. And what you can see here in the European data in orange is far more people were classified lower to intermediate than the American categorization, which tended to include most people in intermediate to high risk, both in men and in female. So when you look over here of the probability estimates that you can see now, the straight lines, which has to do with pretest probability, are very much more in sync with the actual observation of ischemia. So it does appear that we can probably reduce the number of tests needing to be done for evaluation by reclassifying people from low risk, from intermediate risk to low risk. Let's talk now about the appropriate use criterion. They've been present for about 15 years. We're all beginning to use them. We're going to have to start using them probably next year based on the PAMA Act. But how well do the appropriate use criterion impact the ability of perfusion imaging to define risk? So this is a paper by Rami Duki looking at patients who had appropriate indication for testing, and there's a clear-cut increase in risk associated with markedly abnormal perfusion scans. Looking over on the right, you can look at the predictive value for any of these cardiac criterion, cardiac death or MI, cardiac death or MI, and you can see that when the test is done for appropriate or uncertain reasons, there's tremendous risk stratification in terms of outcomes for all of these criteria. On the other hand, when the tests are done for inappropriate indications, you can see that there's no risk stratification. So following the appropriate use criterion lends credence to the ability of myocardial perfusion imaging to predict risk. Knowing that this risk is related to the amount of myocardium at risk, we can maybe extrapolate that, again, appropriately done tests demonstrating high degree of ischemia based on the observational study appear to do better with revascularization. Looked at it a different way, only tests done for appropriate indications stratify risk. Tests done for inappropriate indications fail to stratify risk. You can see here appropriate or uncertain with an abnormal MPI versus a normal MPI, and statistically significant to P equals 0.001. On the other hand, when the tests were done for inappropriate reasons, there was no effective risk stratification at all with P equals 0.11. I want to talk now briefly about the recent release of the multi-society guideline for the evaluation and diagnosis of chest pain. Multiple societies participated. The American Society of Nuclear Cardiology did not participate, and I'm sure you can hear a little bit about more of that discussion on at the ASNC website, or we can talk about it at the open discussion. This, however, creates a pyramid of risk assessment of people from asymptomatic to low risk to intermediate risk to high risk. And what you could see for the first time that there is a large number of patients for whom we recommend no provocative testing, maybe an EKG, maybe a coronary calcium score, but it's not until we really get to intermediate to high risk that we then have to choose whether we're going to go directly to coronary angiography or whether we're going to do anatomic or functional testing. If you want to choose one or the other and look for the benefits and when you should do anatomic assessment and when you should do functional testing, again, low risk do not need treatment. Young, intermediate to high risk in whom less obstructed coronary disease is suspected, coronary CTA is favored. So a negative test that's most helpful with coronary CTA. In older patients, intermediate to high risk, known coronary disease, more suspicion of obstructive disease, stress testing is favored. So the value of nuclear cardiology has not changed, but rather the role of cardiac testing is evolving. So using myocardial perfusion imaging, looking at action and impact, the actions that should be taken based on the results of tests include lifestyle modification, up-titrating guideline medical therapy, and identifying the patients who could potentially benefit from revascularization. The impact of this would be to decrease symptoms, improve quality of life, and decrease cardiac event rates. So patient first means no one specific test should be considered the first line all the time. The choice of tests should be based on AUC and centered on patient needs. The testing should provide the best information to guide patient management. And I think you'll see over the course of the discussion in the next few days, we can all play together in the sandbox, that there's room for everybody. I want to thank you for this. And if we have time, I'll take some questions.
Thank you, Dr. Wolinsky, for this very nice overview of what's new in nuclear cardiology. I know we'll address more specifically also PET in our next session on coronary disease and ischemia, so I think you will hear that from Dr. Al-Mallah. And I want to come back now to Dr. Roberto Lang, who gives us a little overview of artificial intelligence and virtual reality in cardiovascular imaging. What does the future hold? Roberto.
Well, hello everybody. It's a pleasure again to talk to you about artificial intelligence and virtual reality in cardiovascular imaging. What does the future hold? In the next 10 years, a lot of papers will be written on artificial intelligence and cardiovascular imaging, particularly echocardiography. And let me tell you that artificial intelligence is that a technique in which we enable computers to think. A subset of artificial intelligence is machine learning, in which we create rules for computers to learn supervised from data. And another subset is deep learning, in which computer networks are capable of learning from data in a completely unsupervised format. Most of the studies I'm going to show you today are going to be done particularly using machine learning. And then we have the big data, in which we try to understand data, in which, in addition to artificial intelligence, you have other techniques like probability, statistics, algebra, numerical optimization, and programming. To date, a lot of studies have been done in the ologies, which I like to call like radiology, particularly in those type of situations in which the images are static and not dynamic. Echocardiography is particularly difficult for artificial intelligence because in echocardiography, as you all know, we use multiple views, multiple levels of gray, multiple colors, and as a consequence, this is a technique that has suffered in part of a larger that we would like inter and intra-observer variability. One of the first things that our group did, and many other groups, was to try and teach a computer how to identify the different echocardiographic views. And for that, we teach the computer every view and what are the structures that we need to find in that particular view. And this is the result of our study, in which we trained a computer with about 250,000 images. And as you can see, the view classification created by a computer and created by an expert ground truth over all the views is about 90%. This, of course, leads us or lets us to do what is called reading in stacks. If a computer knows and can identify all of the views, we can tell the computer, instead of us reading like we do now, all of these echo images that come in random order, is we tell the computer, let me show me all the stacks that have the mitral valve. And then it becomes sort of easy to read. So we can look at the mitral valve in M mode, in 2D, the quantitation. Then we can say, well, then show me now how to assess left ventricular diastolic function, or let me look at the aortic valve, etc. Then subsequent, a lot of people are putting a lot of energy into teaching computers how to make the measurements in an automated way. And this here is our effort in which we are showing the computer how to do the biplane left ventricular volumes. In the next set, we are going to be teaching the computer how to do the measurements of the left atrium, biplane left atrium. And of course, if the computer knows the different images, it is possible then very easily to do strain, because the computer already knows the views and it does it in a completely automated way. This is an example of a patient with severe aortic stenosis. You can see here that the computer has been, gives you an automated measurement of the left ventricular outflow tract. Then it takes the pulse Doppler and it makes 3 measurements and it averages them. And then it takes the CW across the aortic valve in 3 beats, again, measurements, and gives you an average measurement completely using artificial intelligence of the aortic valve area. Another area in which there are like 6 or 7 companies working on is on the use of automated intelligence for guided image acquisition, or what I like to call the echo GPS. Other people call this the democratization of echocardiography, because a lot of people will be able to do it. And this is an article in which we participated. It was published in JAMA, in which you can see somebody placing a transducer on the chest. And you can see that immediately tells you this is the image that you would like to get in the parasternal. And then it tells you how to move the transducer. In this particular example, you rotate counterclockwise, and then you get a quality meter. And once you get into the green, it will do an auto capture, and it will also use automated intelligence to make the ejection fraction measurements. Now, let me show you, this is yet another company that uses just another type of software. In this particular example, you can see that the transducer is placed on the chest, and then the transducer will have its own X, and then you want to overimpose one X with the other one. And once you are in that type of position, you can do this automated quantification of a very nicely acquired apical 4-chamber view, or whatever view you obtained. And this is an example of an echo that was performed by a nurse who never had experience with echocardiography before. And you can see that in these views, these are not perfect, but you can definitely make a very nice diagnosis of the size of the ventricle, the poorly contraction of the ventricle, etc., if there is a pericardial effusion, etc. So I would like to sort of end this part by saying that our artificial intelligence would not replace echocardiographers, but as all of this advances, echocardiographies who do not use AI are going to replace those people that don't use AI. Now, in the remaining of the talk, I would like to talk to you a little bit about our work on virtual reality. And I would like to tell you that, 3D echo is, we have a structure that is in 3 dimensions, but we display it for you on a screen that is flat. And when this image is flat, we need to color code it to give you the illusion that it is an image that is being acquired in 3 dimensions. And in order to do that, people have used stereo glasses. Many of you probably have experienced them in movies. People have used these stereo monitors, which are very good but very expensive. People at the organizing institution of this meeting have a lot of experience using 3D printing. And then you have also the ability to do holographic displays. These are all different ways of trying to show you an image in 3 dimensions. Our work is using virtual reality. This is a situation in which, with the use of headsets, you're immersed in your own reality. It's a computer-generated reality, and a lot of this has been developed from the 1950s onwards in order predominantly for playing different types of games. This is an example of a game, virtual reality. As you can see here, it looks real. Now, we also have to talk about augmented reality. This is a combination of computer-generated objects like the heart here with real-world objects like my desk. And this is used with Microsoft HoloLens. And you can imagine the possibilities of teaching patients about their own cardiac problems using such a type of model. When we use virtual reality, let me briefly describe the setup. What we need to use is we have room sensors that are tethered to a computer. Then we also have headsets and controllers, of course, tethered to a computer. It creates an area in which we can visualize these VRs. And this is an example of our little lab here, in which the fellow is very worried about me falling when we use these virtual reality sort of models. Now, this VR has undergone a second generation. And now, in order to make this work, we have headset and controllers that are not tethered to a computer. There is a little computer inside the headset. There are no need for room sensors, no cables. And you also have, as I told you before, a front camera, and it is all controlled by different types of gestures. And of course, one of the big advantages is this allows multiple people to use this simultaneously. And this is an example of us doing this work and the American Society of Echo. And you can see here 35 physicians all looking at the same data sets. They're completely immersed in this reality, and it allows us to show one data set and teach a lot of physicians regarding the anatomy. And this is a little movie I obtained from the Cleveland Clinic, in which they are now teaching anatomy using all of these virtual reality data sets. And instead of learning with cadavers, you can wear the bones, you can wear all of this, and you can take it to your house and image and study whenever it is convenient for you. Now, this is an example of a patient with a mitral bioprosthesis using the headsets. I'm going to sort of take this heart out of the screen, make it float in this room. You can see the 3 leaflets. Only one is moving. Now the software has been sort of modified that allows you to do cut planes, to change the gain, and to do all types of measurements. Here we're going inside a CT data set. You see the 2 papillary muscles, and I'm going here inside the left atrium, in which I see the pulmonic veins. I can see both of the pulmonic veins. And I'm turning now to look at the apex of the ventricle. And this sort of reminds me of this movie that some of you might have seen, A Voyage Inside the Body. And I think the same thing you can do now with virtual reality. You can truly go inside the heart and so on. Let me show you another case. This is another CT case in which I'm sort of turning things around to find the heart, to be able to go inside the heart. This is also a patient with a prosthetic valve in which one of the struts is obstructing the left ventricular outflow tract, similar to things that we have to be careful when we do this TMVRs. I'm going to go now inside the heart, and very quickly I'm going to show you these are the different struts of the valve. This is the outflow tract, and you can see how this particular strut is obstructing the outflow tract. So this is definitely a different way of looking at this anatomy. Look how much this is obstruction here. And we can see anatomy in a way that we have never seen that before. A lot of measurements are now allowed. We have been working hard to be able to make these, all types of measurements that you would do from a NPR type of view. And the whole idea of this is, that by using these techniques, for example, I could take you on a trip inside an LVAD to see if there are thrombosis and so on. Imagine how you could see how well this LVAD is sitting inside the chest. And of course, now we can do this simulation of procedures. This is the orifice of the left atrial appendage. We are creating the surface and measuring it. This is just to show you that you're making a measurement on a structure that has 3D. You can take this and you can sort of place it, and you can simulate your procedure and see if there is any leakage on the side of this particular valve. And you can see here nicely that this is something we're sort of working. This is another example of trying to create a simulation of a mitral valve. We have placed sort of a mitral valve. We see the correlation of the mitral valve with the aortic valve. We are now going to take a prosthetic valve. We're going to sort of insert it in place and see exactly how this type of valve looks when it is in that particular type of a position. A little bit, the vision is that we, non-invasive cardiology, will be helping our structural heart disease colleagues and our surgical colleagues in trying to do a lot of virtual surgery on a computer. And this is a little bit the vision. We will be reading our echoes. We'll have our list of echoes, as you can see here. And when there is an echo that you would want to take a VR look at it, you would press a button and convert that echo into a VR, that 3D file. And then you will be able to extract this 3D echo from the computer and make it float in your room. Let me remind you that this is as big as the room that you're sitting in, and you can look at all the anatomy from whatever position you would like to look at it. So I think that with that, just to tell you that, with echocardiography, every time that we think that everything has been done, there is always more and more that is coming, and more to learn, and more information that we can obtain from this amazing technique. Thank you very much, and happy to answer any type of questions.
Thank you, Roberto, for really amazing, fascinating update on virtual reality and machine learning. I think the pictures speak for themselves, and I think the power here of education, learning, not only for the healthcare professionals, but also for patients is really amazing. So now it's our actually time to do some interaction among our faculty, and I want to welcome all of you. Jonathon, David, and Michael, it's great to have you, and thank you for your contributions to this first session on technology. And we're going to open it for questions from the audience, and I'm going to remind them to either go to their computers, or pollev.com, or text it. If they want to text it, to DeBakey 37607. I think we'll have these instructions for you. We have one, let's see here. AI may not pose a risk of displacement to interpreting physicians. However, it may pose a risk for echo technicians. How can they be better prepared for this technology when it is in full use? I think that's a great question, Roberto. You're muted.
Thank you very much. I agree with you. That's a very good question. But I think that sonographers do not need to worry at all, because what is going to happen is that the type of work that sonographers will be doing will be changing. And, you know, I envision in a couple of years that, as I showed today, that you will be acquiring a couple of 3D echoes from which a computer will obtain all the 2D echoes and measurements will be done. All of that will require a lot of human intervention in order to make it perfect. And I think that the work of a sonographer will actually change, and there will be much more sort of work on the computer and maybe less work on these heavily acquisition of studies and so on. So I don't think here nobody's going to lose their job. I think only in my vision, the work is going to be changing. And then the other thing I can say, this is something that none of us can stop. This is going to happen. Change is always good, and change happens in medicine. And so we need to adapt to it. And I think our jobs will be changing.
I really fully agree with you, Roberto. I think you could take the analogy of even AI and machine learning in reading electrocardiograms. It has not displaced, it has facilitated in a way what we've done. And I think for the sonographers, I would add that particularly the new learners that are coming on board, maybe with that enhancement, actually it can exponentially accelerate their learning. Because we know that early on, you know, they need to be shepherded through as to telling them this is a good view as opposed to this, you can enhance this. And basically the machine is trying to do that. Also, we have some auto-quantitation nowadays that is helping us. I'm pretty sure is the same field is happening for MR and CT. Maybe if we can get a reflection on the impact of AI and machine learning from our colleagues here in CT, MR, or nuclear. I don't know, Jonathon, maybe you could start.
Sure, thank you. I trust you can hear me okay.
Yes.
First of all, fantastic talk on the opportunities. I mean, I have little to add to Roberto's thoughtful comments. I think, as he highlighted, you know, change happens. You know, if we think about the history of modern medicine, we're talking about not even a blip of a blip of a blip in the history of humankind. So sometimes I think we get a little bit focused. Well, this is what we do with, you know, echo, or this is what, I mean, echo is, what is it, 40 years old. So I think it's evolved, as Roberto says, just when you think you're done, he continues and others continue to teach us about more opportunities. I think for CT, I mean, the obvious one is it really lends itself to AI and computer augmentation, stenosis quantification, stenosis characterization, and reproducible measures of stenosis. If that doesn't lend itself to a computer versus my eye, my emotion, my variability, my mood, my fatigue, I don't know what does, right? And so, you know, I think that we'll play a role in, as Roberto thoughtfully mentioned, I think in integrating the data, understanding the data, contextualizing the data, looking for pitfalls with the algorithm to better understand where it may have failed, and be able to adapt to unique situations where the algorithm may have not worked. But I think it will not only stabilize those measures, but it will extract more information that we simply can't do. We don't have time, we don't have the capability, you know. Strain from a CT, it's there if you have a full dynamic study. Ejection fraction, extracellular volume potentially, and then of course plaque quantification. So I see this as a real opportunity for our patients. And as Roberto highlights, if we adapt to it, a tremendous opportunity for us to make a bigger difference for our patients and to continue to learn and grow.
A question for you, Michael. can you go scroll down to that last question? Can we use MRI diffusion-weighted imaging, DWI, in detection of cardiac cancer or infarction?
So diffusion-weighted imaging is sensitive to a lot of things. It's sensitive to the motion of water. So anytime that's altered, you can potentially see different things in pathology. So I think there's opportunity to use it in infarction. Looking at tumors, again, you may have differences in the water mobility, which you could detect with diffusion. At least right now, it's still a little bit of a research application in terms of the acquisition, but that's improving rapidly. A quick comment on your last question about the AI. I think in MR, it already is having huge potential in terms of how we do the analysis. I spent a lot of time drawing circles for many years, and now AI does it for us 100 times faster than we're able to do it. And I think similar to Echo, where it's starting to help us do a better job of scanning. There's already a motion in MRI of really looking at how can the scanner be self-driven or other things in order to get the data more efficiently. So I think similarly, we're going to have to be able to know the failure modes of these things and be able to make sure that we're getting good quality data. So I think both the techs as well as the physicians will have a role.
To David and Jonathan, I'll probably start with David. There's a question that said, do we need all these advanced plaque analysis tools? ? Would a calcium score suffice as a surrogate measure of atherosclerosis?
All right, I will start. I have my bias. I think you can get a significant amount of data by doing a calcium score associated with a PET CT or a SPECT CT. But like everything else, more information is valuable. It's going to take time to really see how much it adds. And until you start using it in clinical practice, you're not going to be able to see that. The holy grail is being able to predict the day before an MI which plaque is going to rupture. And that's, I think, where plaque morphology is going to be most helpful.
Jonathan.
And David and I agree very much on this. I think what he said is spot on. I think we've seen from the West Danish Heart Registry and, even from the Confirm Registry, which we participated on, that particularly in a statin-naive patient, that the calcium score will track well with the overall burden of atherosclerosis, such that if you have a low calcium score, you're unlikely to have a high burden of non-calcified plaque. If you have a treated population, obviously we know that the calcium may outstrip the overall plaque burden and may erroneously overestimate risk. So in a statin-naive patient, I think right now it is very helpful. Maybe, the number of segments of disease, crude measures as well, if you do a CT, may help, but incremental to the overall calcium score, not yet clear. I think it's exactly as David suggested, and maybe not even around which plaque is going to rupture, but there would need to be evidence. But one could imagine that tracking treatment response to more expensive therapies, it would be valuable to have a quantitative plaque tool to look at the overall plaque progression or stabilization. But again, you notice I use the word could, not proven, and we don't have a tool that's stable enough to yet do it. So I think we're spot on. I mean, like David, excited to learn more, and obviously some opportunities there. But I think right now, little evidence that it's incremental to the calcium score in a statin-naive patient.
Does the panel agree along these lines? And there was another question reflecting on your comment, Jonathan, regarding functional testing and calcium scoring, whether the question to you guys, and which I feel strongly about, is we do physiologic testing, with stress echo, stress MR, stress nuclear, right? We do all that. And if we don't, if patient is not on a statin and may be at risk of coronary disease, the addition of some burden of disease in addition to the physiologic situation, the data supports a calcium score or some other imaging modality to tell us about the burden of disease, because physiologically they may be fine today, but they're at risk down the line. Do we agree on that, or is there some controversy among ourselves?
I mean, if you're asking me, Bill, I honestly, in the modern day, I'm not sure how you can make decisions around medical management without a measure of atherosclerosis. And as David pointed out, I think, in his talk very elegantly, there are multiple class 1 tests. I think that, pursuing stress testing as first-line tests in some patients, very much very reasonable. But I think that's where, to his comments about having at least a measure of the plaque burden to know, titrating medical therapy, I think is very important. I think that's a message of Scott Hart, and that's a message of a lot of the registry data from Denmark as well.
Also, some.
One of the concerns
Go ahead, David.
One of the concerns I have is that to some degree we're preaching to the choir. We can teach when to order a test. We can make sure the test gets done properly. But we have to make sure these results are used properly. And if everybody has a calcium score and goes on to have a stress test and goes on to have a CAT that they don't need, then we haven't moved forward anymore. So we really have to focus much more on changing behavioral patterns, on using the results of whatever non-invasive test you choose more properly.
Along these lines, David, are you seeing in your, and all of you, are you seeing a lot of layering of testing, and should we do a better job at more appropriate use, or at least scenarios where conceivably you don't need to layer so many tests? Because we see that from time to time, and maybe more than from time to time. And I think that would be important from a healthcare economics point of view, as well as a patient perspective point of view.
So I don't know if you asked me that question directly because I'm in Florida. Absolutely, we see multiple layered testing. I get second opinions all the time on, do I need this test? Do I need that test? But it is a big problem. There's no reason somebody needs a PET, a SPECT, and a CTA before any clinical decision is made. And that's part of the problem. There's no doubt, and I don't want to accuse everybody, but there's no doubt that in the private practice world, there is concerns not only for layered testing, but quality of testing also that can lead to bad clinical decision making. And I urge people to think about what they're looking for when they do the test. Make sure that they follow what they believe in the results of the test, and educate people along the way. I think people who get on this course are practicing good cardiology, but it's up to us to educate those people who don't have access to this, or those people who really don't understand clinical decision making, or the APPs are beginning to do a lot of primary care assessment when patients present with chest pain.
And maybe a good thing to do is for us and all the people that are listening, and leaders in the field and scholarly leaders in the field, is to translate, if you will, the newer guidelines for chest pain and into some different scenarios of people, so we don't have to layer too many testing. And I think we probably should do that, even from an ACC/AHA perspective and European Society of Cardiology perspective. Michael, any thoughts from your end?
Yeah, I think two points. Number one, I agree with making sure that you are doing a test when the results are going to change your management, and then also to less think about our studies as really being binary and being more clinically thoughtful about what the next step is. And then one other comment about layered testing is that, we really have to think about, in some cases, it may be worth seeing anatomy and function before you're going to the cath lab, given the high prevalence of non-obstructive cases, as well as cases where people have non-obstructive disease and it's really microvascular disease. So one way you can say, with all the technology we have for non-invasive imaging, if somebody goes to the cath lab and you don't find obstructive coronary artery disease, it's really a failure of non-invasive imaging. something we really should be able to do better on this.
Roberto, I think you would agree with that too, correct? Even in the echo world.
Yeah, absolutely. I agree entirely.
I think we should do that. There's a question, a technical question here for you, Jonathon. Can you comment on photon counting CT? I know it's a newer technology, and we've seen some of that, and its impact on the cardiac CT itself.
Yeah, I think it's tremendous opportunity. I mean, I don't need to preface it by saying that I don't have one because there's only a few installed. And I think that the first installations are of a really excellent first iteration platform, but I think we're going to see continued growth. The concept being that you can have then true material decomposition or spectral imaging, allowing you to separate energies. That opportunity will allow you to improve spatial resolution. I'm cognizant that Dr. Salerno is also an engineer, has an engineering background, but my understanding is improvements in spatial resolution, but also the ability to potentially do some tissue characterization. Although I think ultimately, MR and echo are really excellent tools allowing us to understand tissue without radiation. So I think the main focus for us with photon counting will be, to just get better with anatomical evaluation of coronary disease, isolate plaques, remove calcium, and be more accurate with improved spatial resolution and start.
Wonderful.
Yeah, there's also potential on having lower dose based on the effect of reducing a lot of the electrical noise and other background noise. So I think they'll both really provide new insights, and it's already pretty incredible to see that in this first iteration of a clinical scanner, they're already doing coronaries with a dual source scanner with 67 millisecond resolution with spectral imaging. It's incredible.
I think all of you have shared amazing advances in technology. I think, going back even 5 years ago, technology in each one of the fields, ultrasound, CT, MR, nuke, you name it, have improved so much. The question to you is, in your practices, what is the quality of things that are sent to you? Meaning, are we lagging too much behind the latest developments, or people are catching up? Because to tell you the truth, I think it impacts quality, it impacts results, and it impacts outcome. I just want to have a feel whether the field is changing in the field.
I think you asked a really good question, and I think echo of all of them is probably the one that does probably the worst, right? Because I think it's so easy to acquire an echo study. Most of the time, by acquiring, I always like to say you don't create harm on the patient. But the quality of studies that are being done, unfortunately, are still lagging way behind what there is. I think also the technology, we see beautiful technology, but part of the problem is that nobody gets paid by using this technology, and I think that has a major impact, right? There is almost no payment for 3D echo. It's sort of very difficult to, the use of 3D echo in the structural heart disease. I think payment is also, I think, a lot of it responsible for the lack. I still think your question is a very good one. My observation is that there is still a huge lag in what is being done outside and what is being done in an advanced type of place. And hence, we see this issue that many times echo studies, not only echoes, but many studies are being repeated. So I think your question is a very pertinent one. And I still think that education needs to go on and on to bring us all up to par.
And I think the physicians have to be the advocates for, obviously it's costly to get a newer machine or an update to a machine, be it MR, CT, echo, whatever it is, nuclear. But it has evolved so much that we have to be the proponents of this, and I know administration at times may not respond as well, but But I think it is our duties, and I presume all the people who are listening have the same kind of issues at times. We're fortunate in our institutions probably that, yes, we get, the latest, etc., but it has to permeate also the field of medicine throughout. Roberto and all of you, are people using handheld devices in their daily practices in the hospital, etc.?
I think that is an area where you see quite a lot of advancement. I think that at least AI devices are being used by the residents in internal medicine. It's being used in the CCUs. So I sometimes ask myself, why on earth would you use a small echo device for your sickest patients, where you want to use the more advanced machine? But that is what's happening. It's being used in the emergency room many times, I think, for things that it should not be used, but it's being used. I think we'll see a lot of changes and advances with the use of these small echo machines. Therefore, all this AI teaching people how to acquire images. But unfortunately, this is the use of echo. In one weekend, you become an expert in echo, right? You do a course, and then people interpret, and you see things, mistakes that occur of a resident. People then who read what the resident did misinterpret this as getting an advanced echo, so you get an incorrect thing about the prosthetic valve and so on. So with all these advantages, there are a lot of problems that the societies will have to deal with in order to. But yes, there is a huge advancement in the use of it, which, in my opinion, is posing problems also.
Are the others seeing the same?
No, I think there is a role in certain cases. You see a big heart on X-ray, you want to rule out an effusion. That's something obvious that you can do. Our fellows do that, and they're very helpful in just assessing things in the area of COVID. If you're not sure about an EKG, and you can look for a wall motion abnormality in somebody who's coming in clearly with COVID, but has a suspicious EKG or vague chest pain, you certainly can reduce the exposure by looking at the echo to see whether there's also acute coronary syndrome going on. So I think in specific issues, but I don't know anywhere where somebody's really had a handheld echo done for a meaningful reason that didn't have it repeated later in the day or the next day by a technologist.
Any other
Maybe
thoughts?
it is because I'm hypersensitive to this, right? And that's why I tell you what I have seen cases in. I mean, if people would do what you say, for specific reasons, human nature is that you try to expand once you do that, and that's where I think sometimes issues happen, and that's right.
Yes, I agree with Roberto's concern, is that in the sickest patients, you have to be careful about what you're looking for and what you're going to be able to miss, unfortunately. And I think, obviously, patient diagnosis and patient outcome is going to be the most important thing, as opposed to just doing the study. So we have to be careful about that. Yes, it's helpful, it's useful, but be well trained for that. Michael, you wanted to say something.
Yeah, no, I was just going to say that, I think it's being used more, and I think what we need to do is make sure it's being used in a high quality way. And I agree with Roberto, it's being used in more places around the hospital, and we just have to catch up on the other parts, which is making sure that these images are getting to our PACS systems, that they're available for others to look at it, and not that you have an initial test and then they come to the echo lab with, we saw what we thought was a big effusion and the images aren't available, because we could probably avoid some of the layer testing by having somebody with a little bit more experience look at some of these images, particularly in the more challenging cases.
Well, with that, I want to thank you for spending some of your Saturday with us. I think this first session was really amazing, putting us on the map of what is the latest in cardiovascular imaging. I want to thank you all. We're going to take a break, but I want to ask the audience maybe to go and visit the exhibits. There is a way to do that nowadays virtually. And want to thank you again for amazing contributions. I think our second session will be co-chaired by Dr. Wolinsky, so we'll get him back, David, and Dr. Leipsic together. So, and we'll meet about half past the hour, so people can stretch, do a few things around the house or the facility, and then come back to us. Thanks again.
Thank you.
Thank you.
All right, I want to welcome you back to our second session for multimodality imaging. And this session will be co-moderated by Dr. Leipsic and Wolinsky. And we'll have actually a featured debate between Dr. Leipsic and Dr. Memarian. And it has a lot of other interesting areas on detecting ischemic heart disease and assessing risk. So take it on, gentlemen.
Thank you so much, Jonathon Leipsic from Vancouver. Privileged to be co-moderating at least the beginning of this session with Dr. Wolinsky. I will kick off the session with a recorded talk, really a powerful advocate for the role of coronary calcium scoring in advancing our understanding of risk stratification, Khurram Nasir. I think few people have contributed to the field of coronary calcium scoring and prevention in a fashion that he has. The talk is Risk Stratification and CV Prevention. Should calcium score guide lipid management? The Power of Zero.
Greetings from Houston Methodist. Welcome to our annual imaging symposium. I'm honored and delighted to talk a little bit about the potential utility of using coronary artery calcium scoring, especially how it can guide your lipid management. So a fundamental issue, and I think so the holy grail within cardiovascular medicine in general, and especially for preventive cardiology, is who is at risk. And that is a critical foundational issue, as not only decide individual, but also at the population level, not only the appropriate resource allocation, but the intensities of intervention that needs to happen to reduce the downstream risk. Traditionally, our risk assessment methodologies rely heavily on traditional risk factors such as blood pressure, your physical activity, tobacco smoking has been upfront and prominent, and newer markers such as stress and pollution intermixed with biomarkers with a major focus on lipid markers, but also glycemic inflammations and some new kids on the block in the lipoprotein A. Most of this are entered into some algorithm, and overall that gives an indication of what your 10-year risk or even lifelong risk is. For example, and these are more prominently used in the general population, and I'm sure you will be seeing the spectrum of patients. For example, someone with multiple lipid disorders, higher 10-year risk. On the other hand, individuals with unremarkable lipids and overall low predicted 10-year risk. And the question is, how would you manage them in your clinic? Naturally, I would be more inclined to treat this patient more aggressively as compared to this one. However, it's always important to take a step back and ask ourselves, how good are these lipid risk factors approaches alone? Now, over the last 2 decades, we have seen quickly how the pendulum have shifted in the past from underestimation, where the general consensus and the guidelines significantly underestimated risk in individuals at having risk for coronary heart disease such as MI. For example, in this study, only 10% of individuals who eventually presented with the MI were considered high risk, to a point where in 2018, with the prior pooled cohort equation, and now we're at a point where almost majority of individuals who are considered high risk are actually much lower than anticipated. So the question really is, why not focus where the money is? And if we truly believe for cardiovascular disease, and especially coronary heart disease, the underlying culprit is not only the presence, but the burden of atherosclerosis, and is the foundational marker for risk, why not focus on this? Of course, in our Moderators, we have many tools, but today I'll speak a little bit more about the coronary artery calcium scoring, which was first introduced by Arthur Eggleston in 1990, which is a rapid CT scan of the heart, doesn't require any IV contrast, is now widely available. Most of the places you can get it for $55 to $150 with a low radiation dose equivalent to a mammogram. That over the last 20 years now, it is well established that it is considered one of the best, if not the best predictor for a future heart disease. Almost about 9 to 16-fold increased risk for coronary heart disease, maybe the best discriminator among who will have versus not, and more importantly, making meaningful reclassification to a point where this treatment decisions can be affected. Not only it is associated with increased risk and identifying those who are likely going to have events. At the other extreme, absence of calcium score of 0, now most commonly known as the power of 0, is very reassuring, whereas almost a decade ago, it was very clear to us that calcium score of 0 seen in almost a significant proportion of the general population is associated with such low risk that downstream further advanced imaging as well as potential preventive medications, pharmacotherapies can be foregone in lieu of focusing on lifestyle interventions. Now, coming specifically for lipids, the question is, what happens if your lipid is normal? Would you still be at risk of having underlying atherosclerosis, coronary atherosclerosis, and can that predict your future risk? So in this study, almost about 10 years ago, led by Ron Blankstein, the past SCCT president, clearly showed in the MESA study, almost half of the individuals who would be considered having normal LDL have any calcification, and almost about 15% with calcification at as high as greater than 100 and 400, with event rates of 5 per year percent event rate going up to 1.5 to 2.5%. Now, more importantly, as shown in this busy slide, you can clearly see that when you're taking into account all the other risk factors, including hypertension, diabetes, family history, cigarette smoking, IMT, it was only not only the presence, but also the higher burden that predicted your risk, even among individuals with normal LDL. And not only that increased calcium score among those with low LDL are predictive. What we have clearly shown that even among extreme risk of individuals, be it number of risk factors of number of lipid abnormalities, a significant proportion of individuals have a calcium score of 0, whereas even among normal LDLs, about 42% of individuals have some amount of coronary atherosclerosis, with 20% of individuals showing significant atherosclerosis. And as clearly shown in both of these studies, it doesn't really matter how you slice or dice the pie. It truly, your outcomes are dependent upon how much coronary atherosclerosis you have. For example, individuals with at least 3 lipid abnormalities have much lower risk as compared to those with none lipid abnormalities, but just presence of minimal atherosclerosis. Not only that, in 2015, we clearly showed that with the 2013 guidelines, almost 2/3 of the adults with atherosclerotic cardiovascular disease are candidates for statin. Surprisingly, 1 in 2 of those individuals have a calcium score of 0, and their 10-year risk is much lower than the threshold where even the guidelines would recommend statin. And as a result, we promoted at that time of a paradigm shift of moving away from screening, and where truly the role of the coronary artery calcium testing is as a decision aid for shared decision making, and only for those individuals who are desiring flexible treatment goals. Subsequently, we also showed that as far as de-risking, calcium score of 0 is truly peerless, and none of the other risk factors come close in lowering the pre-test probability after with the test. Not only that, but it's also cost effective from the societal perspective as compared to the treat all approach. And in a fantastic study, Todd Villanis and group showed that in a 12-year follow-up, even in treating a significant proportion of individuals with a calcium score of 0 would not lead to any changes in downstream events. As a result, in November 2018, the AHA revised their lipid guidelines, boosted the role of the calcium score, made room, and also claimed a larger role in the cholesterol guidelines, where we could now stop making wild guesses and probably move into the direction of having some more educated answers. So if you look at the guidelines, it is recommended for those with a 5-year risk of 5 to 20%, where you are uncertain of the risk. And if the calcium score is done with 50% of the individuals having no atherosclerosis or the power of 0, where you can defer the treatment of statin or even postpone that. And now, not only that, now we also have a role of calcium scoring in high-risk groups that is greater than 190, which was truly an area of unknown. We don't believe that everyone with severe hypercholesterolemia is the same risk, but of course, it was an evidence-free zone. However, a MESA study showed that almost 30% of individuals with LDLs greater than 190 have a calcium score of 0. Their 10-year risk is less than 3%. And finally, in an editorial led by Marcio Bittencourt and Mouaz and Al-Mallah, we truly believe that the power of 0 have passed another test where it can have an application even in this high-risk group. Furthermore, if you look at even with familial hypercholesterolemia, about 40% of individuals have a calcium score of 0. As you can see in this study, in a 5-year follow-up, none of them have any events. As a result, in circulation, we promoted the idea that among those with a calcium score of 0, although everyone should be on high-dose statin, at least the PCSK9 inhibitors and advanced lipid-lowering therapies can be avoided. So, in essence, calcium testing ensures that one size doesn't fit all. It overcomes the imprecise risk estimate by lipid measurements. It's a precision tool. It's going to recalibrate your average risk estimate, irrespective what your baseline estimate is. A calcium score of 0, of course, does not equate to 0 risk, but much lower than anticipated. Your treatment decisions are based on threshold decided with shared decision-making, where a patient may still want to pursue statin therapies even with a calcium score of 0, whereas among people who would like to undertake the test and only proceed with statin therapy, this is a test for them. So in the end, I think so with the new innovation and I would say discoveries, the choice is clear for us, where we may be still stuck with some of the old paradigms. I truly believe that the biomarkers have served very well in the past for risk assessment. Now we clearly have better tools. It's time to have the paradigm shift, moving away from guesstimation to one that is based on see disease and treat disease. Thank you so much. Look forward to your questions and any feedback.
Thank you again to Dr. Nasir for his passionate discussion of the power of 0. The next half hour is going to be really very, very exciting as we discuss probably one of the most controversial topics in cardiology today. Debate CCTA and FFRCT should be the first choice in the assessment of suspected coronary disease. The proposition will be given by Dr. Leipsic.
Thank you for having me, Jonathon Leipsic from Vancouver. I'll be debating on the side of CTA and FFRCT for the first choice in the assessment of suspected CAD. I'm honored to be part of this debate, and I wish we were in person. Such a great meeting. I do have disclosures. I've received a grant from GE Healthcare and give advice to HeartFlow. Those are salient to this talk, but I will proceed. So if we reflect on the title, it says CTA and FFRCT should be the first choice in the assessment of suspected CAD. To be honest with you, while I hold Professor Mamarian in the highest regard, he served as a mentor, such a wonderful physician and a thought leader. He really has an untenable position because, of course, he's taking the side that stress testing should be the first line test. One problem, stress testing gives you no information about the extent and severity of atherosclerosis. The debate is about CAD, coronary artery disease. It's not about microvascular function. It is not about regional myocardial blood flow. It's not about wall motion abnormalities. It's about coronary artery disease. And Dr. Mamarian is going to try to make a case that tests that show you nothing about the coronary arteries should be the first line test. Well, it is what it is for him. I feel badly. I would argue, though, that we should be considering CT first because we really do want to know the extent and severity of coronary disease as it relates to patients presenting with symptoms suspected, suggestive of possible angina. When we look at the pathway that I suppose Professor Mamarian will advocate for, you can appreciate that it is incredibly limited. In fact, it provides no insight into the extent and severity of atherosclerosis until you do an invasive procedure, and only perhaps with invasive imaging. It starts with a tremendously unconsciously and consciously biased adjudication of symptoms, sex, gender, ethnically biased, and even climactically biased. And then traditional stress tests that provide no actionable information around guiding medical therapy, because you have no idea if the patients have atherosclerosis or not, and provides you no information about the extent and severity of anatomical stenosis, which we know is powerfully prognostic. We know this pathway is broken. Perhaps Dr. Mamarian doesn't know that, but certainly the data goes back over at least a decade that shows that this pathway does not provide actionable information, certainly as it relates to ICA referral. See the data on the right from Pam Douglas and Manesh Patel. 82% of patients in the NCDR had stress tests. This should be our first-line test, apparently. And yet when they go to the cath lab, they are found to have no actionable coronary disease. Similarly, on the left, with nuclear stress testing from Dan Berman's lab, 100 patients with ICA adjudicated left main severe stenosis that had SPECT before, 44% of them had normal or mildly abnormal SPECTs. So a normal or mildly abnormal SPECT does not rule out left main disease. So I would argue that we should start with CT. The first reason is it's a better it's an anatomical test and actually answers the question about CAD. Here's data from the ischemia trial highlighting that the agreement with ICA is incredibly high, even in complex coronary disease. We were the CT core lab along with others, and what we found was compared to QCA, CT agreed 97% of the time as it related to the exclusion of left main disease and the diagnosis of coronary disease. Far and away the best non-invasive tool for the confirmation of anatomical stenosis. The second reason we should start with CT is because it's highly prognostic, and the prognostic utility extends way beyond traditional stress testing. I could spend hours talking about the incremental prognostic utility. The negative likelihood ratio of CT is more powerful. The warranty of CT is much longer than traditional stress testing because it rules out atherosclerosis. But I will just share with you this slide, recently published by Harmony Reynolds about 6 weeks ago in Circulation, highlighting that the extent and severity of anatomical disease by CT was associated with a clear dose-response relationship with mortality, whereas the extent and severity of stress testing abnormality exhibited no relationship with incident mortality. So not only is CT prognostic, its prognostic utility far outstrips that of traditional stress testing. Now, I don't have time to delve into atherosclerosis, but last I checked, and I'm sure Professor Mamarian would agree as a professor of cardiology, that fundamental to myocardial infarction is atherosclerosis. So I'm not sure how we can advocate for a pathway that includes imaging that provides no information about the extent and severity of the very disease that we need to explore and we need to treat to prevent incident myocardial infarction. Of course, CT is that test. It tells us not only that the patient has plaque, but where it is, what the morphology is. We will eventually, and not so far in the future, have quantitative tools that will allow us to quantify atherosclerosis. And finally, before I pivot to physiology, the other reason that CT clearly should be the first-line test for patients with suspected but not yet confirmed coronary disease in particular is that it guides medical management in a fashion that improves downstream outcomes. This is from the West Danish Heart Registry, over 60,000 patients. And what you can see here is that when patients are treated on the basis of the results of CT, they have a 30% lower MI rate than those patients who are treated on the basis of traditional stress testing. Importantly, and Dr. Mamarian may try to confuse you by saying, well, PET is so much better than SPECT. The stress test used in Denmark was largely PET imaging. So CT-guided medical therapy improves outcomes compared to medical therapy guided by PET. And it's not that PET and these stress tests don't play important roles and won't help answer other questions, but they shouldn't be used as upfront tests because they don't inform medical management because they provide no insight as to the extent and severity of plaque. Randomized data, perhaps you'd like to see 5-year outcomes from Scott Hart. Patients randomized to CT had a 40% lower MI rate and cardiovascular death rate than those randomized to traditional care. So CT uniquely identifies plaque. It is powerfully anatomically accurate. It is incredibly prognostic, and it actually allows you to personalize medicine, to titrate medical therapy, not based on the presence or absence of risk factors, but the presence or absence of disease, which enables a meaningful reduction in incident myocardial infarction. It is for these reasons that the ACC elevated CT with a class 1 level of evidence A support. So perhaps Dr. Mamarian hasn't read the guidelines, but they're very clear. And it is because CT is not only effective for the diagnosis of CAD, but it also risk stratifies and guides treatment decision-making. On the other hand, when we look at the guidance for functional testing, you can appreciate that the guidance is class 1 level of evidence B, but beyond that, if you initiate that pathway, regardless of the results, you end up in guideline-directed medical therapy because the guidelines are clear that stress testing informs diagnosis of ischemia and provides modest prognostication, but does not guide clinical decisions around need for ICA. So they would advocate, and perhaps Dr. Mamarian is, that you should start this way and then initiate guideline-directed medical therapy. But without knowledge of whether or not the patient has atherosclerosis, without knowledge as to whether or not the patient has left main disease, moderate to severely abnormal ischemia tests, we did CTs, we identified 6% of patients with left main disease. And yet this pathway leaves potentially patients with left main disease undiagnosed. It's unconscionable, in jest, of course. Finally, why FFRCT? We saw it was given a class 2A indication. And I think what we've learned over time is once we diagnose anatomical disease, the key to guiding decisions is then the need is physiology. It is simply put robust across all populations. It informs revascularization, FFR, IFR, by correlating the anatomical target and providing us an understanding of the impact of that target on physiology, enabling targeting of the specific lesion, and the patient will derive benefit from revascularization. We know that this can be provided in a single exam. That was first introduced over a decade ago and powerfully highlighted that physiology can be achieved with robust technology and can provide us physiology in a fashion that is superior to all other non-invasive tests as it relates to the invasive gold standard. Importantly, these data from the Pacific trial underplay the real opportunity. The opportunity is that the FFRCT provides you not only a binary diagnosis, whether the physiology is positive or negative, but actually quantifies the pressure and co-localizes the pressure to the anatomical target. That is what the interventionalist needs. The interventionalist doesn't need that there's possibly abnormal physiology in the LAD. She needs to know where the physiology is abnormal, how abnormal, and where and what is the translesional pressure loss. That can only be provided by FFRCT. As you can see, we can not only provide a binary diagnosis, but the depth of the physiology and phenotype the physiology to help guide the need for revascularization. So in closing, why would we also pursue this pathway? Because it impacts clinical decision-making. We know that stress testing does not inform catheterization in a meaningful way. We also know that stress testing doesn't inform revascularization in a meaningful way, as we saw from Leslie Shaw, published in American Heart Journal in 2012 from Courage, and also for that matter, the very ischemia trial, because global stress testing abnormalities don't inform the decisions around revascularization. On the other hand, we know that FFRCT consistently improves cath lab referral. It increases the PCI to ICA ratio and reduces negative ICA rates in a powerful way, with PCI ICA ratios exceeding 70% across multiple registries and in excess of 80% in some. We also know that this pathway is prognostically useful. We've seen that the depth of the physiology connotes an increased risk to the patient, and revascularization helps modify that risk. This is a recent meta-analysis published by Bjarne Norgard and Hart. Thousands of patients followed over time. FFRCT in a fashion similar to invasive FFR is powerfully prognostic. And finally, the reason I think that this pathway really should be the pathway is because the pathway that's being proposed with stress testing not only is not as helpful in diagnosis or in risk stratification, and certainly provides you no information around atherosclerosis or the need for revascularization, but ultimately the data that we're acquiring with CT could actually inform revascularization, just as we've seen in TAVR, providing meaningful opportunity to plan your intervention, which is impossible with any stress test. You can't look at a PET and say, I'm going to put in a 3mm stent, it's going to be this fluoroscopic angle. It provides you no information around planning intervention. And I think this pathway of sending patients to the cath lab on the basis of stress testing and clinical symptom adjudication leads to far too many patients going to the cath lab without coronary disease, and so many going with severe coronary disease without a plan for intervention. I think the future is to go with the diagnostic pathway of CT, FFRCT, with the anatomy, the plaque morphology, the fluoroscopic angles, the presence or absence of left main disease, and also a physiological roadmap as shown here in Syntax 2, which combines the anatomy and the physiology and provides the interventionist in advance of her cath an understanding of what she is going to be confronted with anatomically and physiologically. There is nothing from a stress testing pathway that can possibly compare to that. And I think herein lies a tremendous opportunity for our interventional colleagues and our patients to achieve more complete revascularization. So I think the future of cardiac CT is bright. I really am very grateful for the opportunity. I'm honored to be debating Dr. Mamarian, and I feel terribly that he would be given a position that is frankly indefensible. Thank you again.
Thank you, Dr. Leipsic. That was a tremendous dynamic presentation. However, I think your opponent in the debate is up to doing his job, Dr. John Mamarian from Houston Methodist, and he will take the con position.
Good morning, everyone. I'll be taking the other side of this debate in terms of promoting functional testing as the way to first assess patients with suspected coronary artery disease. And this is also based on what we see in the guidelines. If you look at stable symptomatic patients with suspected coronary disease, both appropriate use criteria as well as the most recent ACCHA guidelines promote both types of testing. Let's first talk about functional testing. This is myocardial perfusion imaging, which can look at perfusion, function, quantify the size of perfusion abnormalities. And in fact, with PET imaging, we can also assess myocardial flow reserve, which is incredibly important from a prognostic point of view. If you look at testing in terms of outcomes, you can see that with myocardial perfusion imaging, a normal perfusion study leads to a very low event rate in terms of death or MI. And in that way, it's a gatekeeper to invasive coronary angiography. Whereas in patients with an abnormal perfusion scan, you have about a 10-fold increase in event rates, and this predicts a bad outcome. It also turns out that the size of the perfusion defect matters, and there are many trials showing this, but this is from the INSPIRE investigators, showing that somewhere around a 15 to 20% total perfusion defect or a 10% ischemic perfusion defect, you see an inflection point with an increase in both total events as well as death and MI in such patients. This has also been shown in PET registries. If you look at cardiac death from Dorbola, 34% increase in cardiac death for every 10% increase in ischemic myocardium. And if you look at these data from K, looking at different genders, either men or women, you can see the same inflection point around 10 to 15%. Also in women, 10 to 15%. And similar to what we see in the INSPIRE study. Remember that invasive coronary angiography, CTA, and an abnormal FFR in a specific artery cannot predict the extent of jeopardized myocardium. Let's now look at how PET may guide therapy. These are some data from Tim Bateman's laboratory in some 16,000 patients, showing that if you have more than 5 to 10% ischemia, you do actually worse with medical therapy than you do with revascularization, whereas if you have smaller perfusion defects, you do better with medical therapy. These group of investigators have also looked at the value of myocardial blood flow reserve and have identified a cut point of 1.8, whereas if flow reserve goes below 1.8, revascularization is favored, whereas if flow goes above 1.8, medical therapy is favored. Incidentally, these cut points were not influenced by the extent of ischemia on the perfusion scans, and similar results were not only found for death, but also for cardiac death. Remember, neither CTA nor FFR can assess myocardial blood flow. Let's talk about CTA. There are many different types of scenarios you can see with the CTA scan. You can have a normal scan in which we reassure patients. You can have a mildly abnormal scan with non-obstructive disease where we recommend statins and aspirin therapy. You can have a moderate stenosis. These are borderline lesions where we usually do either CT-FFR or functional testing. And then you have patients with very severe disease or maybe uninterpretable studies due to extreme calcification, where really functional testing is the best way to assess these patients. And in fact, if you look at the different types of CT results, it's in this group where CTA becomes very problematic, and in the lower risk population with more normal studies where CTA is most effective. Let's look at outcome with CTA, and these are data from the confirmed registry in 24,000 patients, showing that mortality significantly increases based on the presence and extent of coronary disease. We've known this from many different studies in the past, but interestingly enough, even in the group with non-obstructive coronary disease, you can see a reduction in survival with this as compared to normal patients. Where does fractional flow reserve come in? Here's a patient with an RCA stenosis of 50 to 60%. You can see that the FFR value by CT is diminished, indicating that this is a functionally significant lesion. But there are problems with FFRCT. First of all, the rejection rates tend to be high, anywhere from 10 to 30%. Motion, suboptimal contrast enhancement, severe calcification are all problematic in terms of assessing these images. Stents and bypass grafts cannot be assessed, so these patients are eliminated from CT evaluation. And the turnaround time is variable, and the cost is actually 3 times that of a CT scan. So a lot of different issues. Where does the CT FFR compare with invasive FFR? And this is data from Norgard, showing there's a tremendous splay in the data. And these are actually a meta-analysis from Cook, showing that in patients with very low FFRs by CT, there's very high concordance with invasive FFR. In patients with very high values by CT, there's also good concordance. But in this gray zone of 0.7 to 0.9, you might as well flip a coin in terms of concordance. Not a very good test result. And unfortunately, most frequent FFR-CT values are in this gray zone. It's also true that outcomes and cost benefit with CT-FFR have not been demonstrated. In fact, Platform and Forecast, the most recent trial that was published, didn't show any benefit as compared to standard of care. And so maybe indeed SPECT imaging, and PET particularly, should be the way we go. The last thing I'd like to talk about is the use of functional testing versus CTA in randomized trials. This is the PROMISE study showing no benefit of anatomic testing versus functional testing. And what's interesting about PROMISE is that twice as many patients got revascularized in the CT arm versus the functional testing arm, and yet this did not translate into a reduction in event rates. This is true irrespective of what events you look at. The radiation exposure was higher with CT versus functional testing, and the cost was no different. The Scott-Hart trial was sort of a landmark study because it did show that CTA did better than standard of care with a 50% reduction in event rates. And remember, standard of care in this study was simply exercise treadmill testing. Although revascularization rates didn't change over the course of the trial, what did change was the initiation of different treatments such as antiplatelet drugs and statin therapy. And I think statin therapy is probably the key here, because if you look, for instance, at the confirmed registry data, in patients with normal coronary arteries, statins had no effect on outcome, and everyone had a pretty good outcome. But in patients with non-obstructive disease, in patients not on statins, the event rates were significantly higher as compared to those on statins. So the strength of cardiac CT is really identifying patients with normal coronary arteries, identifying those with non-obstructive coronary artery disease, and at an earlier stage than what we can possibly do with functional testing. So what is an alternative to CTA in patients without known coronary disease? One way we could approach this is to do calcium scoring after stress myocardial perfusion imaging to assess risk. These are data from EMBER in almost 5,000 symptomatic patients with suspected coronary disease. You can see that as the calcium score goes up, the rate of SPECT positivity increases dramatically. But what's most important is that in patients with a normal SPECT, the calcium score was abnormal in 69% of patients, and over 15% of patients had a severe calcium score. What we see in terms of event rates is that in normal SPECT studies, it was lower than in abnormal SPECT studies, but look at the value of calcium scoring in terms of predicting outcome. So in patients with a normal calcium score of 0, irrespective of the perfusion results, those patients had a good outcome. But as the calcium score increased in both groups, event rates increased proportionally. And so there appears to be value of integrating calcium scoring with stress myocardial perfusion imaging so that we can target individualized statin therapy based on the calcium score, and especially in those with normal myocardial perfusions results where this can be very complementary. The last thing I'm going to talk about is the ischemia trial. As you know, the ischemia trial randomized patients with moderate to severe ischemia to either interventional therapies versus optimal medical therapy, and there was no difference in outcome at 4 years. The ischemia trial, importantly, does not negate the importance of identifying and aggressively treating myocardial ischemia. And remember, this was based on functional imaging, not CTA, but it did demonstrate this could be accomplished with either initial aggressive anti-ischemic medical therapy alone or in conjunction with coronary revascularization. Now, some people have proposed using CT as a first-line test based on the ischemia results, but one has to remember that the ischemia population was a very high-risk population with moderate to severe ischemia, and even in that population, only 5% had ischemia, let alone in a broader, lower-risk population with only suspected coronary disease. So in conclusion, when we look at CT and we look at SPECT imaging, there are contraindications to doing CT. In patients with obesity, really PET is a better choice because of the poor contrast enhancement in those individuals. It's not indicated in patients with known disease unless you particularly want to look at patency of bypass grafts, but it can identify non-obstructive plaque. Remember, fractional flow reserve, the only thing it's been shown to do is reduce unnecessary invasive coronary angiography, and that's due to limitations in CTA itself, since the specificity of CTA is only around 50%. With regard to stress myocardial perfusion imaging, there are no contraindications. It provides assessment of rest and stress LV function. It provides assessment of epicardial microvascular circulation, particularly PET, and it can identify the ischemic burden. It may not identify non-obstructive plaque, but this is where hybrid imaging becomes important, integrating calcium scoring with myocardial perfusion imaging. Okay, so that ends this presentation, and I thank you very much for your attention.
Thank you, Dr. Mamarian. For the sake of time, we'll move directly on to the rebuttal. Dr. Leipsic.
Thank you. It was a real pleasure, obviously, to debate Dr. Mamarian, even if it was virtual, and it's a shame that it needed to be. But I think much of what John shared, and I'm sure similarly for I shouldn't speak for him, but I'm sure for him is similar to my presentation. I thought it was a very thoughtful discussion. I would want to highlight a couple of things, though. The Scott Hart data, which showed no differences in revascularization, I think belies the timing of the revascularization. I think the opportunity, if you delve into a paper published by David Newby in 2020, looking at the opportunity of CT, is that it allows you to have greater diagnostic certainty with regards to the diagnosis of coronary disease. A lot of the revascularization and the cath rates started to equalize within Scott Hart over time in the stress testing arm because of the uncertainty. Now, granted, it wasn't imaging-based stress testing, but those patients often would come in with unstable symptoms or even at non-ST segment elevation and needing revascularization. As it relates to PROMISE, I think what we learned from PROMISE is you shouldn't include an incredibly low-risk population, ideally, and you should also follow patients for longer time. I think that's a very important takeaway point that I'm sure John and I both agree on, and part of the guidelines is that, if you're testing patients with an incredibly low likelihood of coronary disease is ineffective. I still think we see some important signals around PROMISE, which highlight the need for the opportunities of CT. As it relates to the cost effectiveness of FFRCT, I would highlight that there has been a post hoc analysis of PROMISE done by Udo Hoffman's group published in JAMA Open, looking at the cost effectiveness of this pathway, suggesting at least modeled that it would be. The data from Forecast, which is a UK trial, showed 22% cath cancellation and a higher PCI to ICA ratio as compared to almost a conventional CT strategy, not compared to stress testing because they've very much moved away from that in the UK. It did not show cost reduction, but showed similar costs. And then finally, and we look forward to a randomized trial called PRECISE, which will tackle that. And the last thing I would want to address is just the Cook analysis. The Cook analysis is obviously one that's often discussed. The Cook analysis is now somewhat historic and included a meta-analysis of a number of accuracy studies, including studies that are that have never been with technologies that have never been FDA approved and are not used clinically. In fact, they had only included a single study that included a technology that was adopted clinically and FDA approved. And in that study, they didn't even have the raw data. As it relates to the agreement in the gray zone, what I would highlight is that that same group performed a similar analysis on FFR, Petracco et al. In JAK intervention, and highlighted across a binary cut point that across the coefficient of variation, you will have some instability, obviously, in agreement. But I think I would reflect on the actual agreement between FFRCT and FFR, the kappa coefficient, which is not perfect, as John pointed out, but it is hovers around 0.8, 0.82. So I think that in clinical practice, it has helped us, and as I tried to highlight, meaningfully inform additional need for revascularization in a fashion that not only augments the anatomical likelihood of disease, but of course, the likelihood of physiologically significant disease, allowing us to target the specific lesion, which of course, traditional stress testing does not allow you to do. What we know is medical therapy works for most patients, but it's really the patients with focal physiologically significant disease where PCI can modify downstream outcomes. And that, of course, is not available to us when we look at global testing. I'll stop there. I think that's enough out of me, but I really enjoyed the opportunity.
Okay. Thank you, Dr. Leipsic. Dr. Mamarian?
I didn't mute him. You're muted, John. I haven't played with your computer, I promise.
Okay, we're good now. I'll just, I mean, Jonathon, I agree with most of what you've said. As you know, we do 5,000 CTAs a year here. I mean, in fact, I'm reading a TAVR study right now as we're talking. But the bottom line is that I think, you know, some of the things that you brought up, for instance, the Pacific study, you know, if you look at actually the data from Pacific comparing CTA, PET was actually the best predictor in terms of diagnostic accuracy. And even if you look at the more recent publication in Pacific, it basically showed that if you use CT-FFR, PET was still best when you do an intention to diagnosis analysis, recognizing that some 20 to 25% of patients could not undergo proper analysis with FFRCT. In terms of the other arguments, I think, you know, it's really not fair to extrapolate data from clinical trials unless they've been done in a randomized fashion. And so a lot of these post hoc analyses are really not valid. If you really want to go forward, then there should be a prospective study to really look at these things. I'm going to share my slides just for 1 second here, if I can find the share screen. And that's good. And I'm going to, hold on 1 second. If I can open this up. I would just like to just share with you just a few slides. And, you know, I think, you know, a lot has been talked about FAME, and a lot has been talked about the issue of doing FFRCT and doing and the whole basis behind FFRCT behind FAME and its results. But you have to remember that in FAME, whether you look at FAME 1 or FAME 2, there was never any reduction in death or MI. It was all just a difference in urgent revascularization. And again, I get back to the issue of prognosis, because the whole idea of doing perfusion imaging is that you can actually quantify the extent of abnormality, which is a fundamental basis for how patients do long-term. You know, you've brought up ripcord, you've brought up different tests. Ripcord was actually an emulation of CT-FFR, but in the cath lab. And basically patients were randomized to invasive angiography versus FFR plus invasive angiography. And all of FFR was done in arteries greater than 30% stenosis, as what we would be doing a CT study. And basically what it showed was no change in cost, no change in quality of life, and in fact, no change in events. And this was a randomized trial. So I like to go with randomized data. So it failed.
You know, moderator, he's introducing new data that I can't rebut.
Well, I mean, this is off the presentation at the European.
Oh, I don't doubt that it's real, but it's new. You're continuing the debate.
Okay, haha. Isn't that a nice twist? Okay, and then Forecast was also a population of 1,400 patients with stable chest pain, primary endpoint resource utilization. You can see here that the endpoints were no different between using FFRCT versus CT alone, which was in the standard of care used most commonly. This was in terms of quality of life, no difference. The only difference, again, was this issue of less catheterization in the FFRCT arm versus standard of care. So the bottom line, addition of fractional flow reserve CT over standard of care did not lower costs, avoid MACE, reduce angina, or improve quality of life, but did reduce invasive coronary angiography by 5%. That's also a failure. Let me show a study that we just got published in JACC Imaging in 471 patients who had a clinically indicated CT and SPECT study, not PET, SPECT. Money had multiple risk factors. You can see that they had a nice variety of coronary artery disease, even 5% with left main or 3 vessel. You can see that in all categories of CAD-RAD, that FFRCT was more prevalently abnormal compared to SPECT. And in fact, 42% of people had an FFR less than 0.8 versus only 14% in SPECT. But when you look at outcomes, FFRCT, this is looking at total MACE, death and MI, no difference whether FFR was high or low. But look at SPECT, exactly what you see in other clinical trials. So ischemia predicts outcome. And when you look at overall MACE, same thing, no difference depending on a cut point of 0.8 with FFR. All the prognostic data was with SPECT. And in fact, if you look at a hazard ratio based on proportional hazards analysis, you can see that CT alone added to a model of just baseline clinical data, but FFR added nothing in terms of predicting death or MI. And in fact, all the value was in SPECT, adding SPECT to both obstructive disease by CT and also FFR. And when you look at MACE, the same thing. CT did very good at predicting outcome in terms of severity. FFR added nothing, and SPECT ischemia added to CTA and CTA plus FFR. So I'm going to stop on those notes. I think we have a lot more that we need to do in terms of how we assess and use different therapies and treatments and diagnostic testing. And I really behoove the SCCT societies and CT investigators to really do more prospective randomized trials to get the answers that are needed to move forward.
I want to thank you both. That was an outstanding discussion. I know we're a couple minutes behind, but Dr. Leipsic is not going to be at the lunch discussion. And one of the points I wanted to make up, and John, you can answer it, or Jonathon can answer it now, is since half of the patients who were in the CT arm of Scott-Hart had a stress test, don't they really have combined functional anatomic assessment?
So I think two things. First, I would say I see now how we debate in Texas. We continue the debate with slides after the debate is done, but that's okay. That's all right. It's sort of like a 10-pace draw or whatever, but turning at 8. But that's, at least I know who I'm debating there, Dr. Mamarian. No, I'm joking. The final question about randomized trials, I mean, that one I have to say is really quite funny because I've not seen a randomized trial in nuclear cardiology in, I don't know. Well, actually, maybe just I've never seen one. But as far as CT, for sure, we need randomized trials. There is the PRECISE trial, which is randomized 2,100 patients and will be presented. And there are also, of course, other randomized trials that are coming. As it relates to the functional testing, I think you raise a really important point. And that's why I don't think that obviously exercise capacity and exercise tolerance is an important aspect. And I'm looking at that in the ischemia trial, whether or not it's incremental to the anatomical data, because we saw very clearly that the extent and severity of the stress testing abnormality in the ischemia trial exhibited no relationship with mortality. I mean, Dr. Mamarian talks about outcomes in his data at 18 months. That's, clearly not long enough. And I would just highlight in FAME, in fact, MI was lower amongst those with positive physiology who are revascularized. So now I'm continuing the debate as well. I will close with you. I think you highlight a very important point about Scott Hart. I think the treadmill plays a continued important role, or any exercise test will still play an important role.
All right,
yeah,
good.
Okay. Let me just say one other thing, David. Jonathan, it was really a pleasure debating you, and really we're not that much different in terms of our opinions, or in terms of what our thought processes are. And I guess that's true, because basically, we do a lot of CT here, as as well as other types of imaging modalities, and we're pretty much on the same plane.
Yeah, for sure.
Let's move on, and thank you both.
Thank you.
So in my discussion, in the earlier session, I really restricted my discussion primarily to SPECT, and that's because we have the privilege to have Dr. Mouaz Al-Mallah, who is head of the PET program at Houston Methodist, talk today now about PET CT and coronary artery disease. Should it replace SPECT?
All right, thanks for the kind introduction, and I'm tasked to present to you today about cardiac PET and would it replace cardiac SPECT imaging for coronary artery disease. These are my disclosures, and they are not related specifically to this talk. Okay, why cardiac PET? So cardiac PET provides a lot of advantages. So in addition to assessment of relative perfusion, like we do in SPECT imaging, we can also assess multiple additional parameters that increases our accuracy for the assessment of coronary artery disease. We can concomitantly measure the peak left ventricular ejection fraction at stress. We can also measure the absolute myocardial blood flow. We can do coronary calcium scoring, because most of these systems are hybrid systems, and even some select cases you might be able to do coronary CT angiography, because many of these are high-end CTs that are attached to the PET systems. So why cardiac PET? Well, first of all, it's the most accurate non-invasive test for the detection of coronary artery disease. This is data from multiple meta-analysis comparing SPECT, CMR, and PET. And you can see here that PET had the highest area under the curve, the highest accuracy, mainly compared to SPECT. And another meta-analysis published almost the same year in another journal, and also showing the same findings, where PET accuracy is higher than the overall SPECT accuracy. However, these studies included different patients, so it's not the same patient undergoing SPECT and PET. However, there is in the literature one study where patients underwent multiple imaging modalities, CT, FFRCT, PET and SPECT, as well as invasive coronary angiography and invasive FFR was used as a gold standard in these cases. And what you see here, the area under the curve for PET was the highest accuracy. So PET, when including the entire cohort of 208 patients in the Pacific trial, it clearly shows that PET had the highest accuracy. When they did CT-FFR in a subset of these patients, you can see that looking at the accuracy of cardiac PET, that it has the highest accuracy using invasive FFR as the diagnostic gold standard in these cases. Now, what else we gain from doing PET? We get excellent image quality. And as you know, as a patient body habitus changes, it becomes more difficult to get good image quality in some cases, sometimes. And you see here, this is a patient with a BMI of 43, which is commonly seen in our labs. And you can see that the attenuation correction, non-attenuation correction images on SPECT are not very good. They improve with attenuation correction, but in the same patient, the PET, rubidium PET, is much better image, provides much better image quality, and is much easily interpreted in this patient. Now, if we look at some patients with bariatric indications, for example. You can see here that this is an image quality of a patient who was referred for bariatric surgery, and you can see the BMI is 62, and the patient has excellent image quality. You will not be able to achieve this image quality in other patients using other modalities. What about additional advantages? We assess coronary artery calcium score routinely with these patients, and despite all of these advantages, cardiac PET has the lowest radiation exposure compared to other imaging modalities. And this is data you can see here, even using traditional PET scans, not the digital newer ones. And you can see that cardiac PET with rubidium or ammonia has very low radiation. Now, even we've slashed these numbers into half or sometimes even 1/3 by using a digital PET scan, which allows us even to inject much lower doses. And now in our lab, for example, we routinely do sub-millisievert cardiac PET, where we inject only 10 millicuries of rubidium, which is less than 0.5 millisievert for rest and another 0.5 for stress. And you can see here the different radio tracers that we use, and many of them have a very short half-life. So that's one of the reasons we have a very low radiation, because many of these radio tracers, especially rubidium, are very short-lived. So even though they're higher energy, they're only short-lived for seconds and minutes, like an ammonia. And we can provide important prognostic information for these patients. And this is one of the strengths of nuclear cardiology, that we are able to predict patients who are at a higher risk. And those patients with normal perfusion has the lowest risk, and there is a graded increase in the risk of patients as the amount of jeopardized myocardium increases, as you see in this study. But more notably with cardiac PET is that we can assess myocardial blood flow and coronary flow reserve. This has significant, important diagnostic information, and this comes as free tool now. So you don't need to expose the patient to additional radiation. It's primarily processing of images that you acquire during imaging, and it allows us to enhance our diagnostic accuracy. So in patients who have normal myocardial blood flow reserve, the chance of having obstructive coronary disease is very low, less than 3% in this study, but also allows us to determine patients at higher risk, even in the absence of perfusion defects. So among those patients without ischemia, those with low myocardial blood flow and myocardial blood flow reserve has a worse outcome long-term compared to those who have normal blood flow. And this increases as the amount of ischemia increases, but we maintain this graded increase in risk as the myocardial blood flow decreases. And there is now new data, even in large cohorts, more than 12,000 patients, suggesting that we are able to prognosticate and guide management in these patients. So those patients with lower MFR or low myocardial blood flow reserve would benefit from revascularization, while those without low MFR could be managed medically without an increased hazard of cardiac death or myocardial infarction. And we can do also other indications, like, for example, many patients with lower ejection fraction may require additional imaging for assessment of viability and other indications. So we are able to provide multiple assessments of these patients while they're coming to the lab, looking at it from different angles, looking at it from the perfusion part, looking at it from the anatomical part and atherosclerosis burden, but also looking at it from a prognostic value and trying to guide management in these patients. So with all these indications, would PET replace SPECT? And I would say that there is significant improvements with PET. And if you upgrade from SPECT to PET, you'll see a lot of newer advantages. However, I think overall there is not enough installed capacity that will allow us to do everybody by PET. And there are some newer patients who are being managed by or imaged by other imaging modalities. But I think it is very important to keep in mind that SPECT also have its own advantages, including exercise testing, which is not possible by PET. And because of all the advantages with PET, there have been significant adoption in clinical practice. This is data just came out a few months ago in Radiology Cardiothoracic Imaging, looking at cardiac imaging trends in Medicare population. And that includes data before the pandemic till 2019. And you can see here that SPECT got a little bit of a hit with little decrease in terms of number of studies because many patients are appropriately either not tested or being shifted to other imaging modalities. And there are increases seen in other imaging modalities, namely CT, MRI, but the biggest increase is being seen with cardiac PET because this is a modality that provides you with multiple additional advantages and diagnostic capabilities. So for SPECT, if it is going to survive, what do we need to do? I think for SPECT to survive, we need to provide better specificity and less artifacts. So we need to adopt attenuation correction for these patients, especially in obese patients, patients with motion and a lot of changes in body habitus that might impact the image quality. We need to have a better assessment of extent of atherosclerosis. It is the extent of atherosclerosis that will determine outcomes on the long term. And with nuclear cardiology, we can easily acquire that information using a calcium score on our SPECT CT and PET CT machines. So that will help you identify the higher risk patients who even could potentially have normal perfusion on SPECT imaging. And finally, we need to utilize lower dose protocols. We cannot continue to use higher dose protocols. And I think the nuclear cardiology community has adopted newer techniques, including stress-only images. There are newer cameras that allows you to use lower doses. But also, we need to do more in these cases where we do more of stress-only imaging, so we are able to get our SPECT doses to less than 5 millisievert, as professional societies have been trying to do for the past few years. So in short, I'm going to leave you with the advantages of cardiac PET, because you will gain a lot by moving from SPECT to PET, and in many patients, PET provides additional information that may not be able or may not be available using other imaging modalities. Thank you very much for your attention.
Thank you very much, Mouaz. Excellent discussion. Our next speaker really needs no introduction. Dr. Miguel Quinones is going to be talking about, is there a role for stress echo in the area of CCTA, PET, and SPECT?
Good morning. I hope you're all enjoying the course so far. And this morning we have been discussing the role of coronary CT angiography, SPECT, and PET scanning in assessing patients with coronary artery disease. And the discussion have shown a lot of excitement and sophistication of this new technology, which makes us ask the question whether there is still any role for stress echo, which is a more simple and older technique. In fact, stress echocardiography has been around for 4 decades. This is the first publication that we had validating the technique in our laboratory, and it was published in 1983. 73 patients were studied, all with coronary angiography. And in that smaller group, we had sensitivity of 91% and a specificity of 88 in detecting significant coronary artery lesions. In 1992, we published a study of 289 patients that had simultaneous stress echo, and nuclear SPECT thallium. And in that group, there was an 88% agreement between the two techniques in differentiating normal from patients with coronary artery disease. And in the subgroup of 11 and 12 patients that underwent coronary angiography, the sensitivity and specificity were very similar for both tests. Also, we observed that patients with one vessel disease and stenosis of less than 70% had much lower sensitivity, an observation that has been shown many times in other publications. As the patients were followed over the years, in 1998, we published the ability of both tests in predicting cardiovascular events. And as you can see in this slide, they were exactly the same. Patients with no ischemia or minimal changes by nuclear and or echo had excellent 5-year event-free survival versus those that had significant ischemia or significant wall motion changes with exercise. Multiple publications have shown similar results. And in 1998, there was a meta-analysis of both echo and nuclear showing, again, similar results for both. So if we summarize the 3 to 4 decades of research in this area, a couple of statements are factual. One is exercise echo is an accurate test for detection of ischemia and coronary artery disease. The accuracy of stress echo, however, does depend on the expertise of sonographers and in the interpreting physician. That it was true 40 years ago, it is true today. Also, the accuracy of stress echo is limited in patients that have left bundle branch block and in those with depressed resting EF and or abnormal resting wall motion, because you're trying to find new changes in wall motion abnormalities with the exercise. And in these cases, dobutamine might be superior to exercise. However, overall, dobutamine stress echo is less sensitive than exercise echo and than the nuclear techniques. And there are more side effects, more arrhythmias, so that in my own personal opinion and my own practice, it's rarely that I will order a dobutamine stress echo, because most of the time it's not worth the expense and risk when we have excellent technology with SPECT, PET, and or CTA to assess these patients. Again, the exception might be selected people with LV dysfunction in whom we are looking for hibernation, and of course, patients with aortic stenosis where we're looking for the effect of dobutamine on the gradient. If the patient can exercise, do an exercise echo. It's what I think it's the best option. And don't forget to consider supine bicycle stress. That's a simple test that is done in a supine bicycle ergometer. It's comfortable for the patient and it's comfortable for the sonographer. The test allows us to look at resting wall motion during low levels of exercise and at peak exercise. And as can be seen in this patient, we can easily detect a drop in EF and changes in wall motion, particularly the lateral wall, when compared to the low level of stress. The accuracy of this test was checked back in the 90s, and a publication in 1999 from our lab in 67 patients with coronary angiography showed very similar statistics for sensitivity and specificity between bicycle and the post-treadmill technique, both techniques done in the same patient. Another advantage of the bicycle is that it is easier on sonographers. It's also easier on elderly patients. They feel more secure. They don't have the fear of falling from the treadmill. And it's a very good test to assess patients with dyspnea on exertion, since we can look for ischemia, changes in ejection fraction, but also we can assess diastolic function, feeling pressures with exercise, and estimate PA pressures with exercise. So let's look at some scenarios. First is the scenario where somebody has no symptoms, but they have some risk for coronary disease, and you're trying to assess the risk of these patients. So it's silent CAD disease detection. And in this type of situation, the calcium score, as we heard earlier this morning, is superior to any stress testing, given that stress tests will only pick up lesions that are significant, usually more than 70%. So somebody may have a lot of plaques that can put them in risk for something in 5 years and yet not be picked up by a stress test. So the calcium score will pick up disease, particularly in people who are middle-aged or older. And those who have a score of over 400 have about a 1/3 incidence of ischemia. So therefore, there is a 2B recommendation in that subgroup to do a stress test. And therefore, we have these choices: regular treatment with EKG, stress echo, or the nuclear techniques. And to be honest, the exercise ECG has only a 70% sensitivity and specificity. And when you're trying to now go to the real level of ischemia detection, I personally would use one of these three. But if the patient can exercise, I think exercise echo is the most cost-effective and accurate technique to assess the patient. There's no radiation. It has comparable accuracy to SPECT. It is faster to do and cheaper. Now, patients with calcium score less are treated medically in an aggressive prevention measures. Now, some people may be a little bit uncomfortable with using 400. Some people may want to use 300, 250. I mean, there's a little bit of room for wiggle room here, but this is what the guidelines do recommend. Coronary CT angio or catheterization only should be done when ischemia is demonstrated. Jumping from a calcium score to a cath, I think, is not a good option. It has been shown to be fraught with all kinds of potential errors in management. Now let's look at a patient with chest pain. So we have a patient that is middle-aged or older, comes in with a typical chest pain and have a low to mid pretest probability. In this patient, yes, we could do a stress test, but actually a calcium score is not a bad option. If the score is 0 in a person that is 50 years old or older, excellent chance that there is no disease at all. The score is positive, however, at any level of positivity with symptoms, I personally will look for ischemia with a stress test. And again, we have the choices of doing any one of these. If the patient can exercise, I think a stress echo is a very cost-effective way of managing them and so forth. Now let's take a patient that is younger than 50, but with very typical symptoms suggesting angina or a lot of risk factors. Likewise, a patient that is a little older, but has a lot of risk factors, for example, diabetes, and comes in with chest pain. In this kind of patient, I prefer personally to go straight to looking for ischemia. And if the ischemia, if we see no ischemia, then we could do a calcium score at a later time looking for mild disease that would still require aggressive prevention. Now, one alternative is to also go to a coronary CT angiogram. If we look for ischemia first, again, stress echo is an excellent approach if the patient is in good health otherwise and can exercise. If they cannot exercise, obviously nuclear techniques are the way to go, and those with morbid obesity are better candidates for PET. Now, if you decide to go straight to a coronary CTA in that patient, if the test is negative, great. You have you've taken care of that, of not excluding disease. But if it's abnormal, I think it's still a good idea to either look for ischemia or do a coronary reserve assessment. The reason for that is that coronary CT angiogram still has the problem that it may overestimate lesion severity, so that sometimes you get in trouble going straight to cath and trying to then decide what to do. So I think it's better in terms of management to document that there is either abnormal coronary reserve or ischemia. Again, you have the choices, and stress echo is still a very good choice in a patient that can exercise. Now, this is a common scenario. Patients are known to have coronary artery disease, and the question you're trying to answer is you want to do some re-stratification, for example, 5 years after PCI, or they come in now with new onset of chest pain. In that situation, I think looking for ischemia is frequently the way to go. and we have the same choices. Patient can exercise echo is a very good option. Again, less accurate if they have abnormal resting wall motion. If they cannot exercise, these techniques are superb. Now, if the test is negative or they show stable findings, we go with continuing medical treatment. If positive, then we may have to decide to do a coronary CTA or angiography, invasive angiography, depending on the individual case. Some people may take that patient straight to an angiogram, either with a CTA or a cath, which is okay, except that sometimes the chest pain might not be necessarily angina, might be of a non-cardiac etiology, so that if you find negative or stable results, that's fine. You can continue medical therapy. But if you find some lesions, now the question comes in, do I intervene or not? And again, I think that a coronary reserve assessment or an ischemia assessment is a good way to go. In fact, in our lab, not uncommonly, we have patients coming for a nuclear stress test after they have had a cath because the cardiologist still wants to know about ischemia. These choices are the same. Patient is able to exercise echo is still a good option versus the other one, particularly when they cannot exercise. So in summary, stress echo is here, still here to stay. He has passed the test of time and is best used when looking for ischemia in patients capable of exercising who have normal wall motion at rest and no left bundle branch block. SPECT, PET, and CTA are excellent, but they are actually the best for patients who cannot exercise and definitely for those with left bundle branch block, resting wall motion abnormalities. In fact, sometimes in this type of patients, we might even consider a PET scanning because the SPECT may have some issues with left bundle branch block. Another option is to go straight to coronary CT angiography, particularly if it's a new onset of chest pain and you want trying to exclude disease. If CTA is done as a first option and is abnormal, consider an evaluation for ischemia or assessing coronary reserve before making decisions for intervention. Thank you very much for your attention.
Thank you very, very much, Dr. Quinones. We're going to have some cases that are presented by Dr. Mamarian and Dr. Al-Mallah in just a couple of minutes, but there are some questions from the audience. Dr. Zoghbi, I think it's easier for you to ask them because they're coming and going from my screen.
Okay. I will go ahead and do that. Can you hear me?
Yes.
Wonderful. First one is for Dr. Quinones. Do you do exercise stress echo without contrast?
Yes and no. So we have actually looked at that and published on that. Dr. Zoghbi actually had an excellent publication in that topic. And if somebody has excellent images at rest, chances are they will have excellent images with stress, and therefore we do not recommend contrast. In our population, often it's the case that the resting images has at least 2 or 3 more segments that don't visualize well. In that case, we will use contrast. Altogether, I would say that we use contrast in about 1/3 or 40% of stress echoes.
Another question for regarding the ischemia trial, so that could go to any of you really, is that one issue with the secondary analysis of ischemia is that the patient selection included moderate to severe ischemia, meaning the possible range of ischemia is smaller than the potential range for coronary anatomy. This is really a sub-analysis and needs to be interpreted with caution. Your comments on it?
Yeah, so Dr. Zoghbi, whoever put this question in is really very bright. I totally agree with this analysis. I mean, the problem with the Reynolds paper is that indeed it's very hard to see a difference with a small, when you have basically ischemia that's in a very narrow range to be able to, whereas with CT angiography it was from normal to severely abnormal. So I totally agree with that analysis.
If I may add one thing here, I mean, patients, the inclusion criteria for the trial was moderate to severe ischemia. Sure, some patients slipped in, but they were called by the lab, local lab, as moderate to severe. I will give an analogy. If you do a study with very low ejection fraction, so everybody has low ejection fraction. Ejection fraction is not going to predict outcome. If you do a study in elderly patients, everybody is going to be 75 or above. Age is not going to be predicting outcome because everybody has this. Ischemia is not the right population to compare ischemia to CT. If you want to do that, look at either at PROMISE or do a study where bring patients with obstructive disease on CT and you do ischemia, then obstructive disease is going to drop out of the equation. So I think there's basic flaw with that population studied. I wrote a rebuttal on this in JCCT where I explained like the problems with that analysis, which always being quoted as a comparison between CT and ischemia testing, which is not the reality here.
Yeah, well, I think you have to keep that in mind definitely going forward, analyze each trial and see which population is the inclusion criteria population in it. Question regarding CT. With this new CT data, how much time does the patient spend in a medical facility to know whether they have coronary disease? Basically, if somebody comes in with chest pain and you're doing a stress nuclear versus a CT, etc., does the data that was shown before regarding the fastness with which you get a result, or is that still relevant, meaning CT is a little faster than a stress nuclear or stress study?
Okay, well, that's a very good question, and I can tell you that we actually have published data on patients going through the observation unit who come in with acute chest pain. And that published data actually showed that if you look at SPECT imaging versus CT, there's really no difference in time to diagnosis with one or the other. And that's because a lot of those patients get stress-only imaging. They get stress first, and if it's normal, they're done. And with CT, sometimes it takes longer just in terms of the interpretation of the study. So there's pros and cons to both, but they're pretty equivalent, either one or the other.
Okay. And also it depends who you have and how often do you have it, particularly in an emergency kind of department, and when can you do the test, right? The other question is regarding CMR. I know Michael Salerno mentioned some of that in the first session today, but the person wanted to address the question about stress CMR, right? It was not discussed in depth, if you will. And can we mention that in relation to the other stress testing modalities?
So I'll take this one. I mean, stress CMR is a very valid modality. I mean, there's a lot of data to support it now in multiple centers and multi-center fashion, even from the US. In the SPINS trial, it has a good spatial resolution. The data also, the randomized trial, especially the MR-informed trial, shows that from a management point, it is equivalent to invasive FFR for clinical decision making. The main limitations of this modality is that, there are a few limitations. The first one is the availability in the US. In Europe, it's widely available, but in the US, it's not available at every center. There are some patients who cannot tolerate MRI. Either renal failure or patients with devices, you might have some image quality, although we do these, but sometimes the image quality may not be the best compared to patients without image devices. I think also comparable to our discussion about the atherosclerosis burden, it's difficult by CMR's perfusion to assess atherosclerotic burden. Like in nuclear cardiology, you can add a CT calcium score unless you do a separate calcium score when you do CMR. And finally, now there is data that's coming out looking at perfusion quantification by CMR and the ability to do flow reserve. I think that will be a big plus for CMR if it becomes routine, and this will be helpful for wider adoption. But I think the availability remains an issue in the US.
A question for you clinicians. I know Dr. Nasser hasn't joined us here, but regarding aspirin use and a calcium score. And two questions regarding that is, what is your threshold for using aspirin in relation to a calcium score? Somebody has coronary disease. Is it above 100 or above 10?
Definitely not 10. I would say that based on the data, it's closer to the 300. This is where you get benefit more. And obviously you have to factor in the age of the patient and other atherosclerotic risk factors there. But 10 is too low really to start aspirin. Maybe consider lowering their LDL and statin and put them on statin therapy. But even statin at 10 may not be extremely helpful.
That was a very good paper in JACC about 6 months ago, looking just at that, where they have the established number needed to harm, and they figured out in each category based on age and calcium score, the number needed to benefit. And when the number needed to benefit was greater than the number needed to harm, that's where the recommendation was. And for most groups it was around a calcium score of 100, although it was much stronger with a calcium score of 300 to 400, as Mouaz said.
All right, another clinical question.
Coming from Miguel Casiano, who's like in our group here.
Another clinical question regarding also treatment. And 50-year-old female with a high HDL of 80 and an LP little a though of 180 with a calcium score of 0. PCP wants to treat with statins because of elevated LP little a, but she has also no family history. What's your approach?
Well, I can take this one. I think that first of all, the HDL is irrelevant. It really has no major value in terms of assessing risk one way or another. The LP little a obviously is high. The calcium score, though, is a much better predictor. And what we usually do with these patients, we don't start them on statins. I really would like to know what the LDL. If the LDL is like 300, then maybe that's a different story. But generally speaking, in patients with a calcium score of 0, their progression of disease is extremely low. And what we usually recommend in those patients is to get another calcium score. And if you're diabetic, 3 to 4 years. If you're non-diabetic, 4 to 5 years.
Wonderful. David, I think we have probably 15 minutes for some cases.
Okay.
15, 20 minutes.
Mouaz, do you have some cases?
Yes.
Okay.
So I will be presenting the cases and will use the wisdom of the panel to help me through this. Do you see my slides?
Yes.
Okay, so I'll show you some cases, and I really selected some potentially controversial cases. I was hoping Jonathon would be with us to kind of shed some light on what we potentially do and not do for these cases. But so the first patient is an 81-year-old lady. She's coming in with chest pain and pre-op evaluation. She has hypertension. She's already been treated, and her BMI is low, so not a metabolic syndrome. We start our PET scan with a calcium score, and this is the reason she's going for surgery. She has a very calcified implant, and they're going to do a long, 6 to 8 hour surgery. And we started with the calcium score, Dr. Miriam, and we got a 2,941. The question, first of all, is PET the way to go, or you would consider other imaging modality in her?
Yeah, no, I mean, obviously, in someone with a calcium score of that high, you're not going to do a CTA, that's for sure. That would be a waste of money. So it would be a functional test. And I think in someone this age, a pharmacologic test would be the way to go. And so, I would really go with a regadenoson PET study.
Okay. So we did that. We have nice perfusion images, as you see here, no perfusion defect, and you have good ejection fraction reserve, more than 10%. You have excellent flows. At rest, it was like 1.4, went up to 4.3 with a reserve of 3. Are you satisfied, John, with despite this high calcium score, or you would like to get more testing? Because her calcium score, we might be still dealing with. So how good is the data I showed you? Normal EKG, by the way, normal perfusion, normal ejection fraction reserve, and excellent flow data.
Okay, so actually, this lady, you said, did you say this lady had diabetes or not?
No diabetes, just
no diabetes. But I mean, I guess the issue is this: we know that someone with a calcium score that high, their long-term risk is high. We know that. Yes. But we also know that in patients with normal perfusion scans, and this is with SPECT and also with PET, there have been several studies, especially in view of the marked augmentation in flow in all vascular territories, that this patient has low short-term risk for cardiac events. So I would say that based on these data, I would clear her for a surgical procedure.
All right. Well, just because to stir some controversy, her referring physician was very concerned about that high calcium score. And this is from the early days we started our PET program here. People didn't have much experience with the flow data. I was like, with this calcium score, you could be having balance ischemia. I'm just going to get a coronary angiography. And sure enough, she did undergo that. She has a mild lesion in the RCA. They did IFR of 0.96. She had a mild lesion in the LAD. I mean, obviously she has atherosclerosis and her IFR is 1. So this case, primarily, I wanted to show that PET can definitely work very well in patients, especially myocardial blood flow with very high calcium score, and compared to invasive FFR, and that really confirms that we can exclude coronary disease based on perfusion, but also adding the myocardial blood flow.
Yeah, no, I totally agree. I mean, the myocardial blood flow reserve addition is really pivotal. And, you and I both talked about this, but I think, in terms of diagnostic tests, PET still trumps basically all of them in terms of diagnostic accuracy. So yeah, I would have definitely cleared this patient for surgery without going to angiography.
All right. Okay. Next.
Can I just add one thing that I think is important in there? And it's important particularly for primary care doctors, is a mention of symptoms and functional capacity. If somebody can walk, 80 years old and are active and has no history of angina, that certainly makes you more comfortable in clearing her despite the calcium score.
Yeah, that's a very important point too. All right, so the second patient is your clinic patient, Dr. Mameri. She's 15.
Oh, gee.
Yep, I did look at your clinic schedule. She's coming to you with intermittent chest pain. 3 years ago, you did a coronary CT angiography. She had some calcium, but no obstructive disease. And you saw the lipid profile was elevated, so you did treat her very well. And her LDL, when she came to you, is 37. And I have to say, Dr. Mamerian is probably very aggressive on his LDL treatment among patients with subclinical atherosclerosis. So now she is coming for some intermittent chest pain. Her BMI is 30. And what would be your second appropriate study, and at this time, based on the clinical information and the clinical risk profile now?
So, I mean, there are many ways to do this, right? I mean, she had non-obstructive disease on her prior CTA 3 years ago, and I mean, there's 2 ways to approach this. I mean, she has atypical symptoms. It could be either to do and again, I would say either an exercise or pharmacologic PET study, or to do another CTA and ensure that she hasn't had progression of disease.
This is what the guidelines now say, that if you have non-obstructive disease and patient come in with new symptoms or worsening of symptoms, you get another CT. So let's study it on an unequal 1 case here. And maybe David, if you have any other thoughts, please jump in. So you did send her for coronary CT, you get excellent image quality, you can see the quality of the scan, there's no doubt about it. And these are her coronaries. The RCA doesn't have anything significant, maybe some plaquing here and there. The LAD clearly has the calcified plaque, which is a little bit more than what it was on the first scan, and the circumflex looks clean. And the concern was this spot just before the calcified plaque. So if I'm to present it here on Zoom panel, you can see the calcified plaque there. There is clearly no stenosis from that one. I hope you agree with me, John. Yeah. You see this spot here, which kind of made everybody concerned. What is this? I mean, is this a plaque? Is this a motion? So you did do some.
Well, can I say one thing? To me, that looks like artifact.
Well, okay. And you did actually take some views, like on orthogonal views, try to look at it from different planes, and you don't see anything there. So the question to you is like, what do you want to do now? You just call it artifact, or send it to FFR, or what do you do?
Well, I mean, I guess the issue is this. I mean, to me, it looks like artifact because if you look, that dark area goes across the entire artery, which is not typical of coronary artery disease. But since we have FFR available, I would send it for FFR.
All right, you did that, and this is a CT FFR data. So now what do you want to do? And this is not like a borderline case. There's clearly a hinge point, and you see that this is where the curve where the calcium is, and this is just at that spot. And from 0.99 to less than 0.5. This is not the kind of the gradual drop we talk about. This is just a very focal drop at that point.
You know, I agree. It's not the typical FFRCT I was talking about during my lecture, where you have that borderline gray zone of 0.7 to 0.9. This is a marked reduction in flow, and as you say, it's directly after what appeared to be a lesion.
So just to refresh everyone's memory, I mean, this is the point where we're talking about, and this is where the FFR dropped from here to here, very significant. So what do you want to do now?
So now it's a question of, is that really an ischemic lesion or is it not?
And obviously taking her to the cath lab is one option, and the second option is, if I remember correctly, she didn't want to go to the cath lab, and you did a PET perfusion on her, and perfusion images look normal.
Agree.
Ejection fraction went up 6%, so you do have no regional wall motion abnormality, and your hyperemic myocardial blood flow data is you got a 2.5 increase, and the best increase was even in the LAD. There.
Yeah. So obviously this is very reassuring, and remember that there was some motion artifact on this particular CT. And as I said in my talk, the problem with FFRCT is that unless you have a relatively perfect study, you can get a lot of misreads on the FFRCT. And so I do believe that dark area going across that lesion was probably more due to motion artifact, because lesions don't go across entire arteries. And the FFRCT unfortunately picked that up because it was a motion artifact, and it was just a problem with how the data are calculated by FFRCT. So the PET study is extremely reassuring, and I would say that continue on treatment of hyperlipidemia, etc., but very reassuring regarding the chest pain symptoms.
Yeah, so this is one of the areas, like if you have an artifact on the CT FFR is not going to bail you out, and you probably need some additional. If you don't believe the CT information, additional testing is often needed.
So, Dr. Al-Mallah, maybe I should have gotten a PET study to begin with.
Well, according to unequal one, that guideline algorithm.
I know the guidelines. I know.
right. So the third case, and I'll make it quick here to stay on time. We have a 6-year-old, hypertension, hypercholesterolemic, obesity, BMI of 38, hyperthyroidism, presenting with chest pain and shortness of breath. You want to do CT or functional testing?
BMI of 38, I would not do a CT. Because unfortunately the contrast enhancement is going to be markedly reduced in someone with a BMI of 38.
Okay, so you did send not you, the referring physician sent the patient for functional testing. It was a PET scan, and we have excellent image quality despite the BMI, a clear ischemic defect in the inferolateral wall, and another defect in the apex itself. So the apical segments and inferolateral, so pointing to potentially to vessel disease, at least ischemic defect.
So I would also say that this is rather impressive because it's RCA and possibly circ or a dominant circ or dominant right with a big PL branch, and it may even be LAD with that apical involvement, right?
I would argue that this could be triple vessel disease, maybe
exactly.
LAD.
Multi-vessel disease, yes, it's multiple patterns. There is a small, probably infarct in the circ territory, although we didn't do viability here. But yeah, there's a lot of ischemia in both RCA/circumflex and LAD. And the ejection fraction at least stayed the same. Didn't drop. He had positive EKG changes with vasodilator, and these are the flows. Flow at peak didn't go up much, and you can see the overall myocardial blood flow 1.5. So that's pretty concerning overall. So the biggest question that always come up: can we treat this patient as an ischemia patient? Do you want to treat him according to the ischemia, do a CTA, and there is no left main, treat him medically?
Okay, well, I mean, this particular patient has multiple risk factors. I'm sorry, what was his ejection fraction?
It was 56%.
56%. So that's, and is he having symptoms of angina?
He is having some chest pain and shortness of breath. That was an indication for the study.
Well, first of all, I wouldn't do a CTA to assess his left main and be done with it. I think in someone like this, based on the size of the perfusion abnormality, I would do an invasive angiogram.
Yeah, and you have to remember that ischemia doesn't say you should revascularize. It says shared decision making.
Exactly.
Benefits of revascularization versus optimal medical therapy. I think, one of the things when I showed the data on risk factor modification, I think if somebody is not going to cooperate in risk factor modification, the efficacy of revascularization may be less effective than if they were going to cooperate. And so you have to take all that into account when you look at the patient.
Absolutely. No, okay, so this is the calcium score that we did at the time of the PET scan, and you can see a ton of calcium in the left main, LAD, circ, and RCA. I'm not showing you all of it, but his calcium score came back to be 2,667. You still don't want to do a CTA, Dr. Mamarian?
Well, I didn't want to do a CTA to begin with because of his obesity. I mean, 38 would have been very difficult to really assess the images anyway, and I certainly wouldn't do it now.
All right. Well, the referring physician wanted to go the ischemia route, and here's the CTA. And this day. So
I hope I didn't read this.
How do you want to read it? The RCA is totally occluded in the proximal segment. And there is some calcium in the left main. The circumflex have a lot of disease, long CTO in the RCA, and you can see the LAD have significant disease there. So how would that end? Like now that we cannot look at it overall, they did the CT-FFR, which I think is more layer testing now at this time since you have an ischemic bed. And you can clearly see the RCA, they cannot calculate it because it's totally occluded, obviously. The LAD is ischemic where we thought it is. There's also some ischemia in the diagonal, and the circumflex also has an OM which is occluded, and the OM itself, is fine, but the circ itself is occluded. So, based on all of this, I'll show you his angiogram, which confirms these CT findings. The LAD is pretty tight. The RCA, this is LAD. You got very tight lesion there, and the RCA is totally occluded, and you can see the collaterals to the right coronary there. And this is his anatomy. So 100%, and there's 75% another occlusion in the OM. So similar to what we predicted based on the PET scan and what we saw on the CT. You think CT added anything here, or probably in this type of patient, you can just go with functional testing after you know that the atherosclerotic burden is so high?
Yeah, so the only way that CT might have helped in this patient is to look at the distal arteries.
Yes.
In terms of assessing potential targets for bypass surgery. Otherwise, it would have been a wasted exam.
You know, I think we have to be very, very careful as we have multiple tests available. The question is, are many private practice places going to be competent in all of these testings? And I think sometimes you need to be very sure based on one test and partially sure based on two tests. And I think that's the part of the problem we are going to deal with these new guidelines that come out, is how are we going to translate the recommendations into performing quality care for our patients. But I think we've reached the end at this point in time.
Just like for the record, I want to say, I mean, this is not something we do routinely here. It's just like I selected cases that have multiple modalities done.
Yeah, no. But the point is, you have high quality testing with everything you do.
That's right. The point here for these cases, yeah. But yeah, most often it's one modality that answers the question, and people go to a management plan based on these. We do utilize multimodality approach. So in the high risk patient, non-CAD, it's more functional testing. In the lower end of risk, we all do coronary CT, and that's why our CT volume is also high. But it does hurt us when we are reading CTs and we get these patients who have very high atherosclerotic burden that you're not going to be able to answer the question with this type of modality. This is a modality that's going to be extremely helpful for lower risk patients rather than patients with high atherosclerotic burden.
So thank you to all the faculty that participated in this. This was really a challenging session and an interesting session. I'm going to turn this over to Dr. Zoghbi now, who will give people instructions on how to get into the open forum.
Thank you, Dr. Wolinsky. Thank you, faculty. Really an amazing forum for us to discuss about coronary disease and some of the issues here. I'll answer two brief questions that came during your case presentation. One is, does a calcium score, if you send somebody to a calcium score, can you see the soft plaques? No, not to my knowledge at this stage of the game, right? No. So, I mean, that's important for us to know. We don't know the burden of the soft atherosclerosis, but there is a relationship of the calcifications to that burden. And the other was for Dr. Quinones, I'm pretty sure, was if somebody cannot exercise, can you do a dobutamine echocardiogram? And certainly you can. You should do a pharmacological stress or a CT, depending on what you're thinking about. But physiology, I think, would be important in those situations. And with that, I want to thank you and thank our faculty for session 2. We're going to turn it over to actually an open forum. So we'd like to ask you to stay with us and ask any questions to our faculty, our senior fellows, advanced fellows that I will introduce them shortly. And use the two different forums, one through the web. Go to PollEv, POLLEV.com, and enter DeBakey for you to send your questions. Or if you want to do texting, text DeBakey, DEBAKEY, at 37607, and I would love to answer your questions. So let's go to our Big forum here. Dr. Quinones. Mike Quinones certainly has been involved and does not need much of an introduction, but I would love to introduce our advanced fellows. Dr. Rowa Attar, who is an advanced fellow here with us at the Houston DeBakey Heart and Vascular Center, and Dr. Amr Telmasi, who is also an advanced fellow, and there will be multimodality imaging experts. So we'd love to have this forum to ask any questions from young faculty to the senior faculty to the advanced fellows as to what are some of the issues that they face, some of the questions regarding training, experience, whatever you feel is needed. So send your questions through the 2 different formats that we talked about, and I think we'd love to answer them. Maybe I could start with one, Mike Quinones, and so we have Dr. Deepan Shah, I think, with us probably on the web. Dr. Wolinsky, if he wants to stay, I think it would be great, whichever you please. And Dr. Al-Mallah is also on the web with us, so we can chit-chat about it. I'm going to ask you a first question. We have 2 of our advanced fellows, and the question would be for the faculty as well as for the fellows is, in the United States, the training is for 3 years in cardiology. Do you feel that there is a need for 1 and at times 2 years of additional training in imaging? And I will start with Dr. Deepan Shah, obviously, who's the director of our cardiovascular imaging training program.
Yeah, so hi, Bill, and hello to everyone. So, yeah, I think the question you ask is a very good one. One of the things that we've seen, I think, in the last 15 or 20 years is that cardiac imaging has really advanced quite substantially over the last decade or 2. Now we've got not just echo and SPECT, but as you've already seen in this conference this morning, we've got cardiac MRI, we've got cardiac CT, and we've got cardiac PET as well. And so I think one of the things I see as program director is I'm getting emails and calls from cardiology programs across the country looking for advanced imaging trainees. So there's a job market is quite substantial, because as these modalities become, the importance of them and the utility of them become more realized, there's many places right now that don't have access to these, but that want to be able to have access to this. So the question now is, if you're going to go as a fellow, it's one thing if you're going to go to a lab that's already established and be one of the members of the lab, versus if you're going to go to a place where you're going to start up the program itself. And I think for the latter, where there's really the biggest demand, for people that can go somewhere and bring a new imaging technology, you need to know that technology inside and out. So not just how to interpret, but also how to do the acquisition, because you're going to have to train the technologists on how to do it. There's not cardiac MRI techs or cardiac CT techs just kind of floating around that you can just hire. Many times you're going to have to train them yourself. So you have to not only know how to interpret, but know how to set up the acquisition protocols, teach people how to do the acquisition. And then I think also importantly, you have to be able to teach the referring physician base when to use this modality, when not to. And so I think all of that would be very hard to do in just a few months during your cardiology fellowship training. And so that's why I think, our advanced imaging program now is 1 to 2 years. And really it's 1 year if your focus is on one specific modality, and 2 years for fellows that want to focus on more than one modality. So I think, the reality is you don't want to sacrifice on quality. And I think to be able to go out and really roll out a new technology, you've got to spend the time in training to be able to do it well.
Maybe I could ask Rowa and Amr. You are a cardiologist, you train, but now you're asking yourself to train further into the field. What's some of the advantages or issues that you are seeing during your training? Rowa, you could start.
So for me, I'm basically doing a year of echo, and we do a good amount of echo during our core cardiology training, but my goals are I want to become a real expert in that field. And to me, that means I need to know the ins and outs. I need to be extremely competent at both transthoracic imaging, TEE, and there's even a structural component there. And also, like, learning to teach sonographers, there's just a lot of depth of knowledge you gain from this year of imaging that I think I probably would have never gained, especially learning from Dr. Q, Dr. Z. I mean, you're learning from the best in the field, so.
Albert, what's you're doing multimodality?
Yeah. Yes. So actually, my main reason to do the multimodality imaging is to be a better doctor for my patient, knowing how to interpret the results, and also knowing how to criticize the information in the results by looking at the images firsthand, and then I can serve my patient better. That was my main reason of choosing the multimodality imaging. And I want to reiterate what Dr. Shah said, to know exactly what you're dealing with, you truly need to spend more time. And now I'm finishing my CMR year and still learning from Dr. Shah every day. And I always tell him, Dr. Shah, I cannot imagine how could people do 3 months or 6 months and then to become truly competent. So time is really needed to add the expertise in this field.
Great. Mike? Yeah. So I agree with pretty much everything that has been said, but I think of myself and Dr. Zoghbi when we were all younger and training, and how old we were when we joined the real world. And now I see all these fellows with white hair. Because they're spending a lot of time in training. And I think that should also be a concern for all of us.
It's true.
So one comment that I have is that if you are lucky as a fellow that you're training in an institution that has excellent echocardiography, make use of your 3 years by customizing your fellowship so you could get the expertise of echo taken care of within those 3 years. That will then allow you to spend a full year or maybe 2 if you think so, but now you can become a real expert on CT, CMR, PET, etc. Now, I know that all programs don't have those expertise, but if you have a program that has excellent echocardiography, my advice to you would be customize your fellowship, have enough elective time so you can get the echo expertise within those 3 years. That will help you a lot doing further tuning up of how you want to do the next year or 2.
One of our fellows also has joined us here, Dr. Dixita Anugula. It's great to have you. So,
Dr. Zoghbi.
Yes, and I agree with Miguel. I agree with you regarding that. You could tailor it. You have to decide at the beginning of your fellowship what area you wanna tackle. And if you're going to be a non-invasive cardiologist, pretty much, be it prevention, general cardiologist, non-invasive with expertise in imaging, start tailoring that, not shortchanging your general cardiology training. You really need that. You need to know, all the specialties within cardiology is how to navigate them, how do you refer to them, etc. But you could structure it in a way to help you navigate. David, how do you see your trainees at Cleveland Clinic?
Again, I think it's becoming more and more difficult because people are just overwhelmed by the amount of material. A lot of our fellows are now deciding, I think too early in their fellowship, what they want to do. And although they concentrate in what they're interested in, they don't always concentrate in what they're not interested in. And I think like you said, I think they shortchange what you can get out of your training, because not everybody is going to become just an imager. You're going to have to be a good clinician also. And the only way you really get comfortable at using non-invasive imaging is to apply it in the clinical world. So it really is a fine balance, and I'm beginning to think that it should be 2 years for non-invasive training, just like for structural. You have to do a year of interventional and then a year of structural often. So I think it's it's just an overwhelming amount of material that they learn. And everybody sits and studies for all these boards that they take early and early in their training because they have to compete for a job. And it's tough to learn everything. And you end up too often spending too much of your time studying for a board exam instead of learning the modality.
Some thoughts regarding amount of training, or what kind of training do you think should you go after your passion in multimodality imaging and choose one or two? Should you train in multimodality imaging? And let me tell you, from my perspective, seeing the field and seeing so many things that are going on, the complexity of cases, I would not venture into an area unless I start feeling comfortable with it. And I know echocardiography, we train quite a few people, and they leave and start reading echoes within 6 months, quote unquote. This is level 2. But seeing the pathology that we see and the difficulties of navigating that, it behooves people to spend a little more time in whatever areas that they are, specializing in, or at least being interested in, to do that. And a patient in private practice, to me, is not any different patient coming into an excellent center. You're going to see the complexity and you're going to see the simplicity at the same time.
So we have struggled with that in the field of nuclear cardiology. Fortunately, I've already been president, and it's going to be Mouaz's job, but we have lost some of the passionate people who are interested in driving nuclear cardiology forward because people are interested in everything. And I try and push people really to focus on one area of imaging, whether it's CT, whether it's MR, whether it's nuclear imaging. Become an expert at everything, become passionate at one of them. I think that's how the fields will grow in the future.
Also, we need to, I think we all need to be honest with each other. We talk about echocardiography being subject to a lot of variability because of sonographer skills and interpreting physician skills. And that absolutely is true. And that's why I wanted to make that point very strongly in my talk. But we also see a lot of patients that bring their CTs, their CDs with SPECTs or CTAs from other places, and they also have their issues. So I think the overall quality of imaging, if we're all honest with each other, across the two coasts of the US are not exactly yet what we would like it to be. And I think, everybody points at echo, but I think we all should be honest. Even CMR, I just had a patient that sent me a CD, heart failure patient with a CMR. I asked Deepan to look at it, and there was a lot to be desired on that CMR. So, it's just one thing that we all have to be, and I hope that those of you taking the course are here because you want to improve the quality of what you're doing.
And for those of you who are
already something, David touched on an important point, which is the issue of passion in terms of advancing the field. There are obviously the basic minimum for every cardiologist in every modality, kind of the level 1, or an echo, probably level 2 is probably the basic minimum for every cardiologist. But I think beyond that, people have to kind of dig deep or be known for one modality or two. Like, for example, or be specifically focusing on a disease process like sarcoid, amyloid, inflammatory cardiomyopathies, and their imaging across modalities. And I think that's very helpful. Multimodality is adds also a different perspective. I do also, as you know, multimodality, and I think when I read my PET scans for sarcoid and my PYPs for amyloid, looking at the MRs, add a way different perspective on how I'm looking and how am I serving my patient. So I think multimodality is not always a negative, as long as it's make it really harder on us to maintain the skill and maintain the competency in there. But I feel that multimodality makes me even a better nuclear cardiologist, or cardiac CT makes me a better nuclear cardiologist, because Number one, I put patient first, but also with my interpretation, I feel like I'm more providing a consult because I review when I read the PYP, I look at the MRI, I look at the echo, and provide the patient with the totality of evaluation. And probably fellows who rotated with me can attest how looking at different imaging modalities help us, like, is this an artifact or this is a true? If I see an LGE on a sarcoid scan in the same area, I'm not going to call it an artifact. But maybe not looking at the MRI, sometimes it's not reported in the MRI because the MRI thought it's something, but now that I'm seeing it from a different angle makes me more confident that this might be an important finding. So I think multimodality does have a role. It just adds a lot of burden on the reader to keep their competency, and we need to have that kind of breed of new multimodality folks that are excellent in what they do, but you're not going to be able to maintain across everything. Probably for me, I'm focusing on the areas I do best, and this is how I maintain my skills in these areas.
These are very important points, Mouaz, and the competency that you and David have mentioned, and all of us have mentioned. I know our audience today is quite a few fellows, quite a few people already in training, are already there. And if you attended session one, if you didn't, you go back to it and your recorded, availability material down the line. Is the field is changing in each one of these modalities at a very rapid rate. So for people who are graduated even few years ago, certainly many more years ago, please take the time. If you're involved in reading and in imaging, and even for take the time, and nowadays this material, this knowledge is available. Just take the time. I think it's worth it in the long run. It's worth it for you as a specialist, and it's worth it certainly for your patients. And to your point, Mouaz, there is actually a comment from the audience. There are commonalities. You mentioned, the commonalities between the imaging modalities. Reading CMR and CCT make you a better echo reader and vice versa. And actually, the more you understand about the pros and cons of each modality and understanding artifacts, advantages, physiology, in addition to anatomy, the better of a clinician you're going to be and the better of an imager you're going to be. So take the time to do that. And
if I may add something, this is something like I've been pushing a lot of my colleagues to advocate this, like really to put the patient at the center. And I know that there are many who may think that one modality could be a one-stop shop. And the reality is, every modality has its strengths and weaknesses. And I think we need to put the patient at center and look at it, irrespective whether this is the modality that I'm an expert in, or the modality that I do in my office, or I have to send them down the street to get their better imaging modality that will answer their clinical scenario better.
Okay.
One other thing that I would advocate for is mentoring. This is your one opportunity to really take advantage of one-on-one relationship with people with whatever modality you're interested in. But it's not just simply how to read it, but how to use it, how to convey the information. And I think those people have been able to find a mentor, come out much more comfortable with whatever they're interested in.
We have a past ASNEC president. We have an upcoming ASNEC president. I'll talk to myself. I was ASE president and ACC president, right? And there's a question regarding this. We need to move to a 2+2 training pathway supported by the ACC. Multimodality approach is the future when we leave the silos. Basically, trying to shorten, a point that Mike Quinones just brought. Maybe try to shorten the whole pathway in a way, but irrespective, you're going to need more training, irrespective of what the modality you're looking at. An interventionalist, an EP doc, adult congenital heart disease, heart failure, imaging, everything else. Instead of going to a 4-year training of cardiology, we're giving the option for people to do that, but I think reality of it is is getting there. So what do you think, David? And would this be a possibility down the line? I know there's a lot of negotiations, ABIM and otherwise.
I mean, I think it's hard to get all the clinical skills you need in 2 years. I am somewhat surprised sometimes by what seems obvious to me and not so obvious to the fellows in evaluating the patients. But I'm, quote, an old man, and I think of things the old-fashioned way. I'm not sure whether 2 + 2 is going to be enough. It's going to be hard to change the fellowship programs to make sure you get the intensity of the training within the first 2 years of some of the basics without people kind of running off and just doing what they want to do.
I agree with you, David. I don't know if Mouaz is going to say something. It will be an act of God to change it. That's number one. Number two, you have some of that flexibility if you work with your program director as to how do you structure your 3 years to get as much without shortchanging the basics of cardiology. You still need to be a cardiologist as opposed to a super specialist from day one. So I think there's that balance of doing that. And I think Dr. Bindu Shubrolu has joined us also, so it's great to have you, Bindu. She's one of our faculty and director of our clinic at Pearland Clinic and a specialist in echocardiography. Certainly we welcome your thoughts. Interestingly enough, I mean, this is a comment regarding talking about being passionate about what you do and important training and updates for your patients, but also because they said the pride, or they are representing the institution that we're trained at. I think there's a dimension of that. We'll take it.
Absolutely.
I'm looking at our fellows here and said, it speaks to you, it speaks to where you train. No question about it.
I'd be curious to know what the fellows think.
I'm sorry.
Let me just before that add one thought. I mean, there were some suggestions at one time to kind of shorten the internal medicine, so kind of have a special pathway for cardiology. So instead of making it 2 and 2 for imaging or other subspecialty, make it 2 internal medicine, 3 cardiology, and then 2 subspecialties. So technically, you're still through the 7 and make an extra pathway. And I think that might be discussed and should be at least looked at it objectively from different perspectives.
There's a question actually addressed to Dr. Amer. My question is for Dr. Amer. What advice would you give to new fellows wanting to learn CMR at Houston Methodist? Here you go, Dr. Shah. What should they expect and prepare for? I mean, that would be that would be the same actually for Dixitha, for
right.
How would you make it a most optimal, time efficient and effective training?
Yes. So first, I would like to tell the person who sent the question that if you will be here at the MRI lab, especially with Dr. Shah and also with the rest of the faculties, be prepared to the flood of information and aha moment that you thought you know something, but you come in and it's like brand new concept you learn about. My first 6 months were like full of this aha moments, and I'm really grateful to Dr. Shah, Dr. Al-Mallah, and like the rest of the faculty. And I still have a second year to spend with probably more aha moments. So that's one of the things. The other thing is, I think just, like it's a very like super friendly, safe learning environment. Just, come in, be prepared to learn, accept comments, and just like, go with the flow and spend time reading about the basics. Probably for the cardiac MRI, what I would say, try to go to the basics from the beginning and spend more time in reading. Maybe that's the one thing I would advise my old Amer a year ago to do more. But other than that, it will be a beautiful journey.
Dixitha, what did you have to do? Or what would you advise other people?
I'm the better person to answer the MRI question because I haven't started my MRI year yet.
But I would echo with Ahmed too. There is a treasure of knowledge out there, especially even the DeBakey YouTube videos we have from all the gents in the multimodality imaging. So those are some videos that I would definitely go over before starting my fellowship here. So just, it's not that you have to be a perfectionist before coming in. That will just give you like a little bit of baseline knowledge to build upon those pillars that you're, because it's already all there, and they're doing a great job at trying to give you a wealth of information, and it's all available on YouTube. So that's something that I would do.
So Bill, if I could kind of chime in, one of the thing I would say is if somebody is interested in training in CMR, the thing that you should do during your general cardiology training is get very solid training in echo, because I think the reality is all of the advanced imaging modalities build upon what we learned from echo, and most of the patients that you're going to encounter are coming to the advanced imaging lab based on some finding on echo. And so we frequently will look at the echo to decide how to do the study and also how to interpret the study. So I think if you don't have that basic foundational knowledge, it's going to be very hard. And it's a difference between being somebody who just kind of reads what you see in front of you versus integrating it together and coming up with an answer. And I think what you really want to do is be a consultant to the general cardiologist that sends the patient and look at everything and give them an answer back. And that's how you'll keep building your program and keep getting more referrals. If you just read, I see something in front of me and this is what it looks, that doesn't help anybody else, right? So I think that having the foundational knowledge in echo is how you, I think, prepare for training in CMR or training in other advanced imaging modalities.
Well, take it from an MRI specialist of the importance of echocardiography. I did not plant that question, nor influenced. No, but I mean, it is true. We have, and there's a comment here, which is, I'll read it for you. MMI, which is multimodality imaging, is a niche and a necessity rather than a luxury. And we need the support from the Imaging Council and multiple societies to expand it and improve it. Because I really feel this is core to many things that we do in cardiology. And if you think of any specialty in cardiology, from prevention to the latest catheter-based interventions to EP, heart failure, you name it, adult congenital heart disease, very essential. And I think the more you know about it, even the basics of it as you go into other subspecialties, but certainly if you want to call yourself an imager, non-invasive person, spend time. And I cannot re-emphasize again, if the fellows are there, that's how you plan your future. And don't plan it on a static learning. This is continuous learning down the line. But for people already in practice who are interested already because they're tuning in one way or another, this forum, many others, our YouTube channel, many other institutions also provide that. Take the time, really take the time. Don't say that you're too busy. Take the time for your own professional development.
So Bill, let me also just kind of second what you said about this continuous learning aspect. And this is the one thing I will really stress to the fellows. What you really want to get out of your training is not just some tidbits of information or approaches to things, but rather learn how to learn. Because I think you can ask, Mike Quinones, when he started, contrast echo wasn't done, strain wasn't done. So he didn't train with someone that taught him how to do those things. He learned those things on the job. And I guarantee you that imaging is going to continue to evolve. And most important is to learn how to learn. In addition to getting the foundational knowledge that you get during your training, is be prepared to and know how to work through new things and know how to work through learning new things. I think that's probably key.
Well, that is a phenomenal statement, Dr. Shah. So I think learning how to learn is I think a mantra which I think even as early faculty and fellows, everybody, I think as we evolve, is something which we really learn every day. And like you said, as the technology is evolving, as multimodality is progressing from 2 dimensions to how many dimensions, God knows. So I feel like it's just training, ongoing educational, I think pursuit we need to do. So I think that statement is amazing, Dr. Shah, and I would second that.
A particular question, since we said anything goes, there is a technical question and there is a clinical question. That's for Dr. Al-Mallah. Can you give us a quick review of how to calculate coronary flow using PET rubidium 82? It doesn't have to be just maybe an elevator talk. How about that?
All right. So, I mean, I'm sure our fellows also can give that. So, but I'm not going to put them on the spot. So, yeah, I mean, the main point here is that we're measuring the vasodilatory ability of the coronaries. So we measure flow at rest. So when we inject rubidium, we have some measurement. We do direct measurement in the blood pool and direct measurement in the myocardium. And with modeling, we calculate how much blood flows to the myocardium. And we do measure it twice, one time at rest, one time at stress. And obviously with stress, you should see that the blood flow increase to the myocardium. And then the ratio is the coronary flow reserve. That's the same concept applied in MRI. That's the same concept applied in echo before, I mean with contrast echo. And this data has been very well validated with PET. Validated with different machines, with different radio tracers, and now it is even reimbursable with PET. So I think it's a very important tool, and there are a lot of nice documents from ASNIC and from leaders in the field that can guide you how to incorporate this information into the management of your patients in different clinical scenarios.
Wonderful. Okay, a clinical question to all of you, whoever wants to take it. This is about cholesterol, LDL cholesterol, and calcium scoring. Okay? And the LDL could be 70 or could be between 70 and 100. But the calcium score could have a range 1 to 99, 100 to 300, 400. Statin for everyone, or which subsets?
I'll take that.
So,
You'll take that?
I'll take that a little bit, just to tell you what
Mike
we do
Quinones
on
was
these
going to take
cases.
it.
I mean,
Yeah, I'll take it because I think this is common practice for all of us. And one thing that the person who asked the question didn't put in is patient's age. Okay, so if you go into my club, I belong to the 70 club. All right. It's different from a 51-year-old. So, my position is that when you're dealing with the younger persons, your threshold for statins is more at any calcium score level. Maybe one you might want to give them a break, but a calcium score of 50, 100, or anything in there in a younger person is extremely significant. So I think I treat that person as aggressively as if they had an MI. Now, you take that same calcium score and do some LDL, and now you're talking of 79, 80-year-old, you have to think it twice, because now you have to put together how much more longevity that person has just basically because of their age, was their mobility, was their false risk. It becomes a lot more integrated question, and therefore my threshold for that elderly patient is a lot higher.
Mouaz, and we interrupted you, sorry here.
I think I totally agree with Dr. Q, and I think it is very important to take the patient age into account, and the calcium score of 50 to 100 in a young patient is more problematic and they need to be treated. I think there is even some data in the elderly, Dr. Q, that does help to put them on statin, so I wouldn't rule out the above 70 from even statin at that age, and this is in both stable coronary disease and acute coronary syndrome.
Agree, but look at the whole patient.
Exactly. Yeah.
And the question, I guess part of that question was, is a statin initiation important, although the LDL level may be quote unquote in the normal range, right? yes, you have calcifications, but for that particular person, yes, you have some atherosclerotic process that may not necessarily be delineated by quote-unquote normal LDL, but I guess the data is supportive in this situation. Correct?
Yeah, and if I may add a little bit also, I see some patients who are getting surveillance calcium scores, they keep checking it on statin. It's not going to come down. If anything, it's going to go up on statin, because statin stabilizes the plaque. You get more of the densely calcified plaque, so the calcium score is going to go up on statins. This is not a bad sign, so it's kind of like a paradox here. Yes, it's going up, but it is probably making sure, it's hinting you that statins are working and stabilizing these unstable plaques.
Do you all subscribe to once a calcium score is positive in your evaluation of risk, do you really need to repeat it another time once you made a decision for somebody to go on a statin? Yeah.
Yeah, I only repeat when you are in these very low levels, let's say a score of 20 in a 53-year-old or a score of, but once you hit over 100, you're totally committed to, pretty aggressive management, and I don't repeat it. I think I'm not going to gain anything. And in fact, Mouaz made a very good point, because the score may go up, and the patient may get even more scared by a number that is meaningless because they already are on statins. So I don't think it's a good exercise to do.
And maybe a last
we only repeat it in the setting of perfusion imaging because it helps us be more accurate in our assessment, not for atherosclerotic burden, because if the calcium now is in the left main and in all vessels, then it might give me additional information for the diagnostic workup rather than more from a prognosis point. And yeah, we know that once these patients develop high atherosclerotic burden, these patients are going to be having, they are at a higher event rate long term. But short term, what will determine their outcome is more symptoms and management and ischemia.
Good point.
A question regarding calcium score and hesitation to do a CTA. What is the level of calcification? Is it 1,000? Is it 500? Are there any data to tell you? And I know the calcium score is rather diffuse, could be all in one artery or multiple arteries. What's your approach to that?
So this question has also some historical perspectives. The historical perspective was if it is more than 400, your CT becomes a little bit less accurate because your specificity is going to come down. But as technology has improved, and now with the newer scanners and newer reconstruction tools, this number moved a little bit more, but still moved a little bit higher. I cannot give you a number because we usually don't calculate a number before calcium score, before CT, but rather look at the distribution. If all the calcium is in the left main and it's very dense, then it might limit me. And in some of these cases, you may not have too much help from CT FFR, and then you may need perfusion imaging for these. However, I think once you start getting closer to 1,000, 600-700, it becomes difficult to read. Closer to 1,000, definitely if you have some of the older generation CTs, for the person who's asking the question, the regular 64 slice, I wouldn't do it above 400. It becomes limiting. Once you get the newer generation CTs, closer to 700-800, your specificity is going to come down. Even if you clear that patient, we don't know the accuracy and sensitivity and specificity. Although you see some papers that tell you it's great accuracy, but these papers are coming from expert centers, and these are not at the point where these are the clinical reads. These were done purely for research. Once you do it for clinical read, people are going to err more on the side of sensitivity to make sure that we're not missing obstructive disease and like limiting patient access to important therapies. So, I mean, calcium, now we're hoping that this new photon counting CTs and maybe spectral imaging and some other vendors or the combination might be able to alleviate that, but that's still a new machine and it will require like long time until it's widely available and adopted. So wonderful. I think these are all helpful tools, but yeah, once the calcium score becomes pretty high, it becomes a challenge.
If I could make a comment, we're getting towards the end of this session, and we've been hearing a lot this morning about all the wonderful modalities that are here for us to use, how they're increasing complexity, how some have their strengths and their limitations. So I'd like to suggest to the audience, those of you who are actually clinicians taking care of patients, is there are situations where before you order a test, it may be better to hold back and consult your imaging experts. If you are lucky to practice in an environment that you have people with expertise around, before you check mark on the computer what you're going to order, ask. Because I think Mouaz showed a beautiful case where the clinician insisted in doing the CTA when maybe the other path would have been better. And I personally do that. I personally call some of my colleagues and ask them, hey, I have this patient, should I go this way or that way? And they help a lot. So, you know, imaging is becoming also so complex for the clinician that as clinicians, we should also pause and ask our colleagues. If you're lucky to have them around, use them before you order the test. It might also be better for the patient and more cost effective.
Very wise advice.
This is a very important point, Dr. Q, and I can assure you, you're not the only one who calls for this. I mean, many of our colleagues, on average, I got between 3 to 5 consults a day just on the phone. I have this patient, which test is the best for the patient? Because people are conscious, you don't want to order test layer testing because it adds cost and sometimes add ambiguity to the patient. Yeah. I think, and this is one of the niches if I'm to kind of like advocate for multimodality imaging people, because we're kind of like looking at it from different angles, and whenever we're on one shoes, we kind of see the strength and limitations of each modality. And I think it's very helpful, I mean, to get these from a multimodality kind of person who can guide you to the modality that will kind of put you on spot for these patients. I think that's one of the evolutions of our field, the multimodality kind of aspect, consult.
Very important.
Yeah, if I could follow on that, I think it's important for the trainees to recognize that that's going to be part of your job. It's not just about going someplace and doing whatever modality it is that you do, but it's educating the referring physicians on when to use your technology and when to use something else. And so, I would say, you give out your phone number when you start at a new place. You'll get a lot of calls in the beginning, and then people gradually figure it out after, you talk to them multiple times. And then the number of calls you'll get will gradually get less and less. But that's an important component of your job, without a doubt.
A last question, I think an important question, because of the audience also. This is coming from somebody who's been out there and says, what options and pathway you have for people in practice to get trained in SCCT and nuclear cardiac imaging, like Dr. Quinones and Dr. Zoghbi. We're not trained, right? But certainly we understand the language and we know who to call, and we've learned so much. I mean, it really is amazing, but many of our physicians who are in practice may want to pause. And I'll share with you, the audience, that one of these physicians who was, in interventions, etc., decided to take a year off. Now that is drastic, and to come and train with us in MRI. But there are many ways. Deepan, can you address that in a way to refresh or get expertise, if you will?
Yeah. So I think there's two aspects to it. There's somebody who's out in practice, and especially if you have already a strong background in imaging as a clinical practitioner, then I think that there are training programs that you can go to for 3 to 6 months. I know for CMR, we have kind of a 3-month training program for people that are out in practice that have already a strong background in imaging in other modalities that can then come and basically learn to get level 2 training. I'm sure that those types of opportunities exist in cardiac CT as well. And I think the key difference there is that somebody in practice has a certain breadth of knowledge that a lot of the fellows don't have, and that's because they've been doing it. And again, as you do something, you have to learn about it. And so I think that there are opportunities like that for people out there. If you go to the societies, most of them have on their websites, the CMR website, or I'm sure SEC website does have places that you can go for training. And some of these training programs are structured so that it's not going for an entire 3 or 6 months, but you can go in kind of weekly blocks. So it's something that you can do, within still the confines of a clinical practice.
Well, I want to thank you all for participating in this open forum. I felt it was important to address training questions, retraining, if you will, brushing up and tweaking your knowledge and in those areas, and maybe address some clinical questions. So cannot thank you enough. Thank the audience also for participating. That closes actually the morning, or the first 2 sessions. We'll take about maybe 10-minute break, start at 15 after the hour, depending what hour you're in. And we will address the role of imaging in heart failure, and it will be co-chaired by Dr. Quinones and Salerno. So thank you very much, and have a wonderful day.
Good afternoon, and welcome to our section 3 of this course. And we're going to be concentrating on imaging in heart failure. We have a list of wonderful speakers coming up. I'm Mike Quinones, and I'm being joined by Dr. Michael Salerno as the moderators for this session. And our first speaker does not...
I don't see you, Mike.
Hey, Jamil. How are you?
Where are you? We are not able to see you.
Okay. Keep going? All right. Anyway, the first speaker today does not need any introduction. Dr. Jamil Tajik is one of the pillars of echocardiography. Spent many years defining and teaching us how to use echocardiography in many, many areas, writing books about it, and having a fantastic career at Mayo Clinic. And now he's enjoying his second chapter with the Aurora Health System. So Jamil, welcome. Thank you for being with us. And he's going to be talking on quantitating ventricular function with echocardiography, when and how to use strain.
Well, good afternoon. And I'd like to thank Dr. Zoghbi, my good friend, for the kind invitation to participate in this multimodality imaging conference. It's a pleasure, privilege, my friend, for your kind invitation. I also see my good friend Quinones is moderating the session on ventricular function. And we'll say a few words about myocardial strain as is being used in our practice and what its impact is going to be. For decades, echo community has known that ejection fraction is not the whole story. And finally, the heart failure gurus have now recognized that we need to go well beyond ejection fraction to totally get an insight on myocardial mechanics and ventricular function. It's a recent quote from Dr. Milton Packer, who's well known to everyone in this audience. The strain is a measure of myocardial shortening, a measure of what the heart actually does, myocardial contraction. Ejection fraction, on the other hand, is a measure of volume exchange. And so Dr. Packer goes ahead to say, sign me up to get rid of ejection fraction, he said. So with that brief introduction, let's see what strain is all about. Myocardial fiber shortening is being done automatically in many of the machines, but all 4 chambers are not being done routinely by many vendors. Looking forward to this kind of a display in the very near future, where left ventricular and right ventricular myocardial fiber shortening is displayed below the baseline, and left atrial and right atrial shortening is shown above the baseline. Just a very simple way to understand myocardial strain is to take a segment of myocardium that's 10 centimeter, and during systole, it shortens to 8 centimeter, and mathematically that is equal to a shortening of 20%, but negative because it is shortening and not lengthening. And that is how strain numbers are conventionally presented, is negative 20 as a normal strain for the global left ventricle. And here are some normal ranges displayed. The global longitudinal strain has withheld the position of being the only number that clearly gives us all of the information of myocardial segments in 4-chamber, 3-chamber, and apical long axis views, and therefore circumferential and radial strains are not routinely being performed. And average in normal global longitudinal strain is about minus 20%. We'll also say a few words about LA strain and not much about the right-sided strains in this presentation. The LA strain is divided into three functions. The strain during the reservoir phase, during ventricular systole, that is the most important one. The conjugate and the atrial contribution to filling of LV are also can be measured and are displayed and measured by the algorithm. Here's an example of that. You can see that systolic strain is represented here, early diastolic is here, and atrial kick is represented in this region. Most of the time, our lab will be reporting the peak systolic strain, which is at this moment in time in the cardiac cycle. So here's a case study that shows the left ventricular strain on the left side with the strain curves for each segment displayed along here. This vertical line represents the end of ejection aortic valve closure. And after that, diastole begins, as you understand very well. And these are the different segments color-coded showing how the normal strain is and global strain and normal in this individual. Left atrial strain in this area is being shown, and you can see different numbers here. Sometimes the septum is excluded, atrial septum is excluded, and only the free wall strain is reported. We report the full left atrial strain in our own practice. I show some practical examples of the use of strain imaging in different myocardial diseases. And while I'm showing that in this particular picture, you also see that I have displayed here at the bottom the myocardial global work. And even though we are not going to discuss much about that, that is the next frontier where the strain numbers are correlated with and standardized by the afterload, which is the systemic systolic pressure. So this is a 22-year-old gene-positive hypertrophic cardiomyopathy, markedly hypertrophic septum, sigmoid shape of the septum of the curve here. You can see also the ejection fraction of this cavity is completely normal. The systolic anterior motion of the mitral apparatus noted, and at the bottom you can see also marked degree of SAM there, and as expected, there's severe obstruction of the outflow tract and severe posterolaterally directed mitral regurgitation. The point to illustrate here is that ejection fraction will be misleading for assessment of ventricular function, in particular the myocardial mechanics of this heart, because that's entirely normal, 68%. However, the global longitudinal strain, GLS, is markedly reduced. Normal for this young person should have been in the range of minus 20, minus 22 range, and here it is quite significantly reduced, and so are the global indices of work and efficiency are reduced. So that's the important use of practical use of the strain imaging results. This patient, also a 74-year-old lady with apical form of hypertrophic cardiomyopathy. You can see through the echo, very typical of the apical hypertrophy evident. Ejection fraction is 72%. Strain map is being drawn here. You can see here the strain curves being shown, and you note that the global strain is quite reduced, minus 14%. But if you pay attention to the regional strain right here at the apical levels, depicted in the bullseye display right here, the strain values are, as we call in the lab, are totally kaput. They are markedly reduced. And that is the display of the global strain as well as of the regional strain at different levels. Again, just quickly alluding to that the global work index is markedly reduced and efficiency is 83%. When you incorporate the blood pressure information, the systolic blood pressure, with the strain data. And the third example is of a major regional wall motion abnormality at the apex. Happens to be another patient with a hypertrophic cardiomyopathy with midventricular hypertrophy, apical aneurysm. Overall ejection fraction, again, is in the normal range or low normal range for a hypertrophic patient. Note on the bottom left, you can see clearly the classic emptying pattern from the apical aneurysm during diastole, also and very mild degree of obstruction. The GLS is markedly reduced. Apex is completely wiped out. It's blue. Aneurysm is dyskinetic here. And overall efficiency of this ventricle is markedly reduced. These are the parameters we need for further management decision-making for such patients. Markedly reduced GLS. What is the emerging data of GLS in hypertrophic cardiomyopathy? And you can just see that this is a recent publication, shows when the GLS is normal, blue, survival is decent as compared to the markedly reduced GLS in hypertrophic cardiomyopathy. Overall survival free from major adverse events is quite reduced. And that is incremental information to ejection fraction, incremental even to late gadolinium enhancement type of information in this entity. Let's look at another entity, which is amyloid heart disease, very much a topic of these days of discussion because new treatments have become available for this condition. This is the ATTR patient with markedly positive PYP scan. Here's a ratio of 2.2. And you can see the ejection fraction of this heart is still preserved, both in long axis view, in the short axis view, you can appreciate that. However, the strain pattern, the bullseye, is very, very abnormal with apical sparing pattern, which is referred to as cherry on the top appearance of the bullseye, pretty characteristic of amyloid heart disease, but not specific to amyloid heart disease. It has been seen in several other disease entities as well, the cherry on the top appearance. So here is a GLS of only 8% in a patient with well-preserved ejection fraction. So EF is not the story anymore, and everyone, including the heart failure gurus, have now come to realize that. This is another patient with amyloid heart disease, just to demonstrate that a similar age group, but here the ejection fraction is already reduced. GLS is also severely reduced in this patient, and left atrial strain was also markedly abnormal, although not shown here. And a recent publication in regards to the data from GLS, from strain imaging in amyloid heart disease, published just also this year in JACC, shows all effect of the all four-chamber strain evaluation. Here is the LV, here is right ventricle, left atrium, right atrium. Of course, these are patients with amyloid heart disease, so they all have reduced strain values to begin with. But within that range, if the strain values are in the higher median, above the median, better survival than the lower. Note that the left atrial strain pattern is even more distinguishing for survival, and that needs to be further followed up with larger studies and in other disease entities. And that's why the importance of measurement of left atrial strain. Example of left ventricular non-compaction syndrome. Young person, 31-year-old, severely involved left ventricular non-compaction at the mid to apical levels. You can vividly see those right here. Marked non-compacted myocardium right there as compared to compacted myocardium here on the lateral wall, infralateral wall here, marked non-compaction. Ejection fraction, 25%. And note, there's some apical sparing in this, and GLS is, of course, totally reduced, and this patient underwent successful cardiac transplantation and is doing well. Restrictive cardiomyopathy, left atrial strain, all shown in this example, all are markedly reduced, note markedly dilated atria, typical appearance of restrictive disease. Chemotherapy is an area where strain imaging is now routinely being requested by the oncologist because it can tell if ejection fraction is going to fall way before clinical symptoms appear. So that's being routinely done. It's well accepted in the clinical practice. And I'm going to go quickly over the last couple of slides here. This is the chemotherapy patient. On the left is controlled pre-chemo measurements, normal GLS to even increase values there. And at 6 months follow-up, you can see reduced. And at this level, you can start the usual treatments with beta blocker and afterload reduction therapies. Coronary artery disease is, of course, the bread and butter of cardiology, and there we see so much of disease and wall motion abnormalities. And here, of course, already the ejection fraction has taken a little hit, 46%. Apical wall motion abnormality is very evident on the 2D echo, and we can see on the strain images that the apex is very markedly reduced strain at that level. So incremental value. Just to conclude then that strain imaging is here to stay. It's being done routinely in many, many labs around the country and should incorporate all four-chamber strain assessment. All are very informative. They have prognostic information, incremental not only to ejection fraction, but to other serious parameters. And with that, I thank you for your kind attention.
Thank you. It was a really excellent talk. Learned a lot about strain. The next speaker is Sharif Nah, who is the professor of cardiology at Houston Methodist and really is a well-known expert in evaluation of LV diastolic function. So we look forward to your talk.
Hello, I'm Sharif Naga. I'll talk to you today about the echocardiographic evaluation of diastolic function. My routine is to look at the clinical data. When I read an echocardiogram, I look at the heart rate and the blood pressure, pay attention to the 2D findings, be it ventricular size, ejection fraction, wall thickness, mass, look at global strain, which we acquire routinely in our lab, as well as mitral inflow, annular velocities, pulmonary veins, tricuspid regurg signal from multiple windows, and an echo estimation of right atrial pressure, which is usually through the subcostal views, looking at inferior vena cava size, its change with respiration and sniffing, as well as hepatic vein flow. If feasible, and we have a decent signal, then we also look at the pulmonary regurg and diastolic velocity, and when needed, left atrial reservoir strain. I'll have something to say about these towards the end of the talk. Important principle, Doppler assessment of diastolic function and filling pressure has good accuracy if you look at patients with cardiac disease, but if you look to normal subjects and in situations where there are acute changes in loading conditions, the accuracy is much lower. So an important task is to recognize those with cardiac disease. I'll refer a lot to the 2016 recommendations for diastolic function evaluation. And these are geared to the estimation of early diastolic pressures. When we talk about early diastolic pressures, we are referring specifically to mean left atrial pressure, pulmonary capillary wedge pressure, and left ventricular pre-A pressure. These are the pressures that determine the filtration forces in the pulmonary capillaries and result in symptoms of pulmonary congestion. There are general guidelines that we will focus on, and they do not apply that well to the specific patient populations that you see on this slide. It does not mean we cannot assess diastolic function or filling pressures in these populations, though, but the general guidelines do not apply to them. They include patients with hypertrophic cardiomyopathy, any degree of mitral stenosis, significant mitral regurgitation, 3-4 plus mitral regurg, moderate to severe mitral annular calcification, severe aortic regurgitation in patients with a normal ejection fraction, sinus tachycardia with variable degrees of merging of early and late diastolic velocities, atrial flutter, fibrillation, left bundle branch block, ventricular pacing, patients with AV block, group 1 and also groups 3 to 5 pulmonary hypertension, pericardial compression syndromes, heart transplant recipients, and patients with left ventricular assist devices. The first question to ask and answer is there diastolic dysfunction or a high likelihood of diastolic dysfunction? And here we look at the cardiac evidence of cardiac disease, be it structural or functional abnormalities. Example of some of the structural abnormalities you see on this slide. So someone with known disease of coronary artery disease, and you have the patient has multiple segmental wall motion abnormalities. A patient with pathologic left ventricular hypertrophy defined by mass index adjusted for sex, as in patients with aortic stenosis or hypertension. Hypertension in particular can manifest with cardiac disease in terms of structural abnormalities, not only with increased mass, but also left atrial enlargement. So left atrial enlargement in the absence of atrial arrhythmias, mitral valve disease in someone with hypertension is indicative of diastolic dysfunction. Systolic dysfunction is noted by a depressed ejection fraction. A word of caution here, some athletes that do more of endurance athletes can have a larger sized ventricle, lower ejection fraction, but do not have diastolic dysfunction. And these can be recognized by the presence of normal strain and normal annular velocities. Abnormal lung axis function, as recognized by global strain, we do not need nowadays mitral annular plane systolic excursion or S prime velocity, but if you happen to have a study where you don't have a good global strain signal, you can look at these. We look at strain from the 3 apical views, and when one assesses the presence of abnormal strain, you have to be satisfied with technical aspects, as well as consider the fact that strain is also affected by heart rate, preload, and afterload. The detection of diastolic dysfunction can be challenging in normal ejection fraction settings and with no apparent disease. And here we want to look at more subtle, if you would, functional abnormalities. We rely on pulmonary vein signals, what happens to the mitral inflow with a Valsalva maneuver. We compare mitral and tricuspid inflows, and we look at the L wave. These signals are many times ignored, and people refer to the 2016 guidelines as though they support that. That is incorrect application of the guidelines. Example is shown here in a patient who has heart failure preserved ejection fraction, and you see a very small A velocity for the mitral inflow. In comparison, the atrial reversal velocity in the pulmonary veins is very prominent. It exceeds 40 centimeters per second. And if you compare its duration to that of the mitral A, which is very much abbreviated, that's a good indicator that this patient has increased left ventricular and diastolic pressure. The yield of good pulmonary vein signals is in excess of 80% in the outpatient setting. The changes in mitral inflow with Valsalva is shown here. When the intrathoracic pressure increases, venous return drops, left atrial pressure drops. As a result, the mitral inflow changes from a pseudo-normal pattern to one where the E to A ratio is reduced, as you see here. The challenge is to have a patient who is cooperative enough to understand the instructions and also to do the needed effort. So specificity is decent, but sensitivity may be lower. Comparing tricuspid and mitral inflow is also a useful approach. These are pressure and Doppler recordings taken from a patient with cardiomyopathy that involves both left and right ventricles. If you look at the left ventricular pressure recordings, you have a pre-A pressure of 18 millimeters mercury and an end diastolic pressure of 30 and a corresponding mitral inflow pattern that fits restrictive filling. If we look at the tricuspid inflow side, you will see that the ratio is less than 1 clearly and a markedly reduced tricuspid E' velocity. Looking at RV pressure recordings, both the pre-A pressure and the end diastolic pressure are normal. So if we start with the premise that both left and right ventricles are depicting the same abnormal function, the reason, or abnormal relaxation, the reason the mitral inflow looks the way it does is because of the higher left atrial pressure. Otherwise, it should have mirrored the tricuspid. An L velocity can be recorded. A pathologic one is seen in situations with slow heart rate, impaired relaxation, high left atrial pressure, typically in excess of 50 centimeters per second. It can be recorded sometimes in tissue Doppler signals, but it has been much less evaluated based on tissue Doppler only. So we gathered all this data and we do not have any other abnormal clinical 2D or Doppler findings. Where do we go from here? We look at the average E to E' ratio, the annular velocities, the peak TR velocity, and left atrial maximum volume index. If the majority are abnormal, diastolic dysfunction is present. If the majority are normal, then normal diastolic function is present. In between, we're looking at indeterminate grades. Sometimes people believe that if you have only 3 variables, that is not enough to proceed with the evaluation. No, you can. And again, you look at the 3 variables that are available, and depending on where most of the evidence is, the call will follow. Once a conclusion is reached about diastolic dysfunction, the next step is to estimate left atrial pressure, and here we rely on mitral inflow. And based on the E to A ratio, patients are either placed into a normal left atrial pressure with grade 1 diastolic dysfunction or increased left atrial pressure grade 3 in the middle group, depending on the majority of the signals being normal values or outside the normal values. Patients can fall either in groups 1, 3, or indeterminate. That's an example from a patient with heart failure, preserved EF, a large left atrium, normal ejection fraction. You can see restrictive mitral inflow, a peak TR velocity in excess of 3, as well as increased E to E' ratio. That is noted at rest, so fits the diagnosis straightforward. The 2016 guidelines refer to the diastolic stress test, which is a helpful tool. In patients with a normal left atrial pressure at rest, the idea is that these patients, when they exercise, their left atrial pressure will go up and they will develop dyspnea. So if you have a patient who is already having an elevated left atrial pressure at rest, you do not need a diastolic stress test in this setting. To increase the specificity of the test and decrease the number of false positive calls just based on E to E' ratio only, the guidelines refer to acquiring both tricuspid regurg signals as well as E to E' ratio. That's the section in the guidelines which refers to the diastolic stress test. Another good reason to consider diastolic stress test is these are usually elderly individuals, and a stress test can uncover the presence of coronary artery disease as the cause of exertional dyspnea. Example of a positive stress test is shown here. We can see an Reduced annular velocities in the middle panel, both at rest with exercise. The mitral inflow changes from impaired relaxation to pseudo-normal, and the peak TR velocity goes from 2.5 to closer to 3.5. So all findings indicative of increased left atrial pressure. An example of a case that is applied here, you can see that if we look at the findings, the E to A ratio is between 0.8 and 0.9, but the peak E is more than 50. Left atrium is markedly enlarged. E to E prime ratio is 15. The TR jet is incomplete. If we apply the first algorithm, we have 3 signals, all of which are abnormal. We conclude diastolic dysfunction is present. We go to the next step of estimating wedge pressure, and we are in the middle panel. We have 3 signals to look at. The TR is incomplete, but we have 2 concordant signals. Therefore, this places the patient in grade 2 diastolic dysfunction with increased left atrial pressure. And the wedge pressure recordings confirm this, and these are decent wedge pressure recordings. You see both A and V waves in the wedge pressure recording, and a mean wedge pressure close to 28. An example from a patient with a depressed ejection fraction is shown here, and a quick review of this data shows you that the E to A ratio is more than 2. Everything else is clearly in the abnormal range. And if we go with the application of the guidelines, that places the patient in grade 3 diastolic dysfunction with increased left atrial pressure, readily confirmed by a mean wedge pressure about 25 millimeters mercury. These guidelines were looked at their accuracy in a large sample of 450 patients, and you can see here that the accuracy was much better than clinical evaluation of the presence of heart failure findings. With an accuracy of 87% compared to 72% for clinical. Importantly, if you look at the group of patients with an ejection fraction of more than 50%, about 240 patients, the accuracy here was much better than clinical evaluation. Clearly, an accuracy of 84% leaves room for improvement and hence the need for other signals. Left atrial strain is a promising signal. The reservoir strain that is recorded during systole is a metric of what happens to the left atrial stretch. And this left atrial reservoir strain is reduced in patients with increased pressure. However, the accuracy of left atrial reservoir strain is much better if you look at patients with depressed ejection fraction less than 50% as opposed to those with 50% or above ejection fraction. In particular, when the global strain of the left ventricle is 18% or above, there is no good accuracy. The strain does not detect the presence or absence of elevated wedge pressures to any satisfactory degree. A large study from the Mayo Clinic looked at 363 patients with proven diagnosis of heart failure, preserved ejection fraction based on cath, and here the sensitivity was pretty decent at 94%. So the specificity was pretty decent at 94%, but sensitivity was only 56%. A PR jet is very useful to the extent that pulmonary artery diastolic pressure is closely following left atrial pressure in the absence of pulmonary vascular disease. And so here, if you apply the modified Bernoulli with an end diastolic velocity of 2 meters per second, you can readily see that this patient has an increased left atrial pressure even before you add right atrial pressure. Speaking of right atrial pressure, it frequently tracks left atrial pressures in patients with heart failure, be it normal or reduced ejection fraction. This is data from the challenging group of patients with normal ejection fraction, and you see in general a decent correlation between them. An example is shown here where a patient with heart failure preserved EF has both right atrial pressure and pulmonary capillary wedge pressure elevated. Are these signals useful? Yes, useful as a surrogate, but if you have more direct evidence of left atrial pressure, they would be relied on more. I want to leave you with 2 points. One, the yield of indeterminate diastolic function is much less if you take into account all the data that we talked about. You should not stop at just the 4 variables of mitral inflow, annular velocities, LA volumes, or the peak TR velocity. Look at everything else you have in the study. I will close with a slide that addresses the echo diagnosis of heart failure, preserved ejection fraction. Remember, the diagnosis is a clinical diagnosis. It's not just echo findings. So you need to look at the clinical setting, look at the 2D data as we discussed before, look at all the indices of diastolic function, and including left atrial strain as needed. If you have a patient with borderline findings at rest, then consider a diastolic stress test to elicit their symptoms and the evidence of increased left atrial pressure. If we are still left with indeterminate data set, then the next step is to proceed to cardiac catheterization. Thank you.
Thank you very much, Sharif. That was a real state-of-the-art lecture. The next topic is a very important topic. Right ventricle has been kind of an orphan chamber for many years. In the evaluation of heart failure, we have always recognized that depressed RV is not good for a patient's health, but we have struggled with best ways to assess that. And our next speaker will help us with that, Dr. Nadim Fassa. It's one of our colleagues in the imaging division here at Houston Methodist. She is expert echocardiographer and also a member of our structural imaging team, supporting a lot of the catheter-based procedures. So it's my pleasure to introduce Nadim to us and to have her talk on right ventricular function, how to assess it. Nadim.
Good afternoon. My name is Nadim Fassa, and I'm one of the structural heart imagers at Houston Methodist. Today, I'll be talking about the right ventricle, how to evaluate its function, and its importance in heart failure. I have no disclosures. The objectives of my talk are to identify causes of RV dysfunction, highlight the role of echocardiography in the evaluation of RV size and function, and review the role of MRI in RV evaluation. Causes of RV dysfunction include RV pressure overload, RV volume overload, and RV cardiomyopathy. Causes of RV pressure overload that are important to recognize include pulmonary hypertension with its different types, pulmonary valve stenosis, pulmonary artery stenosis, and pulmonary embolism. RV low volume overload can be secondary to valvular regurgitation, systemic to pulmonary shunts, and high output states. There are various causes of RV cardiomyopathy, including inferior MIs, ARVC, dilated and hypertrophic cardiomyopathy, infiltrative cardiomyopathies, and RV dysfunction can occur post-surgery, post-LVAD, and secondary to chemotherapy. In normal circulation, and when you have normal systolic and diastolic LV function, the right ventricle really does not encounter much pressure secondary to compliant left ventricle and pulmonary vasculature. In contrast, in cases of systolic or diastolic heart failure, left atrial stiffness develops, leading to reduced pulmonary vascular compliance and increased pulmonary vascular resistance, and that increases the work that the RV has to do. This is why RV function is the barometer of all that lies ahead in patients with heart failure, and its function is an important prognostic factor. Echocardiography plays a major role in evaluation of RV size and function, and it's the first modality of choice for the evaluation of the RV. It's important to remember that multiple parameters and views have to be taken into consideration when evaluating RV size and function. Starting with the peristernal lung axis views, you can appreciate the anterior RV wall. The second view shows us the RVOT and the pulmonary artery, and the third view shows us the RV inflow, where you're able to visualize the tricuspid valve with its anterior and posterior leaflets. The short axis views are also very helpful. The first view shows us the basal RV at the level of the aortic valve and also shows us the tricuspid valve. The second view shows us the bifurcation of the PA, so you're able to visualize the RVOT. And then short axis views can be obtained at the mitral valve level and the papillary muscle level. Apical views are also very helpful in evaluating RV size and function. Starting with the 4-chamber view, you're able to visualize the lateral RV wall in the tricuspid valve. The RV focused view is the preferred view for measurements of RV dimensions, as we'll discuss later. The modified 4-chamber view gives us a good visualization of the lateral wall. The 5-chamber view shows us the anterolateral wall and the moderator muscle. And the apical coronary sinus view shows us the posterolateral wall. The subcostal views are also important in evaluation, and the 4-chamber subcostal view is the view we use to measure RV thickness. A short axis view can also obtain from the subcostal views and can show us the RV inflow and outflow. RV perfusion is mainly by the RCA, where the posterior descending artery supplies part of the interventricular septum. The acute marginal branch supplies the anterior and the lateral walls. The conus branch supplies the RVOT, and the LED supplies the apex, moderator band, and part of the interventricular septum. This is a case of a patient who presented with an inferior MI caused by an RCA occlusion, and the patient presented with hypoxia. The peristernal lung axis view here shows us RV dilation and systolic dysfunction. And the bubble study was performed, showing us a right to left interatrial shunt secondary to high right-sided pressures as a result of the RV infarction. RV size also relies on measurements at different views at different levels, starting with the peristernal lung axis view. A measurement of the RVOT diameter of more than 30 millimeters signifies RV dilation. RVOT proximal diameter using the short axis view of more than 35 millimeters signifies dilation. So does an RVOT distal diameter of more than 27 millimeters. The RV focus view is the apical view of choice when measuring RV size. RV dilation is defined as an RV basal diameter of more than 41 millimeters, RV mid diameter of more than 35 millimeters, and an RV longitudinal diameter of more than 83 millimeters. It's important to make these measurements using this specific RV focused view. The recommended parameter to assess RA size is the RA volume, and the normal ranges for 2D RA volumes are 21 plus or minus 6 cc's per meter squared in women, and 25 plus or minus 7 cc's per meter squared in men. RV thickness is measured using the subcostal view at end diastole. M-mode can also be useful in delineating the RV wall, and IV hypertrophy is defined as an RV end diastolic wall thickness of more than 5 millimeters. Switching gears to evaluation of RV function, fractional area change is one of the parameters used to evaluate RV function. And this is calculated by subtracting the end systolic area from the end diastolic area and dividing that by the end diastolic area. An abnormal RV fractional area change is less than 35%. 3D acquisition can also be very helpful in evaluating volumes and right ventricular ejection fraction. So using multi-beat RV focused 3D volumes, the volumes are calculated and then the EF is calculated. An abnormal RV 3D EF is less than 45%. The RV free wall strain is also another parameter used to evaluate RV function. And you want to make sure that you have a good visualization of the RV free wall before attempting to assess the strain pattern. And an abnormal RV free wall strain is less than 20. TAPSE, or tricuspid annular plane systolic excursion, is one of the most common methods in evaluation of RV function. And an abnormal TAPSE is defined as less than 17 millimeters. Again, you want to make sure you have clear visualization of the tricuspid annulus with proper alignment. Tissue Doppler of the tricuspid annulus is another commonly used method in evaluation of RV function, and an abnormal pulse wave Doppler of S less than 9.5 signifies an abnormal tissue Doppler of the tricuspid annulus. Estimation of PA pressure is key when you're evaluating RV size and function. The PA systolic pressure can be evaluated by looking at the peak TR velocity, looking at the continuous wave jet through the tricuspid valve. The PA systolic pressure is assumed to be equivalent to the right ventricular systolic pressure in the absence of pulmonic stenosis and equals to 4V squared plus the right atrial pressure. You can also obtain the mean and the diastolic PA pressures by looking at the pulmonary regurgitant jet, where the peak early diastolic velocity can be used to derive the mean PA pressure, while the end diastolic velocity is used to derive the diastolic PA pressure. Estimation of RA pressure relies on evaluation of the IVC and the collapsibility index. If the IVC diameter is normal, less than 2.1 centimeters, and collapses more than 50%, then that means a normal RA pressure of 0 to 5. If the IVC diameter is less than 2.1, but it collapses less than 50%, or if the IVC diameter is more than 2.1 and collapses more than 50%, That usually means an intermediate RA pressure of 5 to 10. If the IVC diameter is dilated more than 2.1 and collapses less than 50%, that means high RA pressures of about 15 millimeters of mercury. This is an example of pulmonary hypertension. The peristernal lung axis view shows us RV dilation and systolic dysfunction. The short axis views also shows us the RV dilation, systolic dysfunction, and flattening of the septum in systole and diastole. The apical four-chamber view again shows us an enlarged right atrium, enlarged right ventricle, and systolic dysfunction of the RV. The subcostal views can be helpful in also evaluating for right ventricular hypertrophy, which you can appreciate here and is secondary to pulmonary arterial hypertension. It's important to determine whether pulmonary hypertension is related to heart failure with reduced or preserved ejection fraction, or if it's related to other causes. And looking at the diastolic parameters can be very helpful in making that determination. For example, this is a patient who has a PA systolic pressure in the 60s, and looking at his diastology, you notice an E to A ratio of 2.75 with a septal and lateral E to E prime of more than 14 and a dilated left atrium. These all point towards heart failure as a cause of pulmonary hypertension in this case. So looking at the diastolic parameters can be very helpful in determining the cause of pulmonary hypertension. This is an example of a patient who presented with a saddle PE, and the echo was obtained to evaluate for RV strain, which can have treatment implications. Again, you can appreciate on this peristernal lung axis view that the RV is dilated and there's RV systolic dysfunction. The septum here appears paradoxical. On the short axis view, there's evidence of mild to moderate TR, and the PA pressure calculated from the TR jet is equal to 60 millimeters of mercury. Looking at the short axis view, you can appreciate the flattening of the interventricular septum, which suggests elevated RV pressure. And here you can appreciate the McConnell sign, which is a sign encountered in PE, where you have akinesis of the mid-RV wall and hypercontractility of the RV apex. What is the role of MRI in RV assessment? So MRI can be very helpful in the assessment of RV and diastolic volume and systolic volume, stroke volume, and EF. It's important for evaluation of intracardiac shunts and flows, determining RV mass, and looking at regional wall motion abnormalities and strain, and has a key role in assessing RV perfusion, edema, fibrosis, and necrosis. These are some of the cases that highlight the role of MRI in RV assessment. The first case is that of an inferior MI, and you can appreciate the enhancement in the inferior LV wall in addition to the RV walls. The second image shows us a case of ARVC with fibrosis in the right ventricular wall. Third image is that of a patient with amyloidosis, and you can appreciate the enhancement secondary to amyloid deposition. And the last one is a case of sarcoidosis, where you can appreciate the late gadolinium enhancement in the septum and the RV free wall. An important entity to recognize is arrhythmogenic right ventricular cardiomyopathy, which can be a cause of ventricular tachycardia and sudden cardiac death. And both echo and MRI are part of the diagnostic criteria. You have major and minor criteria, but basically what you want to be evaluating for is wall motion abnormalities, including akinesia, dyskinesia, or aneurysm in any of the RV segments, in addition to RV dilation. So this is a very important entity to recognize, can be suspecting by looking at the echo, and MRI can additionally provide diagnostic information. In summary, RV dysfunction can occur secondary to RV pressure overload, RV volume overload, or RV myopathy. Echocardiography plays an instrumental role in RV evaluation. Multiple parameters need to be taken into consideration when evaluating RV size and function. CMR additionally has a role in RV assessment and delineating the type of RV myopathy. Thank you so much.
Thank you. That was really an excellent presentation. Really great information on the RV. The next speaker is Dr. Tajik, who will be back to talk about current multimodality approaches to pericardial disease. He's well known for his work in pericardial disease when he was at Mayo Clinic for many years. Dr. Tajik.
Hello, everyone. Dr. Salerno and Quinones, ladies and gentlemen. Let's get started on discussion of pericardial diseases role of echo and multimodality imaging. This is an area where echocardiography came into being in the sense of detection of pericardial effusion. So there's a long and glorious history with pericardial diseases. And now with multimodality imaging, we have even more fantastic details obtained about the pericardium and associated myocardium. What we'll be discussing today is primarily echo findings supplemented by CMR, CT, and nuclear when needed. And these images will be shared with you in my presentation. So let me start off with the conclusion. Multimodality imaging is essential in diagnosis and management of pericardial diseases. Echocardiography is the initial test, and in my opinion, quite a bit of a gold test for majority of conditions that we encounter, such as pericardial effusion and constriction. Masses require further imaging with CMR, PET, or CT whenever tissue characterization is needed for edema, inflammation, and characterization of masses. So that's pretty much the summary of what my talk is sharing with you. Cardiac CT is fantastic for assessment of the structure and calcification. So thick pericardium demonstrated here in the CT, non-contrast, very clearly seen here. Calcified pericardium is beautifully seen with the CT scan. And absent pericardium, rare entity, but also nicely diagnosed by CT as well as by MR, but CT is my preference. MRI, on the other hand, is excellent for structure, hemodynamics, and inflammation detection. So you can see some of the findings on MRI of interventricular exaggerated interdependence. When these are playing, you can visualize it, these abnormalities. However, the inflammation is best seen on delayed enhancement images as shown here. So illustrative cases will highlight some of these findings. Here's a patient with constrictive pericarditis. Diagnosis is very nicely being suspected with these 2D images, with the septal shudder, as well as the exaggerated interventricular interdependence with respiration, and septal bounce is being visualized. Now we come to the Doppler findings, and you can start seeing with respirometer traces with inspiration and expiration, marked changes in the mitral inflow, tricuspid inflow, high in inspiration, reduced there. Dramatic changes in hepatic vein noted in this patient, that during expiration, diastolic reversals are evident. And that's very typical finding in the hepatic venous flow in constrictive pericarditis. And furthermore, note that during inspiration, there's very little augmentation of forward flow in the SVC. In fact, it gets reduced during inspiration, which is a sign of, at the bedside, called Kussmaul sign. So those are very typical Doppler findings. You saw typical 2D findings of constriction. Here is additional supportive findings for the diagnosis of constrictive pericarditis. Note septal TDI is much higher than the lateral one, which is the opposite of what normally is seen, and that's referred to as annulus paradoxus. And that's what you can also see in constriction. This individual had calcific pericarditis with constriction, marked constriction, and you can see calcium surrounding the heart, predominantly along the posterolateral wall of the left ventricle as well, and around anteriorly, and preoperative bullseye strain pattern. It was very interesting. You note here, all along the lateral wall, posterolateral wall, you can see that the strain is markedly reduced, well preserved in the all remaining segments, actually compensatory increase in the basal anterior septum and mid-wall. Postoperatively, with the total resection of the calcified pericardium, much better strain, not normalized, but much better in the posterolateral wall is noted. Patient had tremendous symptomatic improvement with pericardiectomy. Here's a young person, came from a military camp, chest pain, diagnosed with pericarditis, had a course of colchicine and improved. And then this recurred again. And then he finally was referred to us because of recurrent pericarditis, not responding to the usual measures. Note here in the long axis view, deformation of the posterior wall, the large echo free space posteriorly, noted here also along the posterior wall, inferior wall right there, extending this way. So we have complex situation here of individual with recurrent pericarditis and effusion, which is not a simple pericardial effusion. Note the septal shudder evident here in this short axis view very clearly with respiration. Doppler features of constriction, or now it will be zero constriction, effusive constriction, because there is localized effusion present. And also you can see it is Doppler features of effusive constrictive pericarditis, changing E, tall E and a smaller A is noted. On the mitral and tricuspid inflow, changes are occurring with respiration. The septal TDI is higher than the lateral one, although not as markedly so as the previous case, but still abnormal because septum should be always lower than the lateral TDI. Very marked, dramatic, diastolic expiratory reversal in the hepatic vein, and similar findings in the SVC, no forward augmentation of flow during inspiration. In fact, some reduction taking place. All features of constriction, and it is effusive constrictive features. MRI to the rescue and give more details about this localized pocket, large pocket of effusion. You can beautifully see it on MRI images right here, indenting the posterior wall. Here we see it, posterolateral wall there, localized area. Delayed enhancement image is the dramatic one here, and that referred by my MRI colleagues are saying very angry looking pericardium. It's all white, delayed enhancement, indicative of there is a lot of inflammation present. Here is the complex fluid in the middle of it. Delayed enhancement images again, 4-chamber apical long and 2-chamber views, and the arrows are pointing to the marked degree of enhancement and also surrounding the pocket of localized effusion, resulting in abnormal filling dynamics of this heart. This patient underwent total pericardiectomy very successfully and has done well as well. The third example is a 40-year-old with chest pain. It's also been recurrent chest pain in this individual. And you see already a big abnormality here. There's a left ventricle, septal jiggle is evident. RV cavity has been indented by something pushing from the outside, free wall of the RV there, resulting in narrowing of the tricuspid annulus as well. Now, here's a long clip from the subcostal, and you can see there's a large echo-free space that's evident around the right atrial annulus of the tricuspid valve and RV. Doppler profile shows some evidence of narrowing of the annulus, exaggerated increased velocities of the tricuspid inflow noted here, but no major constrictive features here. CT scan elegantly shows the collection of fluid, complex fluid in the location that we just saw on the echo. The size is 86 millimeters. MRI, cine image, again, very nice representation of the dynamics that we saw on echo. Now we see the whole picture nicely. And here is this big loculated area, some complex features to it. And the delayed enhancement image shows the inflamed pericardium. Well, here are different imaging displays, T1, T2, and of course, there's no enhancement in this area in T1 and no further brightening in this area either. So it's not with fat either. And perfusion shows lack of perfusion of this localized mass fluid complex region there. You saw the delayed enhancement, which is quite evident. Now here's a TEE examination, which was quite intriguing because it showed coming just close to the orifice of the right atrial appendage right here. This is the right atrium. You can see a mobile mass. And here we see this collection with a lot of echogenic material within this area. So with all these imagings performed, it was felt to be a very complex loculated fusion. Maybe it is purulent that was being suspected with vegetation extending out there. And patient was taken to the OR, total pericardiectomy performed. And here you can see from this all of the purulent material that was received, purulent pericarditis. This is the bacteria. It was successfully treated by our infectious disease consultants with antibiotics and has done well subsequently. My last case is of an 85-year-old lady presenting with progressive dyspnea and lower extremity edema. Echo shows this large posterior mass that is evident right here. This huge mass is evident. In this location, one starts wondering about hiatal hernia as well, masquerading like a mass. Patient was given some water to drink. No opacities appeared here. So this was very solid mass there, pushing the mitral apparatus inward as well. Here's further views of that mass, huge mass. Now we're looking at a different view here, somewhat confusing if you're not oriented to these subcostal images. LV short axis, RV here, and there's another mass in this region. So there are two masses now. There's one here, large one, posterolateral, and one is anteriorly located. 85-year-olds, of course, we are thinking of malignant processes as well. CT scan, again, very nicely shows the extent of these two masses. And here's the MRI, the anterior mass, posterior mass, complex appearance. What is next to do here? More MRI images, of course, different sequences were utilized to get better insight into the tissue characterization here. And Dr. Shah in the audience can read these and tell us what the diagnosis is. To us, we rely on experts like him, our own experts here, Dr. Galaska and Dr. Muthukumar, involved in this case, provided that this is a very complex, not simple cyst and so forth. Clearly, enhancement is evident. So there is evidence for inflammation. So is there a malignancy here? PET FTG did not show any uptake there or in the lungs or in the body. So that was quite reassuring that there is not a metastatic lesion here, primary or secondary, of course. And with that information and compression of the heart and symptoms, patient underwent surgery where the anterior mass was readily resected. It was a complex cyst with hemorrhage in it. And the posterior could not be completely excised because of its location, but felt to be also the same entity there. Cysts surrounding the heart with hemorrhage in them and appearing complex and producing compression. So conclusion would be that multimodality imaging in pericardial diseases is a very robust way of fully diagnosing different pathologies here. Echo is a workhorse for pericardium. CT, MRI adds additional important pieces of information. PET FDG, PET for inflammation and metastases detection, and for other uncommon conditions as well, diagnosis is made. Thank you so much, and I wish to also thank my colleagues, Patricia Galaska and Lakshmi Muthukumar, of the multimodality imaging expertise that they provide to our group here, and really indebted to them for the images they have provided, and of course to Matt Umland and Chris Kramer, who have been the backbone of echocardiography practice at Mayo and now here at Aurora St. Luke's Medical Center. Thank you all.
Thank you, Jamil, for another state-of-the-art lecture as we have been used to listening from you. I'm delighted to present our next speaker, which is my co-moderator, Dr. Michael Salerno, Director of Cardiac MRI and Echocardiography at Stanford. And you all have already heard him this morning. So without any delay, Michael is going to talk to us about CMR in heart failure, a very important topic. Michael.
Thank you very much for the invitation to give this talk. I'm going to be talking about CMR and heart failure, assessing etiology and prognosis. Here are my disclosures. And so my learning objectives for this talk are to help you understand the unique information provided by CMR in the assessment of patients with heart failure, to help you understand how CMR can help assess prognosis in heart failure, and to show you how to integrate CMR into the routine evaluation of patients with heart failure. So in this talk, first I'm going to talk about some of the techniques, then I'm going to talk about assessing the etiology of heart failure, and finally I'm going to talk about specific cardiomyopathies. So CMR, as you know, provides a comprehensive evaluation of heart failure, including anatomy, function, myocardial edema, stress perfusion, focal fibrosis and scar, and diffuse fibrosis and infiltration. And when you look at the AUC guideline for heart failure and cardiomyopathy, CMR is given an appropriate indication for the initial evaluation of known or suspected heart failure based on signs and symptoms, and an appropriate indication for cases where it's suggestive that there is an acquired or inherited cardiomyopathy, including restrictive, infiltrative, dilated, and hypertrophic. And then as an additional testing after TE, you can see that CMR has a number of appropriate indications, including evaluating systolic function, looking at pulmonary hypertension, excluding CAD in patients with heart failure and angina, helping to define undefined cardiomyopathies, and then evaluation of sarcoid amyloid cardiomyopathy, hypertrophic cardiomyopathy. So what are the techniques that we use? We use cine imaging, usually in short and long axis images. We use native T1 mapping, which can help us look for focal fibrosis or edema. We use, in the cases when we're worried about an acute process, we can use T2 mapping to look for acute injury and myocardial edema. When we're interested in looking at iron overload, we'll do T2 star mapping. We'll also sometimes use T2 star mapping for coronary artery disease when we're looking to evaluate hemorrhage. We do and then late gadolinium enhancement and post-contrast T1 mapping in order to calculate the ECV. And a key important point is differentiating ischemic versus non-ischemic causes. Ischemic causes will tend to be either subendocardial or transmural, whereas non-ischemic causes may be mid-myocardial or subepicardial. And over time, there's been different patterns of late gadolinium enhancement that have been established to differentiate between different etiologies of cardiomyopathy. The other point I want to make is looking at T1 and ECV in clinical practice. So the extracellular volume, when this is markedly elevated, you have to think about AL amyloid or ATTR amyloid. And when the native T1 is reduced, the two pathologies to think about are Fabry's disease and iron overload cardiomyopathy. So let's go through some cases. Here's a 50-year-old man diagnosed with hypertrophic cardiomyopathy after having a preoperative EKG for knee surgery. And you can see that he's got marked hypertrophy in his anterior wall, as well as in the septum, with particular thickening in the mid septum consistent with a reverse septal hypertrophy pattern. His late gadolinium enhancement included the areas of hypertrophy as well as a more diffuse fibrosis through his apex with a LV scar mass of 23%. His T1 maps demonstrated increased extracellular volume fraction and pretty normal native T1. So what do we know about the prognostic utility of LGE in late gadolinium in hypertrophic cardiomyopathy? This was work we did a few years ago as a meta-analysis, and it's predictive of cardiac death, sudden cardiac death, heart failure, and all-cause mortality. And if you look at these odds ratios, they're very similar to those of the traditional risk factors. This study by Chan et al. Showed in 1,293 patients referred for CMR with 3.3 years of follow-up that the adjusted hazard ratio for sudden cardiac death increased by 1.5 for every 10% increase in late gadolinium enhancement. And they defined a threshold of an LGE greater than 15% of the LV mass was associated with twice the risk of sudden cardiac death. And in the new HCM guidelines, there's a number of indications for CMR, including helping to find patients who are at high risk, who are not otherwise defined at high risk from family history or other risk factors. So here's a second case, a 27-year-old male, acute chest pain, suspected myocarditis. He's got mildly reduced LV systolic function that's somewhat global, maybe slightly worse in the lateral wall. When we look at his T1 maps, he shows evidence of increased native T1 in the infralateral wall and the lateral wall, here also seen on the forechamber. After gadolinium, where the shortest T1s are going to be where there's scar, we can see that there's going to be evidence of late gadolinium enhancement in this lateral wall. When we look at the T2 maps, they also show evidence of edema in this area, and the ECV maps show increased ECV along this area in a pattern consistent with myocarditis. Here's his late gadolinium enhancement images, which again show scar in a sub-epicardial distribution in the lateral wall. So what do we know about using parametric mapping in myocarditis? In a large study that was done in JACC, the best technique in terms of diagnostic performance was native T1 with an area under the curve of 0.82, significantly outperforming the traditional Lake-Lewis criteria. We performed a bivariate meta-analysis, and in this study, we showed that indeed the main thing that drove this difference was that the sensitivity for T1 was higher than the other techniques with a similar specificity, resulting in a higher diagnostic odds ratio. And in the revised diagnostic criteria for myocarditis, T1 and T2 mapping are now prominently included. Myocardial edema by T2 mapping or T2 weighted imaging, and then non-ischemic myocardial injury is given by abnormal T1, ECV, or late gadolinium enhancement. All right, here's another case. Here's a case. It was a 67-year-old female who presented with heart failure symptoms. The LV function looked normal. There's left atrial enlargement. If you look carefully, there's evidence of pericardial thickening as well. So this EF was normal. When we look at the late gadolinium enhancement images, we can see that there's evidence of scar in the septum, anteroseptum, basal anteroseptum, and then the mid wall. And if you look carefully, you can see that there's also evidence of pericardial delayed enhancement. And this patient was diagnosed with sarcoid. Here's the T1 maps in this case with areas of scar showing mildly increased extracellular volume fraction. So how useful is LGE in sarcoid? This study out of the University of Chicago looked at 205 patients. 20% of these patients had LGE. Of the patients that died, 83% were in the LGE positive group, and LGE burden was the best predictor of death and ventricular tachycardia. In terms of prognostic utility, the presence of scar in a relative sense is even more useful in the patients that have well-preserved EF, where the differential of having an abnormal LGE puts you at higher risk than other people with a normal LV function. And the HRS consensus statement says that if patients have any symptoms, an abnormal EKG or an abnormal echo, they should go on to having CMR or FDG PET. And this is a class 2 indication. And the joint position paper on cardiac sarcoid suggests that CMR is really the preferred first test. If it's normal, they can undergo clinical follow-up unless there is a high suspicion under which FDG is reasonable. If FDG is positive, consider immunosuppressive therapy. And if CMR is positive, consider ICD. Here's a fourth case. This is a patient with new onset heart failure. The left ventricle shows wall thickening. The native T1 is markedly elevated. The ECV is markedly elevated. And the PSR-IR shows patchy late enhancement. And CMR can have a number of roles in assessment of amyloidosis, including the assessment of new onset heart failure symptoms suspicious for cardiac amyloidosis, patients where there's a high clinical suspicion of amyloidosis that's uncleared by echo, as well as to evaluate AL amyloidosis. And LGE has been shown to be associated with an adverse prognosis in amyloidosis. Furthermore, parametric mapping with either ECV showing the highest diagnostic utility or native T1 have a very high area under the curve. In fact, if you use an approach of first looking at non-contrast CMR, if they have a markedly elevated native T1, it's diagnostic for cardiac amyloidosis. Whereas on the other side, if they have a normal native T1, it has a very high negative prognostic value for predicting amyloidosis. And in an intermediate range, we really need to think about giving contrast. Native T1 and ECV are both prognostically useful in predicting adverse outcomes in cardiac amyloidosis. And here we can also see that it correlates with the grading of the severity of the amyloid deposition. In terms of the diagnostic performance, LGE has the highest diagnostic odds ratio, which is significantly higher than that of late gadolinium enhancement. Again, consistent with the idea that ECV is probably the best diagnostic tool. In terms of prognosis, ECV had a higher hazard ratio than either LGE or native T1 for predicting adverse outcomes. When we look at iron overload cardiomyopathy, this is a 35-year-old male, sickle cell disease with new onset heart failure. And he has a markedly reduced native T1, T2 star, and T2 map diagnosis of iron overload cardiomyopathy. And in terms of prognosis, it's been well demonstrated that patients with less than a 10 millisecond T2 star have a high likelihood of developing heart failure within a year. Last thing I want to talk about is patients that have, this patient that has no known CAD with angina and heart failure. They had mild troponin elevation, and they were referred for CMR for evaluate for ischemia and viability. Here is the cine imaging showing markedly reduced LV function. The EF is 24%. Here is the CMR stress perfusion imaging, stress on the top, rest on the bottom. And we can see that there's clear evidence of inducible ischemia in the LAD territory, RCA territory, and mildly in the circ territory as well. He has no evidence of late gadolinium enhancement, so this is evidence of ischemia without any underlying scar. And he had a high-grade lesion in his right coronary artery and a high-grade lesion in his LAD. So the last quick case here is a 51-year-old female admitted with acute systolic heart failure. Her cath showed no coronary artery disease. She had a family history of CHF and had a Holter with frequent PVCs. So she was sent for a cardiac MRI for evaluation of cardiomyopathy. And we can see here her EF is 29%. When we look at her late gadolinium enhancement, we can see that she's got mid-wall late gadolinium enhancement, consistent with a pattern of dilated cardiomyopathy, likely familial in this case. The pattern of late enhancement is useful for differentiating ischemic versus non-ischemic pattern, and the presence of subendocardial ischemia is subendocardial scar is helpful for ischemic cardiomyopathy. We know among those that have a non-ischemic pattern, the presence of a mid-wall stripe is associated with adverse prognosis. And when we look at a meta-analysis looking at all-cause mortality, heart failure mortality, and sudden cardiac death, non-ischemic myopathy with scar is predictive of adverse outcomes, resulting in higher pooled annualized event rates. This has been meta-analyzed more recently, demonstrating that the presence of LGE and non-ischemic cardiomyopathy portends a worse outcome. T1 mapping has also been shown to be prognostically significant, and it's actually the best predictor of adverse events in multivariate analysis. So in summary, cardiac MRI provides a comprehensive assessment of cardiomyopathy. It can differentiate between ischemic and non-ischemic causes, and it plays a pivotal role in differentiating between etiologies of cardiomyopathy, and provides important diagnostic and prognostic utility for multiple cardiomyopathies. Thank you very much for your time. All right, our next speaker will be Dr. Mouaz Al-Mallah, who's the Beverly B. and Daniel C. Arnold Distinguished Chair and the Director of Cardiac PET at Houston Methodist. And he'll be talking about amyloidosis and sarcoidosis, the role of PYP and PET imaging. Dr. Mallah.
All right, let's talk now about the role of nuclear cardiology in the assessment of amyloidosis and sarcoidosis. And these are new frontiers for advanced cardiac imaging, and they have been utilized now increasingly in clinical practice. And I will show you why is that and how can we use these new tools to help and benefit our patients. These are my disclosures. All right, let's start with sarcoidosis. And we're using sarcoidosis here as a prototype for inflammatory cardiomyopathy. So what I'm gonna say today about sarcoidosis applies to other inflammatory cardiomyopathies. And most often we start in the assessment of these patients with echocardiography and then move on to MRI because we try to see if there is late gadolinium enhancement in these patients. Most often, if you don't find the late gadolinium enhancement in these cases, then you probably don't need to go further to cardiac PET unless your CMR is inconclusive or you have high suspicion of cardiac sarcoidosis. Among patients where you demonstrate late gadolinium enhancement, even if it is a small percent, then you may need to do another testing, namely FTG PET, to primarily to see if this late gadolinium enhancement represent active inflammation or this is the sequelae of prior inflammation that the heart has already healed. So if you do a cardiac MRI, this is a pathognomonic kind of type of late gadolinium enhancement where it is epicardial, and you can see it is involving the anterior wall, anterior septum, and the septum, and also involves RV3 wall in this case. And this patient actually, when you take them to PET, first you have to prepare them specifically because we want to prevent the normal myocardium from uptaking FTG. So what we try to do is that we tell them to have low carbohydrate diet for the first 24, sometimes even 48 hours before they come to the test. Then we ask them to fast for about 12 hours. This is our sample of what they can potentially eat. Definitely no bread or carbohydrates or adding sugar to their food. Then on the test day, when they come to us, we do perfusion imaging to see if there is any evidence of perfusion defect, like in this case where you see a perfusion defect in the anteroseptal wall, similar to the patient we just saw the MRI. And then we give them heparin to increase lipolysis and provide free fatty acid in the blood, wait for 15 minutes, go ahead, inject the FTG, wait another 60 minutes, and then image the patient. And now we get the metabolic assessment where we see now this FTG uptake is really not representing the myocardial FTG uptake, but rather the inflammatory cells that are sitting inside the myocardium, next to the myocardial cells, and we're trying to image the macrophages and the white blood cells that are there. This is how a normal study would look like. This is a myocardium, and there is no FTG uptake, and all the FTG remains in the blood pool. On the other hand, you see here, this is how we look at it on the regular nuclear display where there is a perfusion defect, so there is likely a scar, but there is no FTG uptake in this patient. But when we go to an abnormal study, now you see that there is a perfusion defect here. So there is a perfusion defect, and there is a perfusion defect in the anteroseptum. And now you see that there is FTG uptake in that territory, suggesting that this patient is having active inflammation in the myocardium. And we are imaging here the inflammatory cells, namely the macrophages and other inflammatory cells. If we use the fusion display, now you see that the inflammation is in the septum, you see it in the lateral wall, but interestingly, we're starting to pay more attention to when you see it in the left atrium, and this has been correlated in some anecdotal cases with some atrial arrhythmias. You clearly see it here in the left atrium and significant FTG uptake in this patient. It correlates well with MRI. So this is the patient I showed you. There is this pattern of delayed enhancement. There is a perfusion defect, and there is the FTG uptake. You can see here that we know that this late gadolinium enhancement is primarily representing active inflammation. We not only detect cardiac sarcoidosis, but we can also see sarcoidosis outside the heart in our field of view, like in this patient, where he has significant FTG uptake in the lung with active pulmonary sarcoid. And you can also see here that the presence of FTG uptake suggests that these patients do worse. And the presence of FTG uptake with abdominal perfusion is the worst, has a worse prognostic value for these patients. I think the main added value of PET over MRI is the ability to follow these patients over time. And with MRI, most often, if you have LGE, it may change a little bit, but most often you cannot use it to trace significant improvement in left ventricular function, or you cannot use it to trace significant improvement in the inflammation or reduction in the inflammation. But what you see here, for example, this is a patient who has significant inflammation, significant uptake in the inferior wall, and it is all gone post-therapy. And if you look at it in another way, here you see all this inflammation and uptake, and now we do see nothing in the same area. So this is a patient where we see the effect of therapy on these patients with cardiac sarcoidosis, which provide us with a tool to follow the response to therapy and adjust their immunosuppressive therapy. So with working with our heart failure team, we often use PET to intensify or lower the intensity of immunosuppressive therapy in these patients. So an important tool to make the diagnosis, but also to follow these patients up for the impact of therapy on active inflammation. Let's move on to another disease, amyloidosis, and you can see that there is a huge interest in amyloidosis in the past 5 years, a significant increase in the number of publications that we are seeing in the literature about amyloidosis. This is partly fueled by the fact that we now have therapy for ATTR amyloidosis, and we want to accurately identify that. And again, similar to sarcoidosis and inflammatory cardiomyopathy, most often we are starting with echo and MRI. I'll show you an MRI here of a patient who presented with heart failure symptoms, and you can see that there is significant restrictive cardiomyopathy, left ventricular hypertrophy, no motion of the mitral annulus. You can see significant mitral regurgitation. So all of this suggestive of amyloidosis or restrictive cardiomyopathy. But I think it's very important to also note that on these patients we have inability to null the myocardium, and this is pathognomonic almost for patients that late gadolinium enhancement pattern is pathognomonic for amyloidosis. However, with MRI, we are unable to determine the differences between the different types of amyloidosis, namely AL and ATTR, and that's why we need another tool to add to the workup, so we are able to differentiate between ATTR amyloidosis and AL amyloidosis. As you know, the management of these patients, two diseases, is very different. And now we have this new tool, which is PYP SPECT imaging, which allows us to image these patients. PYP is a bone scan agent, so you can see the bone is lighting up. And we are trying to see if the myocardium would uptake this tracer. And if there is uptake, this is ATTR amyloidosis. If there is no uptake, this is very concerning for AL amyloidosis. However, the diagnosis is not only made based on imaging. You do need to check kappa and lambda in the blood. So you need to do the immunofixation, because PYP will only work after you have ruled out AL amyloidosis by blood testing, looking at kappa and lambda immunofixation. So how do we interpret these images? First of all, we acquire planar images, and this is where the heart is. This is the sternum. We try to look at that uptake in the heart or not. And we can start with zero uptake, that we call grade 0. If there is uptake but less than the bone, that's grade 1. If there is uptake more than the bone, that's grade 3. And if it's equal to the bone, that's grade 2. But we have taken this even and extended to a higher level, and now we can even create a ratio of the heart to contralateral lung ratio. So we draw an ROI over the heart and lung, and we try to see the ratio, whether it is more than 1.5 or less than 1.5. If it is more than 1.5, as you see in this case, that is diagnostic of ATTR amyloidosis in a patient with normal kappa and lambda proteins. And it is very accurate. In this meta-analysis of 6 studies and 529 patients, the sensitivity is 92%, and specificity is above 95% with a high positive likelihood ratio. So it's a very helpful tool to look for this, and it does predict outcome. So a heart to contralateral lung ratio of more than 1.6 is very diagnostic, is associated with worse outcome of these patients. There are additional tools that we have used in the past few years to kind of help us identify those patients more accurately. So we can use SPECT imaging, not only planar imaging, to look for uptake. And if you see an uptake like this, similar to your regular nuclear scan, that's even more reassuring in these patients, because sometimes this could be due to blood pool, especially among patients with reduced left ventricular ejection fraction. So SPECT imaging for these patients allows you to avoid overlap with bone uptake, help you distinguish the blood pool activity from myocardial activity, and this is probably the most common cause of false positive, and also look at the distribution of myocardial PYP, and also help you identify the PYP uptake in the septum if you want to do a biopsy, and potentially have another way to quantify the myocardial uptake compared to the rib uptake. So here you have a patient where I'm seeing that the uptake is, the ratio is 1.5 at 3 hours, it's 1.57 at 1 hour. But then when I do the PYP SPECT imaging, and specifically we are doing now SPECT CT, you can see that most of the uptake in septum, a little bit in the lateral wall. And this is not a blood pool activity. This is a true positive case. You have to be aware of the false positives and false negatives. There's a long list of these, but the most common causes that I would like to point out for false positives is a blood pool, and does help you to do SPECT imaging to kind of sort it out. Recent MI could be another cause. For false negative, certain mutations, the full-length mutations, TTR fibril, full-length TTR fibril mutations. Early disease has been associated in some studies with false positive, negative, and also delayed imaging have been associated with false negatives, as well as many others that you see on the list here. And now we have new tools to allow us to look for those patients and even appropriate use criteria to guide you when to order these tests. And I just wanted to highlight few patient population where it is very appropriate and you have high yield in these. So screening for cardiac amyloidosis and new symptomatic heart failure, especially among African American age more than 60 with unexplained heart failure, or among those patients with increased LV wall thickness or unexplained heart failure and increased LV wall thickness, and non-African American patients, all of these are appropriate to go down the pathway of assessment. And also, finally, among those who have the gene mutation, you can potentially do a baseline PYP to see if they have uptake, because now a lot of people are doing their genomes and look for a specific gene mutation. And if you know that the patient has a gene mutation, you can potentially look for this uptake. And if there is uptake by PYP, then you can consider preventive treatment, or there is no uptake, you can repeat it after 2 years, and then if it remains negative, then this is a low risk for development of ATTR cardiomyopathy. So with this, I'm going to stop, and thank you for your attention.
Thank you so much, Mouaz. That was an outstanding talk. If any of you are practicing in a tertiary care center where you manage a lot of complex heart failure patients and heart transplants, you are familiar with patients with LVADs, and you know how difficult sometimes it can be to assess these patients, the function of the LVADs, and so on. So to talk to us about that, it's my pleasure to present Dr. Mohammed Chamsi-Pasha, who is a member of our multimodality imaging faculty with expertise in echo, CT, and CMR. So Dr. Chamsi-Pasha is going to talk to us about how to assess patients with LVADs.
So hello, everyone. My name is Mohammed Chamsi-Pasha, and I'm going to be talking to you about the role of multimodality imaging in ventricular assist device. The outline of this topic will be briefly talking about the echo imaging and reporting protocol. We're also going to be touch basing on the role of cardiac CT in detecting LVAD complications, including inflow obstruction, outflow kinks, and thrombosis, along with the role of CT in functional assessment. And we're also going to be touch basing briefly about the role of PET in detecting LVAD infections. Special thanks to Dr. Kasi for sharing some of her slides for this talk. This was the American Society of Echocardiography guidelines in echocardiography, managing patients with ventricular assist device, published in 2015. These are kind of the three currently available ventricular assist device prototypes. So basically from the axial flow pump, which is the HeartMate 2, you see the pump rotor here with the inflow and outflow graft cannula, to basically the most recent iteration of those ventricular assist devices, which is manifested by the HeartMate 3, which is a magnetically levitated rotor in a centrifugal pump, where you can actually see the integrated intrapericardial inlet cannula along basically with the outflow graft in this case. The hardware or the HVAD basically has a very similar design to the HeartMate 3. So this is basically how we can detect the ventricular assist devices on three-dimensional CT using volume rendered imaging. You can actually see here the inflow cannula, the pump, and the outflow cannula in a HeartMate 2 device. And here basically you can see both the hardware and the HeartMate 3, where you can see actually the pump rotor, the inflow cannula, and you can actually see the outflow cannula and both images for both devices. Obviously, when we go to the echocardiography in serially assessing patients with LVAD, it really gives a important perspective of preoperative patient selection who would benefit from LVAD either as destination treatment or as bridge to transplant. The role of echo and perioperative imaging is crucial, and also in postoperative surveillance of these patients, optimizing left ventricular assist device function, troubleshooting alarms, and then evaluating native myocardial recovery. It's always important in our echocardiography report to specify the device type, the pump speed settings, along with the blood pressure if the patient does have a pulse. And really the role of echocardiography is, as we said, in surveillance, optimizing LVAD function, troubleshooting, and basically picking up LV functional recovery. And when we want to troubleshoot ventricular assist devices, we want to see why the patient did or did not have any suction events, assessment of aortic regurgitation, pump thrombosis, low flow alarms, and RV failure. What the heart failure physician is looking for on an echo are the followings: chamber sizes to see whether or not the ventricle, especially the LV, is unloaded. With a higher rounds per minute, the LV cavity shrinks. LV and RV function and septal position, that's also critical. Inflow and outflow cannula velocities. The inflow cannula is usually directed towards the mitral valve, and it's located at the distal apex. And a velocity of more than 1.5 to 2 meters per second, it really suggests inflow obstruction. And the HVAD is a specific ventricular assist device that really causes Doppler artifact, rendering those signals from the inflow cannula uninterpretable for velocity measurements. Filling pressures are also kind of critical, using the E to A ratio, looking at the valves, and more importantly here is the aortic valve opening. During systole, how frequent does it open, along with the extent of opening? Aortic regurgitation, which is a poor prognostic sign, always use the M mode and M mode color. Doppler would be helpful for assessing regurgitation severity. Mitral regurgitation, tricuspid regurgitation, because they give a sense of cardiac volumes, and Doppler-derived pulmonary artery systolic pressures. This is basically a standard echocardiographic parasternal long axis view on a patient who has a dilated ventricle, an aortic valve that has a very brief intermittent opening, in a patient who has a heart rate 3 at 5100 RPM. The M mode was very helpful here to show the pulsatility of this ventricular assist device, showing the brief opening of the aortic valve. You can actually see that there is a mild aortic regurgitation, mild mitral regurgitation, and still what appears to be a dilated, severely dysfunctional left ventricle with a favorable inflow cannula location at the distal apex directed towards the mitral valve. The septum appears to be overall in a neutral position. For our sonographers, use of contrast echo for LV opacification really can give a paramount information about accurate LV chamber sizes by volumes, function, and also the detection of intracardiac thrombi in these patients with ventricular assist device. Here's a case of an old gentleman who basically has had a destination treatment, heart rate 2, and he basically was noted to have suction alarms on his LVAD device. What you can actually see here on the parasternal long axis view, looking at the inflow cannula, you really have a color aliasing. And when you put the continuous wave Doppler on, you have a peak velocity of almost approaching 4 to 4.5 meters per second. So this is actually a case where you can see on the apical views, the cannula is abutting the apical myocardial segment wall, as seen here on the short axis. And that's basically the cause of the suctioning, and the alarms on his VAD is because of the proximity of the inflow cannula to the LV myocardium, causing this suctioning alarm and high inflow cannula velocities. This is a case actually with a ventricular assist device patient who actually has a significant bowing of the interventricular septum from the right to the left. And that basically can be seen in patients with significant RV volume overload in the setting of significant tricuspid regurgitation. Echocardiography would be critical to look for sources of embolism, and stroke is actually not uncommon in our LVAD patients. You can actually see this patient who has a severely dysfunctional LV and RV with a heart rate 3. And what you notice actually on his aortic valve, that there are basically some mobile and immobile large densities on his aortic root on this short axis view, which is basically all full of clot. And that basically can be a source of embolism in these patients with ventricular assist device. This is again the same patient with basically severely dysfunctional LV and RV, and you can actually see that there is just blood stasis because of really lack of native myocardial contractility, which puts patients at risk for intracardiac thrombosis. Aortic regurgitation, we do know that continuously closed aortic valves, they are exposed to high pressure gradients, and the new onset aortic regurgitation could be seen in 25 to 30% in 12 months after a ventricular assist device, and it's known as an adverse marker for LVAD functionality. It carries morbidity and mortality. These are some transesophageal echocardiography in a patient with a ventricular assist device, and there is basically significant eccentric aortic regurgitation, which seems to be opening with every cardiac beat fully. And what you actually notice here on these 2D images, that there is actually a small mobile density along with this aortic valve, and this is really suggestive of vegetation, and there is a suspicion for a perforation of this valve causing the hemodynamically significant aortic regurgitation. Functional recovery on HeartMate 3 can be seen in probably 5% of patients with a ventricular assist device. You can see actually a decent fractional shortening on this parasternal long axis. On this short axis view, you probably have an estimated ejection fraction of 50 to 54% on this patient. And basically that echo would be your first line tool to assess for functional recovery on ventricular assist device. The advantages of cardiac CT, if we shift gears here, is it gives you a three-dimensional view of the whole heart, much higher spatial resolution, a large volume of coverage, and functional assessment can be done using retrospective gated images. Inflow cannula position basically can be very well assessed on CT because we do know that malposition is linked to pump thrombosis, stroke, and inotrope dependence. So you can actually see here, this is a favorable inflow cannula position in the distal apex, and it's kind of directed towards the mitral valve, while this one here is kind of more directed towards the interventricular septum, and this one here is outside the distal apex, it's kind of more directed towards the RV apex, and that's basically a very unfavorable cannula position. The outflow cannula can also be assessed nicely on contrast-enhanced cardiac CT. You can actually see this cannula, which is basically, or graft that's basically open and free of any kinking, air, or obstruction. You can actually see this kink in these distal segments on this outflow cannula, along with this segment here, where there is basically some growth or tissue growth within this outflow cannula causing a kink. And actually, after they have, you can actually see how this will affect the flow through this LVAD in the presence of a kink. And after they lengthened this outflow cannula, the flow increased from 2 liters up to 6 liters. And that basically had to be done surgically. This is a young patient, 43 years old with a stroke, post-HeartMate 3. You can see actually the HeartMate device sitting in the LV apex, slightly angled away from the mitral annulus, but you can actually see that there is a thrombus located on the right cusp of the aortic valve, seen here on the 3D volume rendered images along with the short axis. Large echo density located at the right coronary cusp, and this is an aortic root thrombus. This is basically another extreme case of a root thrombus that's extending all the way to the right coronary artery. This is a curved planar reformat showing the clot extending to the proximal right coronary artery. We do know that aortic root thrombus is associated with ventricular tachycardia, RV failure, myocardial infarction. This is a beautiful retrospective gated cardiac CT showing complete functional LV recovery while basically on LVAD support, and these people basically could be considered for LVAD explantation. This is your apical 4-chamber view, and this is your parasternal long axis view showing that nicely. The importance of surveillance testing has become really important. This is the outflow cannula that's free from any kinking and obstruction, and this is a severely narrowed and almost obstructed outflow cannula basically from this extra cannula growth that can basically be affecting flow in these patients. This is an outflow cannula thrombus, nicely seen on cardiac CT with a very large Hausfeld unit. Pericardial tamponade can also be detected on cardiac CT. This is a large pericardial fluid that's kind of surrounding the outflow cannula. You can see the inflow cannula here. But remember that loculated and small fluid collection can really cause significant tamponade without evidence of tamponade physiology on echocardiography. So that's really critically to detect. And RV function on CT can also be nicely assessed. There is a severely depressed RV function on this retrospective short axis LV, and you can actually assess the RV function on this apical 4-chamber view in the setting of the retrospectively gated CT. Just to finish up with the role of PET in LVAD, you have a 47-year-old male here who had a HeartMate 3 as destination therapy, was admitted with a group B streptococcus bloodstream infection and was noted to have endophthalmitis and brain bleed. So when he actually had a cardiac CT, there was this large texture of density of both hypodense and hyperdense fluid collection anteriorly, basically to the aorta. And basically there was a concern that there might be an LVAD leak surrounding this outflow graft. So there was actually a patient that underwent an FDG PET. And what you can see actually here, these are the CT attenuation corrected images. And you can see this diffuse FDG uptake across the entire left ventricular assist device system. This is the outflow graft, and the SUV max here was almost 9.5, which is highly suggestive and concerning for infection. With that, I would like to conclude, and thank you so much for your attention. And I hope you find use and joy in this conference.
Thank you. Thank you, Mohammed. That was excellent. Sorry, I interrupted my co-check. So we have about 15 to 16, 17 minutes for QA. And as we start seeing questions come in, I wanted to ask Dr. Tajik and Dr. Salerno to comment on a clinical issue, which is the following. We have now, with strain, a multitude of studies showing that patients with HFpEF, and as we start seeing questions come in, I wanted to ask Dr. Tajik. Am I talking or not? Comment on what is this?
Why am I hearing LIVESTREAM back?
Okay. Are we good? Are we okay? All right. So here's the question. There's very strong data that in patients with different forms of heart failure, but particularly just the universe of HFpEF and HFrEF, those with bad strain, low strains, let's say under 10, usually under 8, have much worse prognosis. The data is very strong on that, and it's better than ejection fraction. With CMR, we also are getting more and more data of the impact of scarring, increasing delay enhancement on prognosis. So the problem for the clinician is, what do we do with that data? And I'm not talking about hypertrophic cardiomyopathy. I'm talking about the universe of routine patients we see with heart failures. So if you have two patients with an ejection fraction of 60%, but one has a strain that is very low compared to the other, or one has more scarring in the myocardium compared to the other, what does that tell the clinician as to what to do? Do we have a different kind of aggressive therapy we should use? If you have two patients with HFrEF, both have an EF of 30%, but one has a very low strain, one has a better strain, both are New York Heart Class Association 2, should the patient with a worse strain be considered sooner for transplant? So as clinicians, we're confronted with data that tells us that the patient has a worse prognosis, more likely, but we don't know what to do with that data. And my question to the two of you that I like your comments is, has the time arrived that we need to start doing some randomized clinical trials using this kind of data to eventually develop guidelines to help the clinicians decide on what to do with patients who have these results that predict a worse outcome, but not necessarily tells us what to do? So I'd like to have Jamil and Michael make a quick comment on that. Did that get through, or? Yeah, okay.
You're muted, Michael.
Yeah, so one issue is the fact that we know that low GLS predicts adverse outcomes, but the second question is, how exactly do we use that information to guide what we do in terms of therapy? And I think this is actually a really important question, and really comes down to, is GLS alone sort of specific enough to really tell us exactly what's going on, or is this really a spot where having the information that you can gain from different techniques such as MR, other techniques, can really help guide therapy?
Yeah, and the problem that the clinician has is that the the data doesn't always go with symptoms. So you may have a patient who is class 2, who you, for example, would not consider for transplant, but have these values of results that are predicting a terrible outcome. Should we be more aggressive? Likewise, let's say somebody with an EF of 40% or 45%, but have results from CMR that predicts a high risk of sudden death. Should we be putting an ICD? So these are important questions, but we don't have randomized trials to tell us whether we really should do it or not. So what I'm asking is, do we have enough data from imaging to start pushing the development of multi-center randomized trials to help us answer these questions?
Yeah, I think one example of that might be, like you're saying, so the varying data in non-ischemic cardiomyopathy in terms of ICD utility, with now data by MR suggesting the people that have no scar tend to do better than those that have scar. And we're probably at the point in some of these things where we have some degree of equipoise to start thinking about prospectively asking these questions. So potentially think about taking some of these patients where we have to think a little bit past where we are in the guidelines and say, you know, given newer imaging data, are we still at the same point where just making a decision based on low EF is enough, or can we ask a question in a clinical trial, you know, about scar or other things, and really look at outcomes in terms of randomizing people to get devices versus not devices, at least in areas where there's some degree of equipoise.
Yeah. Any comments from any of the rest of the members of the team here before I go to a few questions that we're getting from the audience? My wife, you have any comments about this?
No, I mean, I had some difficulty hearing the question. Can you repeat it, please?
No, that's okay. We'll move on. So,
okay.
Yeah. So we have a few questions coming in. Let's see. How do you know to refer a patient to cardiac MRI? What are sort of the clinical suspicions or the echo suspicions for some infiltrative disease? Please comment. Mohammed, you want to take that one? You know, what are sort of the 3 or 4 or 5 findings that you look in an echo that say, I should consider recommending a CMR?
Yeah, thanks, Dr. Quinones. I guess the big parts basically is in structural LV and LA changes. So basically patients coming in with dyspnea and they don't really have any clinical significant history of high blood pressure. And I realize that they have an concentric increase in their wall thickness, their LV mass is increased, they basically have a markedly dilated left atrium. So kind of classic signs of basically diastolic dysfunction and someone with or without significant risk factors for heart disease. I think that would be kind of a first line etiology. The absence of large voltage QRSs, the people who have basically severe increase in LV wall thickness, is another kind of a poor man's way of looking at infiltrative cardiomyopathy, where you have low voltage and basically increased LV wall thickness. But it really starts from the clinical history exam along with the EKG, supported by the echo findings, that really would trigger me to go and look for basically cardiac pathologies, especially hypertrophic cardiomyopathy, infiltrative cardiomyopathy, and or if there are pericardial diseases like constriction, that probably be a good screening tool for.
Sharif, I'm going to add one part to that question. It's a certain percent of our quote-unquote HFpEF patients have a restrictive feeling pattern. Do you think that's a subgroup that we should also consider for CMR? If you see a restrictive pattern in somebody that otherwise is presenting as a so-called HFpEF?
If it's a restrictive pattern and there is, say, evidence of uncontrolled hypertension, voltage criteria that goes with someone who has LV hypertrophy, and everything else supporting that etiology, I don't necessarily think we need to do more in these. On the other hand, if it's a scenario of restrictive left ventricular filling in the absence of a clear reason that explains that left ventricular filling, then CMR would be reasonable.
So I guess the
I
answer
think it remains to be seen in the general group of patients with HFpEF, what is the unique role of CMR, when it should be done, and what it can add.
Right. So I guess the best answer to the person who asked the question is there are some echo features that are suggestive, but at the same time you have to bring some of the clinical findings to make the best decision as to continue with a further evaluation of the patient with CMR. Let's see.
I have a question for Dr. Noah about the doing the stress testing for diastolic function. So just really interesting work there. One question I've always had, and I haven't had a lot of experience with it, is that obviously when you stress somebody, they're going to have a high heart rate initially, and you'll get fusion of your ENA and your different waveforms. What do you do in terms of timing of this? Do you do it during a treadmill, or if you do it during a treadmill, how long do you wait after the treadmill before you do it, or do you do it with a bike while they're exercising? What's really the best practice for this?
So my preference and what we do is use the supine bike for several reasons. The supine bike has more time to image the patients per stage, so there will be 2D images acquired as well as Doppler. And one good reason to do stress testing in these cases is not just the diastolic piece, but also coronary, because many of them have risk factors. With the supine bike, you get more of an increment in blood pressure than the heart rate. So in general, it is less likely to deal with the issues of fusion with a supine bike protocol as opposed to a treadmill. Having said that, if fusion is observed, and if one goes first to getting the 2D images quickly, which one wants to do, to pick any regional dysfunction that is present and could be transient, few minutes would pass and then the heart rate would slow down some and there will be less fusion. It remains to be seen how accurate this is as opposed to capturing the exercise Doppler data at the peak of the exercise. But that's one approach that can help.
We have another question that it was for Dr. Tajik, but is Dr. Tajik still with us? Okay.
Sleeping.
Ah, there you are. All right. So Jamil, you talk about the impact of GLS or a bad GLS on prognosis in hypertrophic cardiomyopathy. The question is, when you showed higher mortality, what kind of mortality? Is it more of a heart failure worsening, or is it more of a arrhythmic mortality?
I think it's all maze effect. You have arrhythmia, you have heart failure, you have sudden death, all combined. That outcome is worse with the worse GLS. And pretty much that's a similar one that I think also noted with the MRI, but this particular study I shared, it was incremental to MRI late gadolinium enhancement data. So preliminary but important observation, nonetheless pointing out the role that GLS plays in our daily practices with these kind of patients.
Good.
I may also make a comment on exercise that Sharif, you just did elegantly. I agree, we do the supine bike. And with the beauty with a supine bike is it's graded, you're measuring every level, and you can see what effect takes place at a heart rate of 70, what is at 90, what is at 110, what happens to PA pressure, MR. I personally don't use that test for ruling out ischemia because it's, in my opinion, submaximal, as we do it on this. So from ischemia, I have to do something different in order to assure me that there's yay or nay. But for determination of hemodynamics, that is the best algorithm, supine bicycle exercise test.
Thank you so much. Very good. And thank you to all of you. Wonderful talks. These were really state-of-the-art lectures. And thank you to the audience for staying with us. We're right on time. So we're going to be moving soon. We have about a couple of minutes. You can take a break. And then we're going to start the last session of the day. Thank you, everybody.
Yeah.
The best is yet to come. Huh?
Welcome back, everyone. And it's a pleasure having you and hosting you here to probably one of the most fun times during these courses, which is case studies. It's a pleasure to host this and moderate it with my dear friend, Dr. Jamil Tajik, who I know was introduced but does not need an introduction. A leader, actually one of the founders of echocardiography, and a very dear friend to so many people in the field of imaging and echocardiography. And we have an amazing faculty. Many of them have been introduced. Actually, all of them have been introduced to you. So, and I know they will share amazing, case studies that could send a message, a learning, vignette here and there in multimodality imaging. So, to get us started, how about Dr. Faza, Nadine Faza? Nadine.
Thank you, Dr. Zoghbi. All right, good afternoon, everyone. I'm going to start with my case presentation. So we have a 55-year-old female with asthma and esophagitis who presents with progressive dyspnea on exertion, weight gain, and lower extremity edema. On exam, she was hemodynamically stable with physical exam findings consistent with fluid overload. Her labs were notable for AKI, elevated BNP, and eosinophilia. She underwent an echocardiogram, and the first view shows us a peristernal lung axis view demonstrating the presence of a pleural effusion. The LV function and RV function appear relatively preserved. The second view is that of a short axis showing flattening of the septum, suggestive of elevated RV systolic pressures. Interestingly, by apical views, the first is a 3-chamber view, and you're able to see this filling defect in the apex, and it has a concave border. And you can appreciate the same by looking at the 4-chamber view, demonstrating this apical echo density that has a concave border suggestive of a thrombus. The patient was given IV contrast. And again, you see this filling defect in the apex, LV apex. Looking at the diastolic dysfunction of the patient, she had an E-dominant pattern on the mitral inflow. She had reduced lateral and septal times, all consistent with a stage 2 diastolic dysfunction, in addition to her PA pressure of 50. She had elevated RA pressure, and you can see that there's systolic reversal in the hepatic vein. So putting everything together, she had stage 2 diastolic dysfunction. She had relatively preserved LV and RV function, with evidence of an LV apical thrombus. Given the hypereosinophilia, the most likely diagnosis is Loeffler's endocarditis. And to confirm that, she underwent cardiac MRI imaging, which again showed the large layered LV thrombus measuring 2.5 centimeters with a surrounding layer of hyperenhancement around the thrombus. The patient was treated with guideline-directed medical therapy with Coumadin for her LV thrombus and steroids for her hypereosinophilia, and she had significant improvement in her symptoms. The cause of hypereosinophilia in her case was not identified. She had negative infectious, autoimmune, and oncological workup, including a bone marrow biopsy. She was lost to follow-up and presented 3 years later, and this is her transthoracic echocardiogram, showing that there's reduced systolic function of her LV by both the peristernal lung axis view and the apical views. We noticed that the thrombus is not as well visualized this time. She had evidence of at least moderate mitral regurgitation, and she also had tricuspid regurgitation. A few months, she also had evidence of restrictive cardiomyopathy looking at her diastolic parameters. She had significant LA dilation, an E to A ratio of 2.9, septal and lateral E to E prime ratios of more than 14, and pulmonary hypertension with a PA systolic pressure of 60. A few months after that, she had a follow-up MRI, which showed a resolution of the thrombi with diffuse LV and RV subendocardial scar, most prominent at the LV apex, consistent with the fibrotic stage of Loeffler's endocarditis. And you can appreciate the LGE here on the third image. She also had evidence of valvular involvement, similar to what was seen by Echocardiogram, she had severe TR with a regurgitant fraction of 50%, and she had moderate mitral regurgitation. So the stages of Loeffler's endocarditis, which can help us understand the different imaging findings at each stage, is that stage 1 is the acute necrotic phase, occurring in the first 1 to 2 months of the disease, and is characterized by eosinophilic infiltration with degranulation and release of toxic proteins. The second stage is the thrombotic stage, which results in endothelial damage and thrombus formation. And finally, stage 3, which is the final stage, is the fibrotic stage, occurring after 1 to 2 years, where the thrombi are replaced by fibrosis, the endocardium, valves, and chordae tendineae may be involved, and the stage may be associated with restrictive cardiomyopathy and valve regurgitation. And in patients with suspected cardiac involvement in hypereosinophilic syndrome, the first test of choice is echocardiography, which helps us appreciate any endomyocardial thickening, ventricular thrombi, and restrictive LV filling pattern. This is followed by MRI, which can show us global endocardial hypoperfusion, subendocardial LGE, or ventricular thrombi. If MRI is not available or contraindicated, and there's high clinical suspicion, then FDG PET can be very helpful for evaluation of thrombi, myocardial inflammation, and endocardial fibrosis. These imaging findings can be supportive of the diagnosis of Loeffler's endocarditis. And finally, if the imaging findings are inconclusive, then endomyocardial biopsy can be pursued. Just wanted to touch base on other diseases that can cause some action in the apex, other than Loeffler's endocarditis, and these include apical hypertrophic cardiomyopathy and the presence of an apical thrombus in the setting of an apical aneurysm or wall motion abnormalities. This is an example of apical HCM, which is characterized by wall thickness in the apex of more than 15 millimeters and a ratio of maximal apical to posterior wall thickness of 1.5 or more. When you administer IV contrast, you're able to appreciate the spade-shaped LV cavity, and this is also appreciated by looking at the angiogram. These patients usually have deep T waves in the precordial leads. An intersect phenomenon is the apical blood sequestrations in patients with apical HCM due to the formation of small aneurysms, where the blood can be trapped in mid-systole as the apex contracts. And this gives us this very nice Doppler signal showing a void in systole in patients with apical HCM right here. And again, during systole, and when the LV contracts, blood pools in the LV apex in the small aneurysm, and you have a void in your Doppler signal as you're pointing your pulse wave Doppler at the neck of this aneurysm neck. The last differential is that of the apical thrombus in the setting of ischemic cardiomyopathy, where patients can have LV infarcts, develop LAD wall motion abnormalities, apical aneurysms, and then develop the presence of thrombi. So these are the differential diagnosis for some of the findings in the LV apex. And thank you so much.
That was beautiful there, Nadine. I think I like the theme of apical issues, apical abnormalities, etc. I have a question. I think we'll open up for thoughts and questions here. And if there are some questions from the audience, please send them to, if you're using your internet, just like this morning, Poll, P-O-L-L-E-V, on the internet.com, type DeBakey, and then you can send your question. Or if you want to text it, we'll get it. Text DeBakey to 37607. The question to you is, when you showed me the echocardiogram from the apical window, that first case of Loeffler, along with the clinical presentation, right, as well as the eosinophilia. I know it's beautiful demonstration of many things, but do I really need an MR, right? An MRI. I know we have 2 MRI specialists here, 2.5. But the question is, do I need more, or can I go ahead and do the workup, the autoimmune workup, et cetera, and make sure that I'm not missing anything and treat?
I think the findings of the echo, along with the clinical presentation and the lab findings, were highly suggestive of Loeffler's endocarditis. MRI has additive values in demonstrating LGE, I think it does have a role in the diagnosis and follow-up of these patients. A lot of times, these patients can also have RV apical clots, and in some patients, it might be difficult to visualize the RV apex by echo, so this will also be able to evaluate the RV in a more accurate fashion.
Any other thoughts from our MR specialist or PET or whichever way? This is multimodality.
And I think it's when you have a case that it looks, quite obvious, where you can see that it's clearly thrombus, and the contrast really helped you out a lot on that case. In the context, it seems like it'd be reasonable to do the workup. In other cases where it's less obvious, sometimes it can be harder to differentiate what exactly the cause is, and that's when I think you really get a much bigger gain. But I think she brought up a very good point about being able to look at the RV better, because sometimes you'll see RV apical thrombi as well.
Jamil?
So, can I make a comment?
Yes.
Very nice case, Nadeem. Very, very beautiful images and so forth. I just want to make a couple of points. One, I think the differential diagnosis does not include apical hypertrophic cardiomyopathy. The two images are very different. In the sense of apical hypertrophic cardiomyopathy, there is an LV cavity extending almost to the apex, okay? In this condition, it's an obliterative apex. Apex is totally filled with the thrombus and should not lead to confusion with apical hypertrophic cardiomyopathy. You had a nice case of apical that was very nice to show, but I just want to emphasize that we have a very distinct picture of obliterative cardiomyopathy, of the apex is obliterated. Nothing else looks like it other than a thrombus filled there. In apical aneurysm with a filled thrombus like that, and maybe consider another differential here. Now, are we able to go back to look at your CW Doppler image, or is that a no-no?
Did you have a CW image with that? CW of the MR?
She showed the apical hypertroph with the CW Doppler.
Let me try to pull it up.
That's the one that you showed. There was a void in systole and tapping of the.
Yes, and the diastolic. I mean, Jamil, we described this back in 1983 or 84.
The diastolic emptying with a very characteristic finding. I think the audience needs to see that and be emphasize that particular feature.
Right there.
Yes, so you will see there on the CW Doppler after the void, there's a slight blip on the positive side, on the, towards the transducer is showing, which is the aortic valve closure indication of that. And then this flow below the baseline starts almost at that time during isovolumic relaxation and continues through even through mitral valve opening, and that's not shown very clearly here.
Yes.
But even then it continues. So it's the paradoxical diastolic jet exiting the apex, and it's very beautiful and very characteristic of this ventricular narrowing obstruction and apical aneurysm.
I mean, the interesting thing is that, again, I'm glad you point this out, Jamil, because the ventricle fills, so you'll have positive mitral inflow you're not seeing here, but at the same time in diastole, the apex empties, so you have like opposite flows, one coming from the base and one coming from the apex. That's beautiful.
I thought if there was an orchestra playing at that time when the two jets collide in the middle of the LV, it would produce a beautiful sound to that.
Yeah.
Mm-hmm.
And
now you can see there's a sunshine around here, and I'm getting it in my face.
Wonderful. And the interesting thing to me, and the CMR, the later portion, the 3 years later, right? I mean, obviously the ventricle looked different, has remodeled, but at the same time, you still have that increased thickening of the apical area. Not as impressive, but still there. It's amazing. So, All right. Well, thank you, Nadine, very much. Thank you, really.
Thank you.
Yes, Nadine, or no?
This is
I'm
it,
sorry?
I think.
Do you have another patient?
No, this is it.
This is
Okay,
it.
beautiful one. Yeah.
Thank you.
Guys, can you?
Okay, Michael. Are you trying to? You're trying to share? Here you go. We got it.
Hold on a second. Yeah. Can you guys see my screen?
Yes, there is some display in the middle, but we see your screen.
Okay.
There you go.
Zoom a spot.
That's good.
1 second.
So you should be good.
Let me know if you can't hear me.
You're good.
So this case, a 56-year-old male, past medical history of hypertension, who was admitted for bradycardia. He was asymptomatic. He had a heart rate of 37. Blood pressure was normal. He was on a low dose of Coreg, Norvasc, hydrochlorothiazide, and lisinopril, and he had normal electrolytes. Here was his EKG, and you can see that his EKG demonstrates a complete heart block.
Michael, your slides are not moving on our screen.
We're seeing only the title slide.
Okay, do you guys want to go to somebody else first? It looks like my Zoom is trying to crash on me.
Okay, sure.
Yep.
Roberto?
Yeah, Dr. Salerno, I think you have to come out. Oh, there we go.
Yes, we can.
Can you see that?
Yes, we can.
Okay. So this first case is an 85-year-old man that presents with shortness of breath on exertion and an episode of heart failure that was diagnosed with significant mitral regurgitation on transthoracic echo, and now is being sent to the echo lab for a mitral clip evaluation. And so this is of course, the transesophageal echo in the typical positions. And I want my colleagues to look at it because the first thing that I had sort of difficulty was trying to identify what was the mechanism for the mitral regurgitation. You would agree that mitral regurgitation is probably at least moderate, but it was sort of difficult to pinpoint. Maybe you guys are better to find exactly what was the reason for this mitral regurgitation.
How large was the annulus measurement?
Let's assume it's just probably mildly enlarged.
Mildly dilated, okay.
So here we are. So anybody has any idea? Because I wanted to present a couple of cases on, sometimes we find these cases in which you have moderate mitral regurgitation, and either on transthoracic or transesophageal echo, it is sort of difficult to pinpoint what the mechanism is. So
ventricular function, Roberto?
Ventricular function was preserved.
Also regionally?
Say that again?
Regionally also, not globally, regionally.
There was no ischemic. So this is just an example of where to do a 3D echo becomes extremely sort of valuable. So we do a 3D echo and we see that this patient has a cleft in the anterior mitral valve. That was sort of difficult to make a diagnosis. And you can say, well, maybe as many times we see this is an artifact. So we put color and you can see that there is color coming through that cleft. So this case sort of prompted a little bit of a search, and I started to look. We have a sort of a big database, And I started to look at, this is a patient, of course, that these are all patients that don't have any congenital, no ostium primum or any other reason that comes with a cleft. And we, as you can see here, we discovered that patients with unexplained mitral regurgitation in a percentage of cases can have, as in panel B, a cleft in the anterior mitral valve. And unfrequently, you see a cleft in the posterior mitral valve. And I'd like to call that not a cleft, but an indentation, because the cleft does not appear to reach the annulus. And these are some examples of 7, 8 patients that I found exactly with the same type of situation, in which you see a cleft in the anterior mitral valve in a patient with otherwise not possible to explain mitral regurgitation. And sometimes in these same cases, you see these cases that I would like to call, profound indentations of the posterior valve that do not sort of reach the annulus, but also have a mitral regurgitation. In some of these cases, then I went back and tried to see whether, the typical findings of a 2D echo. Sometimes, unfortunately, we were not extremely consistent at acquiring these type of images. So in some of the cases, you would have been able, Dr. Tajik would have been able to make this diagnosis without 3D echo, right? So then when we looked at these cases, in these type of cases of mitral regurgitation with an unexplained reason, we saw that the majority of these clefts were located between A1 and A2. So this is the case, and I don't know if you ever encountered cases like that. If not, I would prompt you to think about unexplained mitral regurgitation, that you cannot find a reason. Do a good 3D echo, and you might find the cleft.
Very nice, Roberto. Jamil, what do you think?
Well, that's very intriguing presentation, Roberto. I'm very impressed with the 3D image. I don't know what the 2D looked like in the short axis of that particular case. However, it's kind of tough to understand why someone age 85 who's had the cleft all his, you think this has been there all along since birth, or congenital cleft, or is it acquired cleft? I don't know whether the acquired clefts take place. So for an 85-year-old to suddenly present with the MR accounting for symptoms and, and so forth, with the cleft that has been in existence for a long time is somewhat difficult to all put together clinically as a case. I have to find the reason for why this cleft is now leaking this much.
Yeah.
And that, I don't know whether you have some further insights or not.
No, I don't. That's why I was excited to show it to you to see if you, but for sure, we have found more cases that when you have mitral regurgitation and you don't, I know this patient, maybe the age did not, but there are cases that you have mitral regurgitation and you cannot understand why, and then you do a good 3D echo and you find a cleft in the absence of congenital heart disease.
I think that scenario is familiar to me. The younger patients, in their 30s, 40s, that end up like that. I've not seen this age group with a cleft like that. I agree with your nomenclature on the posterior leaflet of saying it's more of a deep scallop rather than a cleft, because first time, a long time ago, of course, when we observed this on 2D echo, I talked to our pathologist, Bill Edwards, who was my go-to person, and I said, tell me about cleft on the posterior leaflet. He said, anatomically, that anatomically does not exist. And that was his blanket comment. I know, and echo literature, a lot of papers have now been published on clefts of the posterior leaflet. So obviously we do see them in real life. They are, whether we should call them cleft or whether we call them deep scallops of the leaflets because of so many scallops of the posterior leaflet, is still under debate. But the anterior cleft is more intriguing. You know, isolated clefts do occur. However, in your case, the age and presentation then is still a little bit unexplained to me. Good one though, it always things to learn and always things to go and search for.
Okay, I will go to the next case. I just wanted to show a little bit some of the extremes of degenerative mitral valve disease. We all understand it is a disease of excess tissue, and some people like to call it, in one extreme, to call it fibroelastic deficiency, going all the way to a Barlow's prolapse. And I think this is probably the disease in which 3D echo has made its major contribution to truly understand the problems with the different types of scallops and where they are located. So just briefly, fibroelastic deficiency is usually a disease in which you have either elongation of the cord or a rupture of the cord. And fibroelastic deficiency usually occupies one single scallop of one single leaflet. And this would be the typical way in which you look at the mitral valve from the left atrium or from the left ventricle, and you see a P2 prolapse. And now with the new type of techniques, is an example of a flail P2 in which you can see that there are at least a rupture of 3 cords, and you could make the argument that there is a flail of P2 and also P3. But what I wanted to show you is 2 cases of the other extreme, which is Barlow's prolapse. And I had the opportunity when I was young to actually spend some time with Barlow in South Africa. And he actually, it was amazing because he could sort of draw these valves without having an echo. And of course, when echo came, he called echo the crap machine. He was very unhappy because it showed that he was not always correct in what his drawings showed. But this is an example of a 42-year-old woman who complains of decreased exercise capacity of recent duration. You can see here the mitral annulus is dilated. You can see these myxomatous changes involving the anterior and posterior mitral valve leaflet. You see this sort of parachute mitral valve. And interestingly, I'd like to pay attention that in these cases, you usually do not see a significant amount of mitral regurgitation. And in this is the operation of that particular patient. And sometimes it is very humbling to see these giant scallops of the mitral valve, and you have to think about the poor surgeon who's trying to repair this mitral valve. It is definitely something that only people that have a lot of experience can do, because imagine this is like cutting paper dolls and trying to reconstruct this particular valve. And again, in Barlow's, this is an exset leaflet tissue. I would like to propose that the most important mechanism here is billowing. The leaflets are thickened, as well as the chordae, and there is a large annulus. And let me briefly show you. This is a similar patient, also a female, who's 60 years old, and a TEE was performed. And you can see that it looks very similar to what we saw, dilated annulus. Both leaflets are occupied. The amount of mitral regurgitation is not significant. Just to show you in this reconstruction in 3D that you see the Barlow is occupying both the anterior and posterior leaflet. And you can see that the line of closure of the valve is only minimally interrupted. These are, again, the scallops. On this is a patient that we did not long ago. You can see again these gigantic scallops, the thickened leaflets, and you can see the sort of the difficulty and the experience required by a surgeon to do a repair. Usually, or at times, these patients end up having a mitral replacement. And just to make the idea here that this patient's mechanism here is a mechanism of billowing. And billowing is that in which there is a systolic protrusion of the leaflet body above the mitral annulus. The tip of the leaflet is on the ventricular side, differently to what happens with prolapse. This, of course, is a flail mitral valve. And this is the reason why the line of closure of the valve is only minimally interrupted, and these patients do not have usually a significant amount of mitral regurgitation.
Roberto, are you presenting some more, or is that it?
Yeah, I have. I have another very brief case of something that is very different. I missed this diagnosis. Let me show you this last case. 38-year-old.
A little comment on what.
Yeah. Of course.
I think, as usual, some beautiful 3D images of these Barlow's valves that you just showed. And I'm very happy to hear that you spent time with him and you're using his terminology of billowing rather than prolapse. I'm told that he hated the term prolapse and did not like when that was proposed by Michael Criley from this country. Anyway, prolapse is the one that caught on. But billowing is a very important concept to understand and properly interpret these valve performance. So beautiful examples of all of this, very nice.
Okay, very briefly, 38-year-old male with no prior medical history presents with two TIAs, episodes also of right arm and leg weakness 48 hours prior to admission. Brain tomography and magnetic resonance imagings were negative, and carotid Doppler showed no abnormalities. You see, now I passed the multimodality testing situation. So then there is a EKG depicted normal sinus rhythm without any arrhythmias, and we did a transthoracic echo and then a TEE, which I will show you. So this is the transthoracic echo. And as far as I can see, there is something here jumping in and out in the ventricle. You can see it here also in this apical for chamber view. Not more than that. And then this is the TEE. Again, we see the structure. We can see the structure, sort of linear structure. You can see it also from the short axis looking in, but this is it. Any ideas of the diagnosis?
Tough one, huh?
So a patient presents with
TIAs, yeah. Well, one would start thinking about an accessory chordal apparatus, very mobile. I thought there was a little structure, substance to it, and that's what was concerning me. So I thought that TE will show me a little better mass effect, and we may start considering that as a another step towards diagnosis. But otherwise, I don't have any clear other feeling. One papillary muscle seen there, but I don't see the other one very clearly. And those are just soft points. It doesn't.
So let me, yeah, I didn't have a clue.
Roberto,
at least you had an idea.
Is this going also into the LV outflow tract from the right upper image?
Say that again, Bill?
In systole, it looks like it's going into the LV outflow tract.
Yeah.
Right? I mean, just below the aortic valve and the right upper image.
So now let me show you. You're gonna scratch your head as much as I did. So again, these are the diagnosis. It's definitely now the Lambel's excrescence, cardiac myxoma. I don't know. I mean, these are the things that I sort of thought that could be. He did not have any. And this is the surgery. This is the aortic valve. And they found this structure. And then they actually, you'll see a little bit that, anyway, to make they will now take it out of it. To make the story short, this was a fibrillostoma.
Yes.
The histology was of a fibrillostoma, which presented was very, very strange because we all have seen fibrillostomas. They usually are on the aortic side of the aortic valve. And this one, seems to be on the edge, and then they actually went on. If we have patients, they could actually peel it off, and the histology was that of a fibrillostoma. You can see that. Thank God they caught it again.
Fantastic, huh?
Roberto, we've seen a couple of cases of ventricular papillary fibrillostomas. One of them looks sort of like a mass or something next to the papillary muscle, and by MR it lit up really bright. And then about a month later, we had another case, which also turned out to be a ventricular papillary fibrillostoma. So I think sometimes we're so used to saying, oh, they should really be on the aortic valve or other things, that you see something that's not really all that clear, and it's probably worth making sure that it stays in the differential.
Yeah, it is. What you're saying is great, because it didn't, for me, I already said it can't be because it was on the wrong side and the structure and so on. And so as Dr. Tajik says, there's always time to learn.
I mean, these have been described. The problem I have with them is the other ones are much more discrete, and you can see them at least on the aortic valve. This one, you just wonder about something else, and you hate to send somebody to surgery, right? And end up with a redundant chordae that is a bit thick. The question to our other imagers is, I know this is hypermobile, so it can create issues for CT and MR. And the question, is there something else to use imaging-wise to help us define that?
Yeah, I can, from MRI, I think these are going to be hard to really be able to characterize very well because they're moving around so much. And we don't have that kind of temporal resolution like you do on echo. And I would think CT probably has a similar challenge as well. I don't know about with PET. PET, I would think, also would have the same issue with temporal resolution.
I mean, PET, unless they have also uptake, you're not going to see them. I think with CT, some of the newer systems, I mean, it's a hit and miss. You can sometimes see them, especially because of negative effect by contrast. But again, if you don't see it, that doesn't rule it out.
So the story why this patient went to surgery also is this patient was a pilot of United.
Yes.
I'm not telling you what flight he does because you want to avoid that route. But that was the reason, because of course he was not allowed to fly unless this was resolved.
Roberto, I wanted to stress another of the Barlow billowing valve. Sure. Is that there are two issues there that I know we'll talk about tomorrow. One is the issue of late systolic MR, like late systolic mitral regurgitation, that by color we may overestimate severity, and we want to make sure that the timing is correct, right? All the measures of color will overestimate severity of regurgitation because they look impressive to the eye, even quantitation, because it happens only during a duration of MR. The other one is the other concept. Actually, we have the expert on that, Dr. Shah, Deepan Shah, who, you know, if the volume of this billowing is very large, it adds to the perceptive volume overload of the ventricle because it's going back. It's not true regurgitation, but it's a volume thing. So we'll talk about that tomorrow.
It's a volume thing. So.
Yes. All right, Michael.
All right, we'll try again to see if I bowed adequately to the Zoom gods to let me share my screen.
Still, I think we're still not seeing it. I think we will play your videos from here, okay? So let's ask Dr. Al-Mallah probably to go next. Mouaz?
Sure. Just...
You
Michael, you probably have to stop sharing before me.
Yeah.
You see my screen?
Yes.
Yeah.
So I'm going to present one case first. They're probably more from a diagnostic dilemma for an etiology of cardiomyopathy. And this case took a little bit longer than usual because it was all during the pandemic and there were some hesitancy for taking care. So this is a 59-year-old lady who presented because of dyspnea and exertion and cough. And she was having also some orthopnea. Her physical exam was showing reduced air entry in the right lower lobe. And this was during one of our uptakes in COVID, and she did test positive during that admission. However, what was interesting is that she had a troponin of 0.17 and the BMP was very high. And the concern whether this is all COVID or there's something more. So once she was stabilized, she underwent echocardiography, and this is her echo. You can see the parasternal lung. I'm not going to show too many echo images because I would like to keep time for other imaging modalities too. So you can see the parasternal lung, her ejection fraction is a little depressed, and this is done during, like, right after her admission. This is her mitral inflow, the peak, the E&A velocity, the peak is 70 centimeter per second, and depressed A. And this is a tissue Doppler, and you can see it's 2 centimeter on the septal annulus and 2.5 in the lateral. So very concerning for something else going on. So after, and this is her GLS. So that kind of made us very concerned whether we are dealing with an infiltrative cardiomyopathy. Since this was like close to her COVID admission, she was supported for her care for COVID and then brought in back later on for cardiac MRI. And these are her cardiac MRI images like few weeks later, and now you can see her LV function was 57%, no significant valvular disease. And this is another view, 3-chamber, and again 57%, no significant regurg or stenosis. But what was interesting is that she did have this poor nulling of her myocardium, and this is like more at the base, but you can see this entire subendocardial late gadolinium enhancement and poor nulling, confirming our concern for a restrictive cardiomyopathy in her case. And this is another late gadolinium enhancement. These are the single shot images, and this is a long axis segmented image, and you can see the significant late gadolinium enhancement that we appreciate in this case. And this is a short axis from apex to base. You can see the significant late gadolinium enhancement. We even have a fiddle sequence, which is dark blood late gadolinium enhancement, which shows you all this late gadolinium enhancement in the subendocardium. So now we are dealing with a case that is very concerning for infiltrative cardiomyopathy, and 59-year-old, and she was recommended to have now subtyping for her late gadolinium for her cardiomyopathy. Interestingly, her initial kappa and lambda came back normal. So now the biggest concern whether this is an ATTR amyloidosis. She refused the biopsy, and obviously we did a PYP scan. I'll show you some of the PYP scans because the ratio, and this is one of the pitfalls I was talking about when I was in the lecture, which is the ratio again measured here. You can see that the ratio was 1.49, which is very close to the cutoff, but doing a SPECT CT image, we can see that there is no uptake in the myocardium. All the uptake is really in the blood pool. When we rescanned at 3 hours, same thing. There is no uptake in the myocardium. All the PYP is in the blood pool. So this is kind of very concerning for this lady because we still don't have a diagnosis in terms of the type of amyloidosis. We have a negative PYP, negative kappa lambda. We don't know if it's ATTR or AL yet. And yes, a negative PYP could still be ATTR in a very small percent of patients, less than 5%. So eventually she, because of COVID and others, she decided not to follow up. 3 months later, she comes in with a chest pain, and she had ST elevation, troponin went up, BMP is also significantly elevated. She was taken to the cath lab, and you can see that her PDA was abruptly cut there. Abruptly cut at this point, which was highly concerning for an embolic thrombus. And this brings up the concern in these impossible amyloid cases for development of an LV thrombi. So at that time, she was again advised for biopsy and repeat kappa lambda. She was treated with anticoagulation and now the repeat was only increase in lambda, but no increase even in the kappa. And finally, she agreed for an endocardial biopsy, and the biopsy, which was, I won't go through the entire details, but came back very positive for lambda-restricted plasma cells, which was positive in the bone marrow, and the final diagnosis is AL amyloidosis. So that explains everything except that the first kappa lambda was kind of deceiving, and it's very important in those cases to go for biopsy, except that the patient had some significant delay in her diagnosis because she declined biopsy early on in her course. And putting it together, sometimes these cases may be easy to make diagnosis, but however, not every case is going to follow the textbook, and it's extremely important to have to rule out the AL amyloidosis before even doing the PYP scan by looking at serum protein immunofixation by kappa and lambda to make sure that this is not an AL, because this is an emergency that requires significant workup. So I'm probably going to stop here and take any comments from the panel.
Really fortunate that you had the MR.
Yeah, I was going to say this actually was, it's interesting because this is actually my patient that I took care of, and this was, she initially presented during like April during the lockdown. So, part of this was just our entire treatment course got delayed because of that. But I think this also kind of highlights the fact that I think this is a great example. If she had not got the MRI, we may have been falsely reassured that the kappa lambda looks fine and then the PYP scan looks fine. And so I think this kind of speaks to the fact that, I think this is one scenario where if you have LV dysfunction or you have HFpEF and you have a thick heart, I think MRI is very, very important, and to not bypass that. Because I've seen some algorithms proposed where they say you just go straight to kappa lambda and a PYP and use that for your algorithm. But I think this really kind of highlights the utility of the MRI.
I mean, that's an important point too, but also on the echo, I mean, the decreased tissue Doppler of the mitral annulus. I mean, I know the Mayo Group and Dr. Tajik published on this many years ago, and this is like very low in amyloidosis. So the strain pattern was very concerning. I mean, it was all adding up for amyloidosis. It's just like we could not pinpoint the type, and the initial kappa lambda kind of confused the entire picture, and sometimes you may need to repeat it multiple times. I mean, most of the time, if you have a reliable kappa lambda level that you have already tested, then you can potentially just go to PYP and biopsy and start the treatment.
Did you do the bone marrow afterwards?
Yes, I did the bone marrow, and she had positive.
So the choice would have been either bone marrow or endomyocardial biopsy, you know.
It was an interesting, I mean, her daughter is even a physician, and everybody tried to convince the patient to go, including her daughter. But because of all the lockdowns, if you remember, I mean, procedures were canceled every now and then, and she was not very keen on having the presentation, on having the biopsies.
I mean, it's important to keep in mind that...
Excellent case. I'm sorry, I interfered with somebody.
No, I mean, Jamila, it's important to keep in mind that some of these diagnostic tests are not 100% diagnostic. And I think the kappa lambda to me is interesting. And you said 5%, one of the questions from the audience, why was it negative? It's interesting. I mean, I don't know what are the circumstances that make it negative. Maybe not enough in the blood or something like this. But
maybe early on in the disease, that was the explanation that hematology came back up, that early on in the disease, even though cardiac was heavily involved in her, but early on in the course of the disease, they say that it might not be that high in the blood.
But even from the echocardiogram, Mouaz, I mean, one is you have a quote-unquote hypertrophic state or increased LV mass, because this is not hypertrophy here, right? Depressed ventricular function with an, cherry on the top and apical sparing of function, right? It all, I mean, I'm glad you pursued the diagnosis, because, certainly when you couple it with the MRI, you have an etiologic direction when you start seeing increased LV mass, significant diastolic dysfunction, heart failure, and apical sparing.
Yeah, and also
I think it's 2 points I would make on this case, which are very interesting. I think one is, obviously, yes, you got to go with your index of suspicion. And then the other thing I think also is always think about common things being common. Because, this case, I mean, it was right around COVID. And so there was some thought, well, maybe is this a manifestation, the MRI findings even, of what happened with COVID heart disease, And again, in the end, it just goes back to stick to the basics, and I think this is a great case. Yeah.
All right. For the sake of time, let's go ahead. Go ahead.
May I ask you a question?
Yes, please,
what's
Jamil.
The explanation that she started with such depressed EF and spontaneously improved to near normal EF?
So, I mean, it wasn't that depressed. I mean, this is taken during her admission with COVID. So I'm not sure. And this is what Deepan was referring to. There were some concern whether this was like COVID involvement. And this is during the very first wave of COVID. So there were some concerns whether there's cardiac involvement with COVID and others. So whether there was or not, I'm not sure. But when we did the MRI a few weeks later, I mean, she clearly had significant improvement in her LV function.
Yeah, I think it's very possible in this case that COVID could have actually unmasked an underlying kind of process that was probably going on, because when we took her history in more detail, she'd had shortness of breath symptoms going on for some time, for several months. And then, she did get put on guideline-directed medical therapy, so that may also have led to some improvement in the rejection fraction as well.
Got it. All right, Jamil, shall we move on to Dr. Salerno? We're going to use your pre-taped cases, Michael.
Good.
Hi, thank you very much. I want to present a few interesting cases of multimodality imaging with CMR and PET. Here are my disclosures. So the first case I want to talk about is a 56-year-old male, past medical history of hypertension, who was admitted for bradycardia. The patient was asymptomatic, but noticed that his heart rate was slow. His heart rate was 37. He was hemodynamically stable with a blood pressure of 132/76. His baseline medications included Coreg, Norvasc, hydrochlorothiazide, and lisinopril, and his lab showed normal electrolytes. Here was his 12-lead EKG. We can very clearly see AV dissociation here, and this patient is in complete heart block. An echocardiogram was obtained, and the echocardiogram demonstrated normal left ventricular function with possibly some mild left atrial enlargement, and you can see the obvious bradycardia resulting from his complete heart block. The patient underwent a cardiac MRI, which demonstrated normal left ventricular function, normal right ventricular function, and no significant valvular disease other than some mild TR. And the late gadolinium enhancement images showed patchy mid-wall late enhancement in the anteroseptum, as well as in the inferolateral wall. And here are his anatomic images of his chest. The patient had a pacemaker placed, and he was planned for an endotracheal biopsy. So what's the diagnosis in this case? The pattern of late gadolinium enhancement could suggest non-ischemic myopathies. Could this be something like myocarditis? And another consideration would be cardiac sarcoidosis. So he underwent an endobronchial lymph node biopsy of one of these enlarged lymph nodes, and that showed non-caseating granulomas, and the patient was started on prednisone as well as Bactrim. So this case points out an important point, which is delineated in the Heart Rhythm Society guidelines, and that is patients that have unexplained Mobitz type 2 or third degree AV block under the age of 60 should undergo high resolution chest CT or advanced cardiac imaging, including CMR or FDG PET imaging. If there's a suggestion of FDG PET, then there's a high probability potentially of cardiac sarcoid, and the patient should undergo a biopsy. And so a biopsy is useful in this population in order to evaluate for sarcoidosis. So here's a second case. This is a 43-year-old female with biopsy-proven pulmonary sarcoid. The patient had a CMR to evaluate for cardiac sarcoid. Medicines included albuterol, aspirin, prednisone, and Bactrim. So here are the CMR images. Again, relatively preserved left ventricular systolic function and right ventricular function. When we look at the late gadolinium enhancement images, there's clear epicardial delayed enhancement along the anterior wall as well as the inferior wall. Again, seen here, anterior wall as well as in the inferior wall, and some patchy enhancement in the septum. This patient underwent a PET study, and to basically describe what we're seeing in this study, the top row is FTG, the second row is myocardial perfusion, in this case with ammonia. And what we see here is patchy FDG uptake in the inferolateral wall as well as in the anteroseptum. and as we move towards the base in the inferolateral wall and the anteroseptum. Again, these areas correlate pretty well with the areas that are seen on the MRI, showing that there's a component of active sarcoidosis. The perfusion images show evidence of scar in the basal wall and a little bit in the basal septum. However, it's less obvious than it is on the MR studies. So in terms of pattern, a normal pattern would be to have uptake on the perfusion imaging and no FDG. A non-specific pattern, which can happen when people don't follow a strict diet, would be a diffuse pattern of FDG uptake. And then in cases of focal myocardial inflammation, what we would see would either be normal perfusion with an area of FDG or an area of reduced perfusion with an area of FDG. Or in this case, there's absence of perfusion in an area of scar, but that area of scar also has cells that are macrophages that are taking up FDG. And finally, in the case of chronic fibrosis, we'll just see an area of reduced counts on the perfusion imaging, but we won't see anything on the FDG imaging. So here was a follow-up study for this patient. And on the follow-up study, we can see that there's still some patchy FDG, but it's significantly improved since the prior study. There's still some inferior scar as expected. And then finally, this patient went a study about a year later. And now, sorry about the different color scheme here, but these are the FDG images on the top row, the perfusion images on the next row. And what we can see here is that we see a pattern where the cavity is brighter than the myocardium, and we don't see any uptake in the myocardium. So this is actually complete resolution in this person's case of the inflammatory component being treated on steroid therapy. And this has been looked at mostly in small studies, but demonstrating that we can use PET to monitor the progression of inflammation. And just to finish talking about the joint position paper, in the case of suspected cardiac sarcoid based on symptoms, abnormal EKG or abnormal echo, CMR is preferred because it's the way that we can look at scar. If it's normal, the patient should have clinical follow-up unless there's a high suspicion, in which case they should go on to FDG PET. If CMR is not available, then they should also go on to FDG PET. In terms of the FDG PET, if the PET's positive, that may tell us that we need to increase our immunosuppressive therapy and consider an ICD, although SCAR is more predictive of ICD firing than the component of FDG, although the combination of FDG uptake as well as late gadolinium enhancement has been shown to have a worse prognosis. Whereas if the patient has FDG negative, it means that there's no evidence of active inflammation. But if they have scar by the perfusion imaging by a lack of flow or late gadolinium enhancement, then we should consider ICD therapy. And so just to summarize, cardiac sarcoid is a multi-system inflammatory disorder of unknown etiology. The prevalence is 10 to 40 over 100,000 patients. They have non-caseating granulomas, and patients that have cardiac disease have worse prognosis, including heart failure, arrhythmias, and sudden cardiac death. It's a challenging diagnosis in terms of biopsy, and the treatment is really with steroids or immunosuppressive therapy. So I hope you enjoyed these 2 cases of cardiac sarcoid. Thank you very much for your time.
Thank you, Michael. Great cases, really, of sarcoid. Any questions for Dr. Salerno? Jamil, you're good?
I find this a very challenging management cases, cardiac sarcoid. Tedious follow-ups we do with them, recurrences then take place, and really quite challenging. Yes, that's what has intrigued me about cardiac sarcoid quite a bit. Diagnosis is now with multimodality imaging is fairly nicely established. I have not resorted to doing any endomyocardial biopsies for confirmation.
How often do we expect, for the panel and you guys, how often do we expect complete resolution of FDG uptake with therapy? Or is there still some smoldering inflammation activity? I don't have much experience with it, so just...
So in my lecture today, I showed few cases where we have like complete resolution. Usually it takes about 3 to 6 months and depends on how much inflammation is there upon the start. There are some cases where it decreases. There are some cases where we see decrease in inflammation in the cardiac, but increase outside the heart, like in the lungs or in the mediastinum. So it's a very kind of unpredictable disease, and it may improve in one area and flare up in another area. And that's why we see many of these patients. I mean, we've done so far 500 scans on 300 plus patients, and I cannot tell you that one patient is similar to the other. That we have some, usually what I notice on your second case, Michael, I mean, the papillary muscle is kind of very specific. When you see it, it's rarely an artifact. You know that the patient followed the diet. And also it is kind of the last to resolve, and it tells you that the disease is pretty extensive. Whether it has impact long-term on mitral regurg or no, that probably worth a study.
So maybe a couple of comments or questions, I guess, for both of you guys. I mean, from a management standpoint, right, these patients, I think as Dr. Shajik pointed out, are pretty challenging to manage. And I think we tend to go with steroids as a first line. But I understand now there's some of the heart failure folks are using some more novel therapies in these patients as well, right? Sometimes steroids alone won't really do the trick.
Yeah, I mean, what I've noticed from my heart failure colleagues, I mean, I'm mostly on their imaging side, so I see the effect of what they have done. If the inflammation is very minor in terms of area or in terms of SUV, usually steroids probably can do it. However, if the inflammation is extensive and it involves multiple areas, then probably they need, in addition to steroids, some additional therapies. And I've seen them use methotrexate, Cellcept, and in some cases, I mean, some like cyclophosphamide and other diseases. So there are many like heavy guns in their artery, and they use them depending on how bad the cardiomyopathy is. I just want to also point out that FTG uptake alone does not mean this is sarcoid. I mean, we've seen it in multiple cases with IgG4 cardiomyopathy. We have like a couple of cases where they did not improve. In fact, we lost a patient recently for that. We've seen it in patients with lupus. We've seen it in patients with the most recent case like Wagner granulomatosis. We have even a case where we did not see cardiac involvement, but the whole pericardium lit up. So it was like very impressive, and there was a correlating cardiac MRI where the entire pericardium was actually having late gadolinium enhancement. So, I mean, it's a very heterogeneous disease, and I think the key point here is that most often you will require both. I find that once you make the initial diagnosis by MRI, your follow-up has to be by PET. So that's why, I mean, and it's extremely helpful. I always tell my trainees, we have to look at the images, put them side by side and look at them, because sometimes you have the same area has late gadolinium enhancement but does not have FTG, or vice versa. So it could be that you have early FTG uptake, but there is no late gadolinium enhancement. Or like, for example, the case that Mike showed, I mean, there was way more FTG uptake compared to the late gadolinium enhancement that was on the MRI, which tells you that there's a lot to potentially salvage in this patient by treating him aggressively.
Okay. I think.
I think I would just quickly add one comment, and that is you need multi-specialty approach to cardiac amyloid, and rheumatologist involvement, at least I feel, is very important. If we go beyond steroids, then we do involve them with us in the management of such patients. And a number of centers now, sarcoid, subspecialty clinics have started just to bring multi-specialty group together to put their heads together to treat one single patient.
Absolutely, and we have that here led by one of our heart failure doctors who's she's very active in this actually, and she has a multidisciplinary, I support them from the imaging standpoint, but the management is mostly on their end.
Perfecto.
Dr. Tajik, do you have some cases you want to share with us?
I do, but I was hoping to see what Shah has for us.
Oh, it's up to you. You could have a duel if you want, one-on-one or whichever way.
I haven't heard him present today at all.
Okay, Deepan.
Yes. You want me to go? Yeah.
Yeah, go ahead.
So I had one
Deepan,
case.
show us some nice stuff. Huh?
Okay, so I had one case which is a sarcoid case. I'm not going to show that, but I've got another case which is, let me share my screen here.
Don't show an amyloid now, come on.
Yeah, no. This is going to be something completely different.
That's
so
good.
This is actually can you guys see my screen? I'm going to take you right to the images. And the reason is, this is a patient who, we have these MRI courses, and oftentimes we'll put a volunteer on. So we got one of our staff to volunteer for a scan. So this is one of our staff that volunteered for a scan. And I'm going to just show the images to everybody here and tell me what you think. I just want the audience to take a look at these images. I'll let the panel take a look at these images. And then I'll kind of walk you through what the interesting findings are here. So, the only thing when she was being scanned, the techs and the attendees for the course were like, yeah, this person's having a lot of PVCs. So this is a great example of how you troubleshoot when you're having arrhythmias. But you can see, despite the PVCs, the image quality here is actually not that bad at all. So despite the fact that these images are taken over several different cardiac cycles, this was done using kind of an arrhythmia rejection technique. And with that, we're able to kind of negate out the PVC beads. So right off the bat, I think what you'll notice, LV function looks, quite normal. But look at the RV. And I think this goes to, Nadine's talk earlier today, that MRI is great for looking at the RV. And you can see we've got what looks like a pretty large right ventricle, right? Not just in relationship to the size of the LV, but actually if you measure the size of this RV is about a 200 cc ventricle. And this was a small patient that we had. But the other thing also is if you look at RV motion, right? And I think I'm going to click on one of these views here. This is kind of what I always tell the fellows is kind of the classic MRI finding you look for is kind of an accordion sign. Where you see it almost looks like there's like a little accordion shape to this RV free wall. And in addition to that, compared to the apex, which seems to be contracting, this lateral wall here looks like it's just being translated down. It's not actually contracting, it's not actually moving in. And also it looks like the RV free wall here looks thin. But there's another interesting finding on this person. If we scroll down to this view right here. So this is what I call an RV 3-chamber view. So this is the SVC, the right atrium, the right ventricle, the pulmonic valve, and then the pulmonary artery. And you see this area right here in the infundibulum. This person's got a big, huge aneurysm in the infundibulum. And then in addition to that, we also did our kind of standard delayed enhancement imaging. And you'll notice this person has, in fact, some areas of hyperenhancement here in the septum. And then you can see that, but you don't really see the RV wall very well when your delayed enhancement images. And then if you look at this is kind of a newer technique called a dark blood delayed enhancement technique. You can see there's little areas of fibrosis or hyperenhancement in the septum. I'm going to scroll through these here. And I think you can see it also on this view here, that there's actually some areas of high signal here in the RV free wall in that abnormal area. So, you put this all together, right off the bat, this looks like a case of RV dysplasia. So with this person, then obviously based on these, so I'll give you the numbers that we had. So the RV end diastolic volume for this patient, the index value was about 110. And this was a woman, and her RV ejection fraction, in this case, measured out to 38%. So again, if you look at kind of the CMR criteria for RV dysplasia, it's basically the presence of, either akinesis, dyskinesis, or dysynchronous contraction, or an aneurysm, as you have also in this case, associated with either RV dilatation with an end diastolic index of greater than 100 for women, or greater than 110 for men, or an RVEF of less than 40. So this person meets kind of all the CMR criteria, so there's a major criteria here for RV dysplasia. And then the workup for this patient that is based on this volunteer scan that she did, we told her, you need to see the EP docs. So we got her to see one of our EP partners who did right-sided EKG, where she has the T-wave inversion. She also had genetic testing done as well, which showed a variant, a high-risk variant for ARVC. And again, this person then, based on this, went on to get a prophylactic ICD placement done. But I think, again, this is a great example of sometimes just volunteering can be good for your health as well.
Or not.
I mean, I think people who I figured out over the years, we have detected interesting cases like this on court volunteers. And I have a suspicion that volunteers already think something is wrong, and they go ahead and are more apt to volunteer to get testing done like this.
Yeah, so there may be a selection bias for volunteers, you're saying.
Absolutely, because I remember several cases, including Epstein's anomaly and so forth, in individuals that have volunteered for echo. But volunteer for MRI, that's a pretty nice person for you, huh?
Yeah. I think those abnormalities are specific for MRI volunteering. So,
Deepan, you point out a really important thing about getting that RVOT view. A lot of times, just in this case, everything is pretty obvious from the axial images, but in some cases it can be subtle, and you could have much more subtle dyskinesia of the RVOT. So it's important to get that view when you're evaluating ARVC, or just even to do it standardly.
Yeah, no, exactly. And for RV dysplasia cases, what we always do is, in addition to kind of the standard short axis, long axis views, do really a kind of a long axis stack through the RV, so that you're interrogating all the RV free wall, and then obviously these kind of specialized views of the RV with the RV3 chamber, and then this RVOT view as well.
Of course, echo is more limited for the diagnosis of this entity, and we always stress that the need to do non-traditional views. But here, once again, 3D echo is we actually did a study with a group in Italy. 3D echo can be pretty good at finding, because you can get all of these views, right, by doing all of these cuts. So you do better than 2D echo to find these microaneurysms and these accordion-like lesions and so on. So beautiful case.
Roberto, since we're talking about 3D for the RV, RV, the best window is that in RV delineated apical view, or what things do you suggest?
The RP focus view, probably.
All right.
And then with the multiplanar, you can change it around.
And since we talked about infiltrative cardiomyopathy, there was a question here. Is there an algorithm to rule out infiltrative cardiomyopathies? Did any of your talks address that? I don't know if we can refer them back to that talk. Any of your talks were...
My talk actually spoke about, the role of, primarily I covered a little bit of the added value of MRI and PET together. So, and a little bit after after a highly suspicious echo or CMR. So on that talk, you can find that. And there is a nice multi-societal guideline led by Sharmila Durbala about amyloidosis. So specifically about amyloid, it's a multimodality, both appropriate use criteria and also a multimodality imaging document.
There is a comment and there is a question probably for Dr. Tajik and et al. The comment is the accordion sign that you mentioned was described by the Hopkins group to describe patients who have normal RV in diastole, but it crinkles in systole. This patient you are showing has obvious microaneurysm in diastole. I would not use the term accordion sign for this case for that reason.
Yeah, well, I was using it in the layman's term.
It's somebody very familiar with musical instruments, including accordion. Now, the other question, this is for mitral valve prolapse, Jamil, and your thoughts and the thoughts of the panel. Will there be a discussion of mitral annular disjunction sometimes during this course? I'm interested to hear what your experts think of this entity. Mitral annular disjunction. I know we're going to talk about mitral valve tomorrow, but not particularly MAD per se. And maybe your thoughts, and I'll give some thoughts. Go ahead.
I say no, MAD should be discussed. And yes, there is an entity in my mind very clearly that there is what is called mitral annulus disjunction accompanying the Barlow syndrome, okay? Now, mitral annulus disjunction without any mitral valve disease is the more controversial situation. And I think the jury is still out on that, whether that carries the same connotation. A paper has been published and others may be coming that indicate that just simple presence of MAD is arrhythmogenic irrespective of Barlow's valve. Personally, I don't totally subscribe to that. To me, is a part and parcel of Barlow's condition where it becomes, arrhythmogenic, and the larger the MAD, the larger the billowing excursion is, the more arrhythmogenic it is, using the mechanism of mechanical stimulation of arrhythmia from papillary muscles and postrobasal LV wall. So there's a lot more yet to be learned, but it's not to be ignored. It should not be minimized, the detection of MAD and reporting of MAD as part of total assessment of the myxomatous mitral valve disease.
I agree with you, Jamil.
If I could kind of posit one, one of the things that we've noticed, I think on MRI, when we look at a lot of these patients, is oftentimes you have to be careful. Well, I found that I have to be careful about what I see, what looks like annular disjunction versus sometimes that posterior leaflet, which especially in these big Barlows, where the posterior leaflet is almost hugging against the left atrial wall. And so oftentimes what I find is you have to kind of scroll through the images between systole and diastole to make sure we can really identify where the attachment point of that posterior leaflet is. Because I think sometimes it can seem like there's more disjunction than there actually is unless you follow that leaflet all the way down. So I think that's an interesting thing also.
Yes. I think that's very well said, Dr. Shah. You have made the correct observation there that these have to be images both on 2D echo as well, scroll through to find the posterior leaflet left atrial junction, okay?
Yes.
And I find exactly what you just noticed also, that people in a hurry will not do that and they'll just overestimate the size of MAD, the distance, as opposed to coming down to fine measurement like what you just noted. So it should be done like everything else, carefully and not just casually to make those measurements.
Well, on that note, I cannot thank you enough. Dr. Tajik, Jamil, it's great to see you. And thank you for joining us. And our faculty here, stellar presentations, great discussion, including MAD. I think it was not on the radar screen, but I'm glad one of our viewers looked at that. Tomorrow's schedule, I think, would be very interesting for many. The whole morning tomorrow is on valvular heart disease and structural heart disease, mitral, aortic, and tricuspid, with really experts in the field. And in the afternoon, a fun session, just Central Time, 1 to 3, going through reading with the experts, the ins and outs of each modality. So each modality, we're going to spend some time with the experts, and many of you are participating in this. So cannot thank you enough for being with us, and we'll see you tomorrow. Thanks again.
Thank you.
Thank you.
Thank you.
Bye-bye.
Good evening.